Once again, a warm welcome to each and every one of you. And those of you who are outside who can hear me from here, I request you to please settle down, take your seats. Just a few hygiene announcements before we begin. Please remember to put your mobile phones on silent. If you have two phones, please put both your phones on silent. I know a lot of people reach out and send images on WhatsApp. We want your full attention on the stage. So remember to put your mobile phones on silent, everyone included. And a warm welcome on behalf of the Indian Society of Vascular and Interventional Radiology. My name is Sano, and I'm the host for today. I'm truly honored to be here. And can we give ourselves a nice big round of applause? Those of you who are very, very proud to be part of this profession, give me a nice big round of applause. And those of you who are very excited to be part of ISBR, please give yourselves a nice big round of applause. Yes, I'm very excited to be here. Yeah. And if the person is looking very nice next to you, give them a high five. Just turn and give them a high five if someone's looking really good. No? All right. I see. I get it. So, welcome to the 26th edition. And this conference has a habit of going places. After a historic Kochi, we have returned to Namma Chennai. So, let's do some numbers. As you know, there are 1,200 members, 800 registrations for the conference, and we're seeing an increased participation of women professionals, particularly in this conference. A nice big applause for this. 150 women are part of the ISVIR 2026. Women, you should be clapping the loudest, by the way. You're not clapping at all. I want to hear from you both. Thank you. Right, highest number of abstract submissions, 420. So what's new this time, what's different this time is that we're making sure that lectures and workshops, they don't overlap, so you get the best of both. We have the first of its kind lunch symposium, where we will get to understand the issues faced by the industry, and of course, we're very eager to hear from you. And for the first time, we have a live workshop streaming from the US, and we also have a beautiful app, the ISVIR app. It's available on iOS, it's available on Google Play. So if you don't have the opportunity to get your questions answered, remember you can leave your questions there. The moderator will read it out over here, it will get documented, and the experts will answer them later. So make sure that you make the most of the app. And the ID cards, please keep them very, very safe, what you're wearing, for many reasons, including dinner. So make sure that you keep them safe with you. And a few reminders, remember to collect your dhotis or saris in case you haven't. They're near the massage counter. Remember to walk more than 12,000 steps, you get that spa voucher. Remember to meet all the people from the industry, from the stalls, they're waiting to hear from you. If you need any help, do connect with the industry captains. And the important thing is maintain time, because all of you are equally important, all your sessions are equally important, your time is absolutely important, so please maintain time. If you exceed time, we will hear from Ira. Can we see Ira on the screen, please?
Last 2 minutes.
She cannot be bribed, cannot be told, please wait. She will just cut you off. I mean, not you, I mean the screen. So maintain time, right? Please do that. It's a humble request. And also, for those of you who are not part of the main faculty group, a lot of you have not joined it, please do join so you get all the updates. And those of you who are staying in Sheraton, remember that there is a service exclusively to take you there and bring you back. So make the most of it, don't worry about it. We have a team waiting for you. And the dinner is right here nearby in the same hall. All of you can have dinner there. And I'm told specifically that around 11 o'clock, there is a Kire Kada dip soup that you should try. On that note, ladies and gentlemen, before we begin, I'm going to teach you a very important part of the South Indian culture. Just take your hand and bring it near your mouth, if you will. Take your hand and bring it near your mouth. Now whistle. Doctors, whistle. No? Not even one whistle? This is any big movie, any big blockbuster, this is how we begin. So I want, on the count of 1, 2, and 3, hear some whistles from you. 1, 2, 3. I do understand that you have to study a lot and very busy people. So those whistles are enough for me. Give a nice big round of applause as I invite Dr. Kiran on the stage to kickstart the proceedings of the day. Ladies and gentlemen, nice big round of applause. This is what we're going to be doing. Yes.
Good morning. Welcome, Vanakkam, and Namaste ISVR 2026. It is a fine day for learning and so much fun. On behalf of the ISVR organizing committee, I welcome you all today. And I hope that each of you find out what you came for, be it rest and relaxation or just academic ardor. So without much further ado, I would like to enrich the stage with our chairpersons for the morning, for the head and neck session. Dr. Matthew Cherian. Hi, sir. Needs no introduction. And sir is the boss of KMCHIR. Sir, can you come up on stage? And the next person, Dr. Rajesh Pusarla, who is a senior consultant IR at Care Hospital, Vizag. I think sir is yet to arrive. So, Dr. Tarun Sabrawal, consultant IR from the NHS. Dr. Arun Prasad, senior advisor and head, Department of Radiology and Intervention Radiology, Command Hospital, Pune. Dr. Rashmi Saraf, Assistant Professor and in charge, Division of Interventional Neuroradiology at KM Hospital, Mumbai. Dr. Nagarajan Sir, Professor of Intervention Radiology at JIPMER, Pondicherry. Oh, sorry. Nagarajan sir, Dr. Muralidharan V. Hi sir. Sir is a consultant neurosurgeon at Rela Hospital, Chennai. And for the first presentation on hardware and techniques of transarterial embolization, I call upon Dr. Nirmalya Ray from Manipal Hospitals, Kolkata.
So just to let the audience know, very few audience, there's a problem, everybody must be in the beach. The idea is that we hope that you can practice these techniques once you go back. So we just take in very selected topics. So feel free. I think your app allows you to ask questions, I think if I'm not wrong. So please make use of it and you can keep asking questions so that we'll address it. Yeah, Nirmala, you can start.
A very good morning to all of you. So I'm very glad to start the conference with the talk on a head and neck tumor hardware embolization technique and of the transarterial embolization. So as you all know, preoperative embolization refers to devascularization and significant
just one second, the monitor is not working here. Can you just get the screen working, or we cannot do anything, or we come down? It is not come on this.
Can I have a pointer?
Anybody from the audiovisual team, please? Can you have this working, please?
Pointer?
No, believe me, it's not working. He wants to verify it is not working. Sorry. Because no, we can come down. I think it'll save time. Shall we go down? Because it's by the time you fix it, so you save time.
Can I have a pointer, please? So as you all know, preoperative embolization refers to the devascularization or significant reduction in the blood supply of any tumor by means of induction of thrombosis of the arteries supplying the tumors. Providing optimal conditions for the surgery. So what are the goals of preoperative embolization? So goals include to control surgically inaccessible arterial feeders, decrease blood loss, shorten the intraoperative procedure time, increase the chances of complete surgical resection of the tumor, and to allow for better visualization of the surgical field with decreased overall surgical complication, and to relieve intractable pain when we are planning for any palliative procedures. So ideal time for preoperative embolization is generally 1 to 4 days prior to the surgery. Generally it's done at least 72 hours prior to the surgery. So these are the various head and neck tumors that we can offer preoperative embolization, like paragangliomas, juvenile nasopharyngeal angiofibromas, meningiomas, hemangiopencytomas, hemangioblastomas, various hypervascular scalp and other metastases, schwannomas, rhabdomas, sarcomas, esthesioneuroblastoma, and thyroid tumor embolization. Although not typically the part of the head and neck tumors, the spinal tumors can also be undergo embolization preoperatively. So first is the patient preparation, and most importantly we should see the cross-sectional imaging very well, plus do the basic investigations like chest X-ray, coagulation profile and renal parameters. And before the DSA procedure, we have to do an access site preparation, intravenous access and Foley's catheterization, because at times the procedure takes longish time. Some of the conditions need some special preparations like paragangliomas, where it can release catecholamines in less than 5% patients, and patients can have paroxysmal hypertension after the procedure. So plasma-free metanephrines and 24 hours urine fractionated metanephrine should be done before the procedure. Alpha blocker pre-medications may be required. Cardiac workup for LVH or dilated cardiomyopathy is also required in these patients. And for any large tumor, there may be abrupt increase in the mass effect or leading to further complications. So these patients should receive iso or hypoosmolar non-ionic contrast, and we should reduce the use of normal saline during the procedure. Pre and post procedure steroid helps in these situations. Coming to the material selection for various preoperative embolization, so I have divided into the guiding catheters, microcatheter, needles and embolic agents. Guiding catheters are usually a 90 centimeter guiding catheter, 5 French system. 6 French devices are guiding catheters are used if we are contemplating to use 2 devices. Angle tip devices are better than straight. For pediatric patients, we can use a diagnostic 4 French or 5 French diagnostic catheters as the guiding catheter as well. The microcatheter choice depends on the vessel size or the type of embolic material used. 2.4 French to 2.9 French microcatheters are used when we are planning to use gel foam PVA or 018 coils, while 2.4 French, 1.9 French or 1.3 French catheters are preferred when we are planning to use embospheres in NBCA glue or detachable coils. If we are planning to use onyx or squid, this EVOH based liquid embolic material, then a DMSO compatible catheter is required. Percutaneous, there are various needles. I will not go into details of percutaneous as my next speaker will be talking on that. So these are the various embolic agents that are available in our armamentarium, and I will be discussing the major embolic agents in brief. So coming to gelatin foam, that is a basic embolizing material with which all of us have started our IR career. So these are biological substances made from purified gelatin. They can aggregate or swell on the hydration into a larger particle, cause mechanical obstruction, slowing of blood flow and hastening of the thrombus formation in the vessel, leading to temporary vessel occlusion, but it can lead to recanalization in a few weeks. The other agent that is used very commonly is the polyvinyl alcohol or PVA. It is the PVA foam sheet vacuum dried or wrapped into particle. Particles are filtered with sieves from 100 millimeter to 1100 micron in diameter. Permanent occlusion can be achieved by adherence to the vessel wall, leading to stagnation of flow, inflammatory reaction, and focal angionecrosis with vessel fibrosis over time. Disadvantages of PVA include it has a tendency to aggregate, occluding the vessels more proximally. Particle clumping can cause catheter occlusion, which may be avoided by using absolute alcohol with it, or it can accumulate in the catheter hub and can cause subsequent non-target embolization when the catheter is flushed or a subsequent postoperative embolization done. Now coming to the embosphere or tris-acryl gelatin microsphere, these are impregnated and embedded with porcine gelatin, non-reabsorbable hydrophilic particles that are precisely calibrated in size, smooth and spherical in shape. They may penetrate into smaller vessel compared to PVA of similar size. The disadvantage include cost and anaphylaxis to the porcine gelatin. Coils are permanent embolic agents, has a variety of shapes and size, typically used for occlusion of larger vessel, physically slow or stop blood flow, providing a thrombogenic surface for clot formation. Coagulopathic states may hinder complete vessel occlusion when coils are used. Now coming to the NBCA glue or N-butyl cyanoacrylate glue, the anionic environment in the blood or water induces polymerization of the glue. Lipidol is used as a vehicle of the glue and acts as a polymerization retardant, and it helps in visualization of the glue. It makes a permanent cast of the vessel independent of the inherent coagulation, incites an acute inflammatory reaction in the vessel wall, progress to chronic inflammation and fibrosis. Remember to use dextrose whenever you are using glue instead of normal saline. And last but not the least is the onyx or squid, the EVOH liquid embolic material. These are copolymer of ethylene vinyl alcohol prepared with dimethyl sulfoxide, DMSO as the solvent. Radio opacity is provided by tantalum powder. These are non-adhesive, allows for longer or interrupted injection time. Disadvantages include catheter retainment, can flow into some complex angioarchitecture. Now, how to choose the embolic material? So, it depends on the lesion, how far you can reach up to the lesion, what are the types of vessel, location of the feeding artery, how you are going to, what are the normal structures that can get injured during the procedure, and what is the desired effect in relation to the planned surgery. So, whether you want to achieve a complete tumor necrosis or you just want to achieve a feeder occlusion. Remember, particles less than 150 micron or liquid embolics are able to penetrate into the vasa nervorum of the cranial nerves or nerve roots and dangerous anastomosis with a potential for complications. Coming to the diagnostic assessment before the procedure, cross-sectional assessment is very essential to see the location, spread of the tumor and involvement of the adjacent vital structures. Like here you can see this is a case of right jugular paraganglionoma. It is important to see the draining veins that is draining into the posterior fossa, as well as the relation with the various lower cranial nerves in this lesion. Now coming to the vascular location, it is very important to know the angioarchitecture of the lesion, tumor demand, that at what rate the tumor is opacifying, whether there is any arteriovenous shunts within the lesion, whether there is any dangerous anastomosis, and whether any potential arteries that is supplying the adjacent cranial nerves. So this is the same case. You can see this is the right jugular paraganglionoma having supplied from the various external carotid artery branches, ascending pharyngeal artery mainly. And whenever we do this type of, this is very important to see the status of the cranial nerves. Sometimes we need to do a provocative test by injecting 10 to 30 milligram of intra-arterial lidocaine. So whether after embolizing the patient can lead up to any cranial nerve deficit. So if it is positive, then we should select an alternate branch, reposition our catheter and use larger particles greater than 100 micron to prevent the cranial nerve injuries. So what injections you should take for planning a head neck tumor tumor? So you have to do a complete angiogram for the bilateral internal carotid artery, bilateral external carotid artery, bilateral vertebral artery and the cervical branches of the subclavian arteries, that is the thyrocervical and costocervical trunks. You have to take a run at a higher frame rate of at least 4 frame, if not 6 frame. Superselective microcatheterization distal vessel will help in telling us the distal vessel supply and the intratumoral shunting, as well as we have to see the various extra and intracranial anastomosis. So in the same case, this is the right ECA run that shows the vascularity from the ascending pharyngeal artery. But if you see from the right internal carotid artery also, there are some dural feeders which is contributing to this aneurysm, to this tumor. As well as from the vertebral artery injection on the right side, you can see there is supply from the meningeal branch of the vertebral artery as well as from the right posterior inferior cerebellar artery in this case. On the left ICA injection, there is no supply from the left ICA or left ECA. So just a bit on the dangerous anastomosis, there is a talk on this I think in the subsequent sessions. So what I would like to mention that 3 areas you should look. One is the region of the orbit where there is anastomosis between the ophthalmic artery branches and the internal maxillary or internal carotid artery branches. Another is the petrocavernous region where there is anastomosis between the inferolateral trunk, petrous ICA branches or meningohypophyseal trunk, or extracranial branches of ascending pharyngeal or IMA branches, and the upper cervical or the vertebral artery region where there is anastomosis between the vertebral artery and the ascending pharyngeal.
Achha, Nirmala, sorry, this is being covered by
Yeah.
Dr. Nagarajan, so,
Yes,
and
sir.
you are running short of time. So.
Okay. So just an example of a dangerous anastomosis in a case of vertebral giant cell tumor, you can see an anastomosis between the right thyrocervical artery branch and the right vertebral artery. So this will also be covered in detail I think in the subsequent session. So just to talk about the technique of preoperative embolization, I will be covering the endovascular or transarterial embolization. So try to reach as distal as possible, small particles up to 150 micron followed by larger ones up to 300 to 500 micron if you are using particles like PVA. Smooth continuous flow we should try to achieve. We should be aware of vasospasm, hinders delivery by tumor and increased chance of reflux. Embolize all the safe feeders. Our target should not be to achieve a radiologically or angiographically perfect embolization. We should not try to embolize feeders which can lead to some cranial nerve deficit or other complications. Ideally, the endpoint should be complete absence of tumor blush, reflux into the, or there is any reflux into the vital areas and distal to any dangerous anastomosis. So another point I would like to mention is after whenever you are finishing the embolization, please make sure to flush your catheters properly, aspirate so that no residual material should go into the intracranial circulation when you are taking a post-op embolization run. So just to finish with showing some cases, this is a case of a juvenile nasopharyngeal angiofibroma. You can see supply from the right internal maxillary artery as well as some feeders from the right internal carotid artery as well. So we cannot access this right internal carotid supply. So the right IMA branches were cannulated and it was embolized using the PVA and gel foam slurry. We can achieve an embolization on the right side. On the left side also there is some feeder from the left internal maxillary artery branches which was also subsequently embolized with PVA and gel foam. Another case, glomus tympanicum paraganglionum, you can see there is an enhancing lesion in the right temporal area. So this had a feeder from the right ascending pharyngeal artery branch, you can see here. So here we are able to reach as close as to the tumor and inject. So this is the location of the microcatheter. This is a microcatheter injection prior to the embolization and complete embolization was achieved. Remember, when doing ascending pharyngeal artery embolization, you should be aware of the neurovascular trunk of the ascending pharyngeal artery that supplies the lower cranial nerves. Case of glomus caroticum paraganglionoma. So here you can see there is a very long feeder from the ascending pharyngeal branch of the external carotid artery. So this is a very safe feeder to cannulate by transarterial route. We could cannulate the vessel and embolization could be achieved with PVA. But most of the cases of paraganglionoma doesn't have this type of feeder. So in a companion case, I think in the next session on percutaneous it will be shown better. So here if you see the arterial supply are more of a from the carotid body arteries and it's more of an en passage type of feeder that cannot be cannulated by transarterial route. So in this case with a balloon inflated into the internal carotid artery, direct injection with onyx was done and near complete embolization was achieved. So to conclude, endovascular embolization is an effective adjunctive therapy to tumor resection. Thorough understanding of the angioarchitecture of the head and neck tumors and neurovascular anastomosis is of paramount importance. techniques and embolic agents continue to evolve for better results, and don't go for perfect result and end up unnecessarily harming the patients. Thank you.
Thank you, Nirmala. He's taken you to the intro of this. As I invite Rashmi to come forward, he'll be doing 2 talks back to back for continuity. One is the hardware and techniques for percutaneous. Along with that, he'll also do the case-based discussion. So that's half an hour for you, Rashmi. And we will have the questions towards the end of the session. So, for introduction, I think all of you know Professor Rashmi Sharaf. She's at the KEM Hospital, Mumbai, dedicated neurointerventional radiologist, has been doing some amazing work, both in KEM and in multiple hospitals in Mumbai. What happened? You go there? That's really far, huh? Just as a query from the organizers, do we have the questions running through the app or do they ask it verbally? Anybody, can you clarify that? Huh? Okay. So please use your apps to write your questions down. We display at the end of the session.
Good morning, everyone. And today, after this excellent talk on the transarterial embolization, I'll take you ahead to the direct puncture or percutaneous embolization of the head and neck tumors. Since we do spinal as a part of our head and neck, so I will include some spinal cases as well. So, as we all know that most of the tumors we treat by transarterial embolization. So, there are very specific indications for direct puncture of head and neck tumors. So, as we all know that these are the list of the tumors, it has been already talked about by Dr. Nirmal. So, I will specifically go into certain tumors which cannot be treated transarterially, especially when their main feeding arteries have been occluded or they are not as good for transarterial embolization. So all these preoperative embolizations are aimed at reducing blood loss, reducing the operative time, have a cleaner surgical field so that there is better removal of the tumor. So we should always assess our imaging nicely, evaluate the vascularity on a complete DSA. Where many a times for the neck tumors you have to do subclavian angiograms and document the whole vascularity so that you understand whether there can be a potential anastomosis or what are the supplies so that the entire tumor can be devascularized. So why do we do percutaneous in recurrent JNFs? That is when already it has been embolized or it has been operated. So now the predominant supply is from the internal carotid artery or from the some reformed branches of the external carotid artery, or the surgeon has already occluded the ECA and now it is the reformed external carotid artery. So those are the times we puncture the tumor and we do the embolization by direct puncture. Carotid body tumor, when there is no prominent arterial supply and they many a times have direct supply from the external or internal carotid artery, and that is the time direct puncture of the tumor gives a better result than going transarterially for nice removal of the tumor. Then the meningiomas, recurrence, we do when they have the defect in the bone. I have done only one case till now. We can go through the bony defect and do the embolization. Now coming on to the hardware, it is very, very important to choose the right hardware for direct puncture tumor embolizations, because the tumor vascularity most of the time are very, very small vessels. And when you are dealing with small vessels, you have to have small needles. Like scalp vein, if you are choosing, it should be 24 gauge or 23 gauge. LP needles, then 24 or 23. We don't go to the bigger bore needles. Short arterial connecting tubes, they come handy when you are using LP needles because they keep your needle stable within the tumor, because little movement can lead to movement of the needle from the small vessels where you have parked the needle. So we always attach a short arterial connecting tube to them. Sometimes long LP when you have to go deep, like Chiba kind of needle. N-butyl cyanoacrylate, glue, endocryl, lipiodol or vividol that we have now, DMSO with EVOH based embolic agents, and neuroballoons. They are very, very important to be used because there are potential supply from the internal carotid or vertebral arteries, and you have to safeguard them by using the balloons. Now we have many balloons, even they are DMSO compatible, so if you are using the onyx or the squid, you can use those balloons. So just a picture of these. This is the most common needle that we use for direct puncture. This is a short arterial connecting tube that we use for our punctures with the LP, and we connect them like this to the LP needle. Once we have taken the puncture, seen the backflow, then we attach this needle and we then flush with the dextrose or with the DMSO based on whatever you are injecting. For up till 35 to 40 minutes, you can easily inject DMSO through them. There is no problem. Now coming on to the N-butyl cyanoacrylate, previously we used to have histoacryl, now we use endocryl, and it is as effective as histoacryl. Now again to the lipiodol and vividol. The vividol advantage is it comes in 5 ml vial as well, so it saves the cost at times. So we have again now started using vividol more commonly than lipiodol. Now these agents are the DMSO, EVOH plus DMSO based agents. So these are very, very important tools in our armamentarium, especially for hemangiomas, where we don't want to let them go for surgeries. For tumors, we use in very selective cases because they become very expensive. Tumor is anyways going to be removed, so we avoid them in our scenario, but many people in the Western countries, they are using them. So we have by Ball, Squid, Onyx by Medtronic, and Minox by Merrill. And there are a few more in the process which will be available in next 1 year. Now I'll start with the JNF so that we understand the technique. The routes of spread is important to understand. See your images before you plan the treatment, because based on the direction where it has grown, you can get the access to the tumor. Like if it is medial growth, it's nasal cavity, nasopharynx, so you have good access through the nasal cavity. If it is lateral growth through the pterygopalatine fossa, it has grown out, or it has gone into the maxillary antrum, it gives you a very good access to the transmaxillary or transmandibular notch. So we understand the extensions, it helps us to understand the axis that we need to use. So coming on to the direct puncture, this is just to understand that this anatomy is very, very important for JNF, ophthalmic arising from middle meningeal artery. A routine tumor shown already, good blush, we do transarterial occlusion, but what when we have big tumors like this, lot of ICA supply, and we have to cure them and give them a good feel for the surgeon. So this is a brief of the summary. I'll show you in every case, every part of it. So we do the imaging and DSA assessment, then we take a roadmap of the arterial supply where you see the tumoral blush, take that roadmap, then puncture it with the needle that you have chosen to puncture the lesion. Look for backflow. When backflow has come, inject, and if you are taking scalp vein, we already flush it with the contrast and then take it for puncture. If we are using LP, we take the stellate out, let the blood come back, and when the blood has come back, we attach the short connecting flushed with the dilute contrast, attach it, and then take a dilute shoot, a gentle shoot with the scalp vein or with the LP needle. Once you have confirmed and you are using the glue, then you flush it with dextrose very gently. If you inject it hard, it will extravasate and you will lose that small blood vessel chamber that you have got where your needle is parked. So very slow injection with dextrose or DMSO if you are planning to use DMSO based liquid agents. Then slow injection of glue under roadmap guidance, and if you have used a balloon, inflate the balloon when your embolic agent is going towards a prominent artery like a vertebral or ICA. Concentration of glue is very important. Where you are in the superficial part of the tumor, which is away from internal carotid artery, you can use dilute glue. maybe 20, 25%, but as it progresses closer to the ICA, you have to increase your concentration of glue to 50% or 33% based upon how it is moving. And balloon in ICA, we've already talked about it. Intermittently, you can do check shoots with the diagnostic catheter, which we have already parked in our arteries, and work in orthogonal planes. I'll show you cases what happens when you miss the orthogonal planes. Work in orthogonal planes means either one of the, most of the direct punctures should be done in biplane. We don't encourage them doing in single plane. And when you are doing in biplane, at least one plane should be a neutral plane in which you are used to seeing your angiographies day in and day out. So you have to work in orthogonal planes so that by mistake, if you tend to enter one of your prominent important arteries, you see it, diagnose it and stop. Otherwise, you can lead to catastrophic complications. So what are the routes for direct puncture in JNF? We use these three routes. One is transnasal. Transmaxillary we use when the bone is thinned out because of the tumor infiltration. It is expanded and thin, or through the mandibular notch between the coronoid and condylar process of the mandible. So just for the juniors here, we have to understand the anatomy to understand that this is the lateral part of the nose, these are the turbinates, and they posteriorly open into the nasopharynx, and here is the sphenopalatine foramen. This is the site where the tumor is, the epicenter of the tumor is, which can go towards the nose, down, up, or laterally towards the pterygopalatine fossa. So we have to reach this area in order to do the direct puncture transnasally. So this is a patient with a tumor. So if you enter from here, you have to first go straight and then make it parallel to the hard palate. If you become parallel to the hard palate, you will reach the tumor easily. This is just to show you how we will work in the X-ray, because we are working in fluoroscopy, and this is how you will have a lateral picture. So you have to enter the nose and try to be parallel to the hard palate, and then you will reach the tumor. Again, the same thing in the MRI. I'll show you now how we actually do it. So this is a plain X-ray in AP view. In lateral view, you will have a roadmap plus live fluoro. You need it mandatorily to do all these direct punctures. So this is the tumor which we have to reach. So I have just drawn an outline for you to understand that we have to reach here from the nose. So first we'll take the needle and take it straight into this, directed upwards, and in AP anteriorly it will go straight like this, and then you have to angulate your needle in such a way that it becomes as parallel to the hard palate as possible, and then you can enter the tumor bed. So in AP it will be first straight, and then it should become end on. The AP, the needle will go end on. If it is going end on in AP and parallel to the hard palate in lateral, it means you are going in the right direction. So once you have done, so this is how it looks in lateral. You can see they are almost looking parallel to this line once you have angulated it. And this is in AP, they look almost straight because you have taken the needle straight inside. So this is a tumor, big tumor with extension everywhere, sphenoid sinus, in the laterally, nasopharynx. So this is the tumor which was already operated. I am showing you the technique here. It is the recurrence and huge supply from the internal carotid artery. So we take a roadmap, balloon in the ICA, and then you take the needles in, trying to be as parallel based upon which area you want to go. If you want to go in more superior aspect, you may be little less parallel to the hard palate, and once you reach there, then you have to rotate it slowly till you see blood coming at the stellate base, and if you see the blood has come, then you take out the stellate, let the free flow of blood come in your stellate, in the LP needle. When free flow comes, then you attach a syringe with a short connecting tube to your LP and take a shoot like this. It has to be very gentle shoot. Inject one drop and wait, let it progress. It will spread in the whole tumor. And with the same pressure only you have to inject the glue. You can see now we are injecting the glue here. So the glue is going slowly, it is spreading, and as it is going closer to the ICA, we will increase the concentration of the glue closer to 50%. Balloon is inflated, and now we continue to inject, and and at some point of time it will go close to the ICA because it's near the sphenoid sinus and it is very close to the cavernous sinus as well. So we filled it all, and this is the picture we get. The whole tumor has got a beautiful penetration of the glue within it. Some people can use this also. This is just a representative picture, not of this patient. You can take the... so you can add my
Last 2 minutes.
Next presentation. You can add my time for the next presentation here. So we can inject in the blush of the roadmap so that you know the penetration is happening. But we usually inject with a blank roadmap or with only ICA visible within it. And this is how it looks on the CT scan. So this is how we look, and I will show you how. So this is how we had gone into the needle and injected from here. Now coming to the mandibular notch or transmaxillary. So here it is between the two processes that we go in. So you can see these are the two processes, and this is very straight axis. If you have a tumor here, you can straight go into this tumor. So this is how it will come. You have to go through the mandibular notch. This is the mandibular notch. Your all needles will go between it. In the AP, it will be going medially, and in the lateral, it will be going between the mandibular notch anteriorly. And this is how we achieve. We inject into the whole tumor. Again, now this is a tumor with large lateral extension. This is how we'll take our needle in. This is a blush, and this is how the needle will go through the tumor. And this is here we are with the entire tumor with injected through the transmandibular notch. Now transmaxillary is the easiest of all because bone is thin. You have to just penetrate the thin bone and take the shoot and inject the whole thing with the glue. This is how we go through the transmaxillary. So this was all about JNF. Coming on to the paragangliomas, he has already shown you the vagal tumor, the glomus jugulae, the carotid body tumor. So we all know about the details of it. So coming on to the angio here. So what we are seeing is the blush. It is a very well encapsulated tumor, but it has blood supply from the external and internal carotid artery directly. When we talk about paragangliomas, we have to talk about the BTOs. So we do the...
Time is up.
We do the BTO, and it has to be done carefully because at times the surgeon has to occlude the ICA in order to achieve cure in these patients. Because ICA is well encased by the tumor, and we do the direct puncture. You have to be careful that ICA is medial and posterior. So you have to keep your needle direction which is away from the medial and posterior. Try to keep anterior here and keep lateral here. And in the roadmap you puncture the lesion, and then once it is done, the process is same, inflate the balloon, and this is how we inject the whole tumor and get cure. Now coming on to the hemangiomas, which are also the vascular tumors, and they are very, very difficult because these arteries are very small. These are small blush-like lesions. You have to take multiple punctures and then slowly inject the glue within them. The angio shoots have to be taken very, very carefully, otherwise it starts extravasating, and we don't want that because it spoils the surgical field. Now coming to the percutaneous onyx, DMSO plus EBOH, it can be injected through scalp vein or the short arterial connecting tube easily up till 1 hour. It does not disintegrate up till 1 hour. So this is a small hemangioma that this patient has. We see the blush and the vein in the late phase. So we decided to treat, and we punctured it with, this was multiple things. It has squid, minox, onyx, everything. You can see the different densities. So we punctured, the process remains the same. You get the puncture, you see the backflow, you take a gentle shoot, micro shoot, and once you are done, flush with the DMSO at a very, very slow rate, and then inject onyx or squid or minox, whatever you want to inject, and this is the final picture. So what I want to show you here is the change in the skin color. This is not necrosis, this is just the change in the skin color. It becomes blackish or darkish color next day because of the onyx, the color of the embolic agent which is visible outside. Another case, this is a pinna AVF, but it is very slow flow. It is in the transition between the hemangioma and AVF. So the parents did not want surgery, so we decided to embolize it with direct puncture onyx. The good part is if you don't extravasate, the patient does not require any surgery. Only thing, color changes. This is the color, and this color he will this was done many years ago. He's still having the same color as compared to this pinkish color that he had before. So now I will show you one case where it is AVF, but I just want to show you the technique to use. We did the transarterial to reduce the flow, and then we take puncture to slowly inject the onyx within it. And this is how one single puncture, if you have nice puncture, you can take the whole lesion and avoid surgery. So this was his eye before, and this is his eye immediately next day. And this is after around a week or so. You can see it is regressing. It will further regress in size. This was done almost 2 months ago. I don't have his recent picture, but it has become much better, and the surgery has been avoided because there is a tarsal plate involvement. If they do the surgery, the eye will not open. So that's why the direct puncture onyx has become a boon to us. So now any tumor in this area, you can go, you can puncture, you can inject onyx or glue, whatever you want to use. Now coming on to ABCs, these are another tumors which we very aggressively treat with direct puncture because they are blood-filled cavities. There are hardly any transarterial supply. We have been doing transarterial before, but now we do direct puncture. So we started off with this case, we went inside, we injected, surgeon didn't want to operate, and in the follow-up it mineralized really well. And this was the time then we started using it more and more, and you can see that here there's a big lesion. You have to go take the backflow, and here sometimes we even use 18 gauge BD needle because it gives you a big space to inject. So big space to inject, you just inject the glue. Surgeon is very happy because when he opens, blood is not spilling in the entire surgical field, and they can just remove these cavities really easily. Now showing you one case because it is about the direct puncture, percutaneous. This is intraosseous fistulas which at times present with high flow bleeding from the gums. He was bleeding from here, and it was a very complex maxillary AVF. So we punctured it with a BT needle because it gives you a bigger bore directly from the maxilla, and then filled it up with glue, and this is giving you a result which you cannot get transarterially. So this is just a time with skill you get this feeling. This is a mandibular hemangioma. Patient was having pain, patient had swelling. So we punctured and filled it with onyx. Again, it's a very old case. Swelling has regressed and he's very happy. He doesn't want to come for follow-up. Again, vertebral body hemangioma. Here, transarterial is good. We do CT-guided alcohol ablation for them, which leads to very nice regression of these vertebral body hemangiomas. Direct puncture, if you have already had surgery, it is for tumors like meningioma or hemangioparasitomas or blastomas, where you have loss of bone. This is borrowed from internet. I didn't have the picture of the case we had done. So we punctured through the dura, and then the glue or whatever material can be injected. Again, a word of caution in hemangioparasitomas, after the puncture, the tumor pressure increases a lot and sometimes they bleed, so a patient should be shifted to surgery immediately. And sometimes you can even do direct puncture of the tumor in the OT. Once they have exposed the tumor, you can puncture, fill it up with glue and give it to them, especially if you have a hybrid OT. So these are the complications which you can have: vision loss, cranial nerve palsies, injury to ICA, vessel occlusions, or embolic ICA, embolic agent going into the ICA. So I'll show these cases in the next presentation. Can you open my next presentation, please? Okay, so this is a case which was treated before with epistaxis, recurrent epistaxis, repeat tumor, puncture. This is just to show you more cases. So this we had injected with a roadmap, and once if you get one good puncture, you should just keep on injecting with changing the concentration of the glue, and you can get a good result. So again, that in the previous case, the ECA was ligated. Here you don't have good feeders. Again, you do the same thing. They are not good access, and you can puncture and fill it with the embolic agent. Now coming on to this case, here you have tumor which is, so embolization was done, everything was good. What was not done here was keeping a balloon in the ICA. And then what was recognized after some time was that there is something migrating into the arteries of the brain. And then we took the shoot. This was done many, many years ago. And you can see that some arteries are missing here. We gave anticoagulation. We gave, that time we were using RioPro, that was given. And procedure was stopped. Luckily, patient did not have deficit, young patient, very good collaterals. But lesson to learn is always use balloon. This is very, very old case. We every single time use balloon. Keep a watch. Balloon should be inflated when you are injecting and stop when you have gone close to the ICA. So this is what happened. This was the glue which had migrated into the brain. Now another patient. Here this is carotid body tumor. I just want to show you a case which we have treated differently. So big large tumor, large blush. So we did the BTO. This says, okay, I think images have overlapped. So there we had occluded the ICA, patient had passed the BTO, there was complete encasement of the ICA, and because of the complete encasement, surgeon wanted the artery to be occluded, so we occluded it with coils before and then we filled it with glue, and you can see we had a very good cast, and at the end it was occluded. So you have to talk to the surgeon before you plan treatment. If they are wanting to occlude the artery, if it is complete encasement or involvement of the ICA, you may occlude the artery and then give the case to the surgeon. It is really helpful to them. Like in this case, it is now an ABC in the cervical region, young boy, surgeon is planning to operate, and you can see that the left vertebral is fully surrounded by the tumor. Whatever surgeon does, this artery is going to bleed on table. So we discussed with the surgeon, surgeon told us to take away this vertebral so that he is comfortable during the surgery. This is, and you should occlude at the level of encasement. That is very, very important. When you include at the level of encasement, when we nick the tumor, there is no bleed coming onto them on table. So this patient, you can see there is narrowing, there is encasement here. So we went ahead, we occluded this segment of the vertebral which was involved by the tumor, and then we punctured it and filled it up with the glue, and from the same our OT table, it went to the surgeon's OT table. The only issue with the glue is if you send them immediately, the glue needs some time to polymerize in the ABC because they are fluid-filled pouches. So he was saying that glue was oozing out from those pouches. So normally we allow them to operate after a day or two. But in this case, the surgeon wanted to shift immediately, so we shifted immediately, and he was operated successfully and they could remove the whole tumor. Now this case is not of tumor, but this case shows something which you all have to see and know. It's a pinna AVF, transarterial embolization was done. Dangerous ECA, ICA anastomosis exists even if you don't see them. Again, it's a very old case. I had just joined as a fellow that time. So after multiple transarterial, patient was taken for direct puncture, and it was being done in an oblique view. So when the puncture was going on, everything was going nice, and then we were injecting, and we were also very excited to see the glue spreading in the lesion, and suddenly the consultant in the room shouted, "Stop." And he said, he came in the lab and he said, there is something which is not okay. And we turned the tube to orthogonal planes. I hope someone can see something here. What is this here? So this is glue going into the vertebral artery. Work in orthogonal planes. It is a basic rule. Work in orthogonal planes. Same thing in the tumors. Like I showed a big tumor in the base of the skull previously. We were doing in orthogonal plane because it had supply from vertebral artery. Everyone, if you are not careful, your glue from the tumor will go to the arteries. It happens many a times. From the tumor, the glue can go to the feeding artery, and it can occlude the vertebral. Luckily, we stopped at this point and we could see this vertebral is occluded, other vertebral, but there was a shower of glue emboli in the brain. She had blindness at that time, but she eventually recovered over a period of month. Again, showing you the complication of a BTO. BTO should again be done, should not be taken lightly. It should be done very, very carefully. Trauma while taking a transsphenoidal biopsy, and we did the cross compression. Patient came for treatment the other day. We did the BTO and we took the shoot after the BTO. I think it was immediately maybe thrombus form, maybe not adequate anticoagulation, and there was something here. So we took shoots from here, we could actually see it was moving. So we deflated, and by deflated the balloon, it migrated. So distally, we injected RioPro in this. That time it was RioPro. We are more cautious. All these complication cases are very old, but they have very strong imprint on our mind, and we still remember every single patient where these things have happened. So to conclude, direct puncture embolization allows good intratumoral deposition of embolic agent, needs expertise and skills to safely puncture the lesion and use of glue. Plan your case well before you want to do a direct puncture. It should not be like you just wake up in the morning and decide to do a direct puncture. They require a lot of planning so that you don't have any complications during the procedure. Knowledge of potential ECA, ICA anastomosis is very important, and it is imperative to work on orthogonal planes. Thank you very much.
So the next speaker, Dr. Kulkarni, is not here with us today. So Dr. Suraj is going to speak instead of him. So he's going to come and talk to us on ablative therapy in head and neck tumors. Thank you for stepping in.
Good morning to everyone. Digging further inside more the topic of percutaneous interventions in head and neck, I'll be talking on the ablative therapies which we can offer in head and neck tumors. So since head and neck is a very complex organ built by multiple areas, according to each organ we have multiple indications to offer for the patient. So most common thing what we do is a thyroid ablation for the benign nodules and cyst. Cyst we can do chemical ablation, benign nodules we usually do the solid percutaneous RFA or microwave ablation. Sometimes you do get referrals for the recurrent papillary CA where post-op bed is highly bed full with the adhesions and surgeons are very hesitant to go and reoperate again. Parathyroid adenomas, ideally surgery is a gold standard, but if patient is not fit for the surgery, you can do ablation, but you have to be mindful of the recurrent laryngeal nerve which will be passing from the posterior aspect of the thyroid gland. Salivary tumors can be benign or malignant or recurrent, where again surgery is a modality of treatment, but in inoperable cases you might get references. Metastatic foci from the thyroid, squamous or lymphomas sitting inside the lymph node, again these are the indications. Adenoid hypertrophy residual tumors, these are usually done by ENT surgeons. Again this is a very hot topic of obstructive sleep apnea where you might get references for adenoid hypertrophy and doing ablations for that. Bone, we have multiple lesions arising from the maxilla, mandible, skull base and cervical spine. So either metastatic foci from the primary or myeloma where patient usually presents with the pain. You can do RFA and vertebroplasty just to do the palliative measurement for pain treatment. Fibrous dysplasia, osteoblastoma and chondroblastoma, these are benign tumors where RF ablations can be offered as a definitive treatment just to get relief of the pain. Vascular malformations, we usually do sclerotherapy, but sometimes we do see cases where sclerotherapy is resistant and you might have to switch the modality from sclerotherapy to the ablation. Soft tissue tumors like sarcoma, benign fibromas and neurogenic tumors, here again surgery and chemo is a treatment of choice, but lesions which are resistant to these conventional treatments, you can offer ablation as a modality of choice. Painful conditions where you will see neuralgias arising from the trigeminal, glossopharyngeal or occipital nerves or neuromas. Again, here are patients which present with the excruciating kind of pain. You can do temporary nerve blocks, and after confirming block, you can offer ablation as a definitive treatment modality. Airway, recurrent papillomatosis, small tumors and hemangiomas, these are again tumors which will cause obstructive airway disease and everything. So again ablations can be offered with the help which will get relief of the obstruction to the respiratory airway. Coming to the common ablation which we offer in head neck area is the thyroid ablation. According to these Korean guidelines, it can be done under either benign or malignant category. So in benign, symptomatic nodules which are more than 2 cm in size, if there is a concern of cosmesis for the patient, or if there are pressure symptoms in the form of pressure sensation while having deglutition, ablations can be offered. Before jumping into the ablation, you have to make sure that 2 separate USG guided FNCs has to be benign, and you have to prove that it is a benign nodule, then only you can do ablation. Again, patients who refuse surgery or who are not eligible for the surgery, ablations can be offered in this category. Recurrent thyroid carcinomas, small metastatic lymph nodes from the thyroid, or primary small thyroid cancers, which can be either papillary or can be from medullary. This ablation modality can be offered. Another emerging indication in thyroid is autonomically functioning thyroid toxic nodule. So here also we have a role. If patient is not fit for the surgery, you can offer in such kind of category. Coming to few cases, 36-year-old female incidentally diagnosed as a thyroid nodule. On ultrasound, you can see the ThyREDS 5 lesion, taller than wider, solid, hypoechoic. You can see multiple punctate foci of calcification. This demands for the FNAC diagnosis, which turned out to be the papillary CA. Since the patient not willing for the surgery, we offered ablation. So for doing thyroid ablation, we usually come from the transsystemic route, coming from the medial to lateral. Just we have to be aware of the two areas. One on the medial side, which is a danger triangle, where recurrent laryngeal nerve is a critical structure. You have to do the hydrodissection. Some people do inject recurrent laryngeal nerve prednisolone injection. So this can be done to get relief of this nerve injury. Again, second critical structure here is the vagus nerve, which lies in the carotid sheath. So you have to see the relation of the vagus nerve with the help of IGV and with respect to IGV and carotid. If the nerve is on the medial side, then again you need to have a good amount of hydrodissection. The technique which we do here is the moving shot technique. So we come from the start from the posterior and the medial aspect of the thyroid and go to the lateral and superficial, because when you do the ablation, you will see such kind of air foci, and that will hamper the vision distal to the air foci. So you have to always come from the medial side and go from the go to the lateral side and come superficial. So this was a pre-ablation PET uptake. How on post-ablation scan you can see a good amount of resolution, and now patient is cancer-free. This was a 63-year-old male and already underwent right hemithyroidectomy, histopathology of which turned out to be the papillary, which was a classical type. Again, patient presented with the left-sided thyroid nodule. On MRI, you can see T1 hypo, T2 hyper, and on dynamic images, you can see progressively enhancing heterogeneous thyroid nodule on the left side. Since patient underwent already one surgery, patient has a bad memory of that, and then patient again did not want to go one more surgery. So we planned RFA for this case. We usually do this kind of techniques to see the stiffness of the thyroid nodule. So this will give the baseline stiffness, which will be more in the favor of moderate to high stiffness, and you can document this on the your baseline pre-procedure scans, and on follow-up you can subsequently see the nodule is getting soft. We did the ablation with the help of moving shot technique. This was a pre-RFA scan, and on 4 weeks follow-up MRI scan after RFA, you can see good amount of resolution of the viability, and tumor is now not viable. This was a case of medullary CA thyroid metastasis, 52-year-old female, medullary CA thyroid, post-total thyroidectomy with neck nodal clearance. Patient already underwent neck nodal clearance, however, there was recurrence inside the node. So you can see on the MRI, there was enhancing lesion which was on the anterolateral aspect of the neck. Again, it was avid on the PET scan, and on biology also the tumor was secreting. So there was increasing levels of serum calcitonin. If you see critically anatomy of this area, brachiocephalic trunk is traversing from the anterior side. You have the lung on the lateral side. Medially you have the trachea, and this is the area which is very critical for doing normal ablations. So to prove it to be the malignant, we did the biopsy from the posterior approach, since anteriorly there was a very critical structures. Ultimately it turned out to be metastatic medullary thyroid carcinoma focus. So we offered irreversible electrophoresis for this paratracheal nodule, since this was a very high risk location for doing any kind of routine conventional ablation therapies. So we do punctures with the help of 16 gauge cannulas that will give the good support, since this was a post-operative bed, and through that we can inject, include the IRE electrodes, which are very flimsy. So this kind of 16 gauge cannula give the good support for the percutaneous punctures. So this is how IRE was planned. Fanning, we covered the almost entire tumor from all the sides. 4 electrodes were covering the tumor. This was a pre-ablation scan. You can see the enhancement of the tumor, and post-ablation scan, vascularity has gone, and patient is typically pain-free. So these were the multiple, we have review literatures where 477 benign thyroid nodules were treated in 222 patients who underwent microwave ablation. Pertinent points to note from this article was many of patients were from the solid nodule, but when you see the follow-up scans of these patients, there was a good amount of volume reduction at 1 month in cystic nodules. However, solid nodules do take time for volume reduction. So when you are able to counsel the patient, you can always counsel if the nodule is solid. It takes approximately 3 months to have a good volume reduction. However, cystic nodules, they usually get reduced after 1 month on follow-up. In malignant nodules, we have a retrospective study, 358 patients with solitary T1 papillary underwent RFA after the mean period follow-up of 75 months. We have the overall disease progression seen in 5% cases. Incidences and recurrence were typically less than 3%. So this was a study and meta-analysis of metastatic lymph nodes which were treated by ablation. 20 patients with 20 studies with 372 patients, encompassing almost 620 metastatic nodules. So nodes were divided into 3 groups according to the size. The pertinent observation from this study was that there was significant decrease only if there is a baseline tumor which is less than 20 mm in size, and however recurrences rate again were seen if the tumor is less than 20 mm in size. And however, complications were seen more in smaller tumors because these are the smaller tumors lying critically by critical structures. So you have to give good amount of hydrodissection and good protective techniques to treat these smaller kind of nodes. Coming to bone and soft tissue tumors, this was a 35-year-old female, left cheek swelling presented since 13 years. There was a rapid increase over the period of 2 months. You can see fibrosis lesion with secondary ABC transformation involving the left maxilla. Clinically also you can see the big tumor bulging. Since she was a young female, there was a concern for cosmesis. So she did not want to go undergo surgery. So we did the cryoablation for this tumor. So we came from the lateral subzygomatic approach. Under ultrasound and CT scan, we parked the cryoneedle bang inside the center of the lesion. And on the follow-up scan, you can see good amount of reduction. Even on the MRI, you can see the enhancement and cystic component has decreased, and clinically also there is good amount of resolution of the swelling, and she was happy with the treatment. So this was a case of right parapharyngeal fibromatosis. You can see the big tumor which was compressing on the oropharynx, and patient presented with the dysphagia. So we came from the lateral approach. This is how you monitor the ice ball margin on the CT scan, making sure that ice ball margin should not spill over outside the tumor. And on the follow-up scan, you can see there is good amount of reduction in the form of necrosis, and oropharynx is also now opened up, and patient is relatively relieved of the symptoms of dysphagia. This was a case of 21-year-old male presented with neck pain since 3 years, which was typically increasing in nighttime, relieved with the NSAIDs. There was a lesion on MRI on the left pedicle of C7 vertebra, the biopsy of which turned out to be osteoblastoma. You can see T2 hypointense lesion, and it was enhancing. So these are the critical locations, since these are very close to the cervical spine. So in this case, we came from the anterolateral approach, and we did the RFA. So this was a avidity which was seen in the pre-ablation scan, and on post-ablation you can see the entire avidity has gone, and patient clinically also has got relieved of the pain and is now off analgesics. This was a case of a 55-year-old gentleman, CA tongue post radiation and chemotherapy. After the disease-free interval of 4 months, there was a nodal recurrence at the left cervical level too. So again, post CTRT, this is a very bad surface for surgeon to operate. So we usually get references for such cases. On PET scan, you will see viable metastatic disease on the left side. Since this was a calcified, peripheral calcified, we did the ablation under the CT scan. Also, you can use such technique to give the good tumor delineation. If you are planning to do ablation under the CT scan of the lymph node, you can inject the small amount of contrast in the area which is adjacent to the lymph node, which will delineate you, and you can do the rest of the ablation on the plain scan. This was a 13-year-old child, left CP angle schwannoma, already underwent 1 surgery and radiation. After that also there was a recurrence of the disease. On clinical examination, you can see the stigmata of neurocutaneous markers. Clinically, there was progression of the lower cranial nerve palsy. So patient presented with the gradual facial deviation, difficulty in swallowing, and there were intermittent episodes of seizures. So on imaging, you can see it is a dumbbell-shaped tumor. One part of tumor was lying intracranial. The part of it is bulging outside the extracranium through the
Last 2 minutes.
through the jugular foramen. So our intent was to give the symptomatic relief just to prevent the progression of the symptoms, and we planned cryoablation for this case. So first we did the cryoablation of the extracranial component, the component which was lying in the infratemporal fossa. We came from the paramaxillary approach, and this is how the ice ball was made bang inside the center of tumor. On post ablation, you will see a good amount of necrosis. Almost 80% tumor has become non-viable. This was very critical. The second session of cryoablation was planned. There was always a difficulty to reach the intracranial component. So we already had the tumor component which was bulging through the jugular foramen. So we went to a transjugular foramen paramaxillary approach, and we did the cryoablation inside the intracranial component. And post cryoablation, you will see the good amount of necrosis. But immediately post procedure, patient had on day 2 headache and vomiting. On MRI was done, which will show the typical features of raised ICP. There was cerebral edema and hydrocephalus, which was due to the compression of the aqueduct of sylvius and fourth ventricle. So typically these lesions will increase in size for a week after the ablation, but over the long period of time they will reduce in size. So this was how clinical course was there. There was a drop in GCS from 15 to 9. Again started on all the anti-edema measures, and ultimately patient needed right V-patient. After V-patient, patient extubated, GCS again improved, and there was resolution of edema on MRI also. So for this case, what we have learned that near critical CSF pathway, we have to be very vigilant in the post-op monitoring. We have to use good amount of steroids and drains if you doing ablation in high risk areas, and there should be careful case selections, and ablation should be staged rather than jumping to do the entire ablation. This was a 28-year-old male, right frontal headache. Presented with the headache. This was again vascular tumor, underwent surgery for 2 times. The tumor was bleeding during surgery. So BTO was done since the tumor was encasing the right carotid. Patient tolerated BTO. Embolization was done with the help of PVA from ECA branches. And after embolizing the tumor, now we know that tumor is devascularized. So we did the cryoablation on day 2 with the help of 13G needle by subzygomatic approach. Post cryo, you will see good amount of necrosis. And after that, surgeon was happy to operate, and there was a good amount of bloodless surgery. So this was a post-op MRI. You will see the good amount of debulking was done for this tumor. 48-year-old lady treated case of lymphoma with severe neck pain. Pain score was 9. These are the lytic lesions in the vertebral body. We can offer RFA and vertebroplasty. So RFA will create some space for the cement, followed by injection of the cement. So these are the cases where you will help the patient to get relief of the pain. So this was a CA lung with a C2 vertebral metastasis. Again, transoral approach was used to reach the C2 vertebra, followed by the cement, doing RFA plus vertebroplasty. So there are multiple studies which are again demarcating the importance of doing RFA followed by vertebroplasty for this spinal metastasis. So in conclusion, ablations in head and neck tumors can be minimally invasive modalities which are less morbid for the patient. They are effective, they are safe modalities, and the intention of treatment has to be clear before jumping to the case. So either it can be curative or it can be palliative. Thank you.
Thank you so much. Just due to time, we're going to carry on with our talks, and all the questions will be at the end. I'd like to introduce my co-moderator, Dr. Arun Prasad, who's going to talk on case-based discussions, transarterial. Thank you.
Sincere thanks to ISVR for giving me the opportunity to deliver something in front of my mentors and stalwarts of the industry. And greetings from the Command Hospital Pune, from the lovely Pune Hospital. So these are my acknowledgements. And we'll start with the cases. So the most common in our setup we receive was preoperative embolizations. The most common tumor being phalangeal angiofibroma. A lot of things have been said, a lot of cases have been shown. It will just be a certain sort of a repetition sort of a thing. And this is the first case, a 14-year-old male presented with painless torrential epistaxis and recurrent nasal stuffiness. This is an nasal endoscopy picture, highly vascular tumor. But we were lucky enough not to fiddle with it. So the patient underwent imaging. What we see, the MRI pictures showing the multiple, is a large due to heterogeneous lesion in the nasal cavity going into the posterior choana, typical nasopharyngeal fibroma with infiltration and avidly enhancing lesion. Again, the CT angio showing the vascularity of the tumor with extensions as well as the bony erosions. So this is a pre-op embolization picture. The right EZI angiogram showing intense tumoral blush from the spinopalatin as well as palatine branches, terminal branches of the IMA. And this is a capillary phase which showing the intense tumoral blush. We went ahead with the pre-op embolizations. In our protocol, we routinely use the guide catheters, 6F guide catheters, envoy other neuron, or then we take up either a micro catheters. Preferably we use Prograde or Parkway micro catheters, and the preferred particles in our setup we use the PVA particles as always, which is the most common, most least expensive and good rewarding case in all the cases. And we also have used few coils and embospheres. So in this case we use PVA particles. The size we routinely choose 100 to 250 microns and a good obliteration of the tumoral blush. Always, as said earlier, we always do the complete angiography picture. In this case, we had a supply from the contralateral side also. Again, the spinopalatin branches were supplying the tumor, which were embolized subsequently with the PVA particles. And then what we get here is a bloodless tumor, which makes the surgeon very happy. Another second case, again a similar case, 15-year-old male, presented with epistaxis, nasal stuffiness, slightly more cystic areas within the tumor, more expansile tumor, avid enhancing tumor, CT showing expansion with bony erosions, typical Holman-Miller sign in the pterygopalatin fossa on the right side, angio showing the right EZ angiogram showing the intense tumoral blush, lot of vascularity. We integrate with the pre-op embolization, and this is the capillary phase showing the tumoral blush followed by the embolization through the PVA particles, selective and super selective, went to the spinopalatin branch and embolized, and total obliteration of the blush. Again did the contralateral side, spinopalatin branches again, similar case, companion case with good obliteration of the blush followed by a bloodless field, bloodless tumor. The surgeon is happy. So, a lot of things have been said, it's just a sort of repetition. What in our setup we receive, either it's a pre-op embolization or it's a bleeding tumor post-RT. So, these are the two commonest indications in our setup we receive are palliative, just for the palliative purposes if it is in inoperable cases. So, the essentials we all said, a lot of things have been said. We need to have a good angiographic anatomy and dangerous anastomosis to be aware of, choice of embolic agent. We routinely use PVA particles and embospheres. We have to have a complete angiography picture. As already said, we always do our angiograms, both bilateral ECA, bilateral ICA, vertebral as well as the subclavian angiograms. Our technique, usually we prefer transarterial on case-to-case basis, like ma'am said, direct puncture techniques are both a hybrid technique can be used, and very vascular tumors, especially in the head and neck tumor, in the carotid body tumors and paragangliomas. Have to be aware of the complications and how to deal with the complications. So, is a excellent picture from the Braddock. The main artery which we are routinely deal with in our cases, in most of our cases, we use the IMA branch, that is either it is for meningioma, that is the middle meningeal artery, or the spinopalatin branches for the JNAs. And for the paragangliomas, it's either it is the ascending pharyngeal artery or the posterior auricular and the occipital arteries. The choice of the embolic agents, it will be already been said. What we use because of the ease of the availability as well as for the least expensive, we use PVA particles. We generally, to avoid cranino or ischemic changes, we generally take more than 100 microns, and of late we started using microspheres because it's they are of regular size and good easy penetrations with good tumoral obliteration of the tumoral blush. And in case of dangerous anastomosis, we always go beyond anastomosis and put a coil on the anastomotic side to prevent the escape of the embolic agent into the ICA circulation. So, this will be dealt later, dangerous anastomosis, we should be aware.
So the complications, we always have faced a few minor complications like patients developing fever and pain. So we started giving pre-op steroids also, and post-op also we give dexamethasone for 2 days, and gradually we taper on, and we also give routine painkillers for the minor complications. Major complications, a few ischemic changes encountered, and because of this, but luckily we have the patients develop without any deficits. Pianino palsies, we don't routinely do provocative testings, but provocative testing is advocated especially when we go with the ascending pharyngeal as well as the occipital regions. As I said earlier, loss of large particles in coils in case if we encounter these dangerous anastomosis, and always remember, please do not inject against any force, will cause rupture of the catheters also and unnecessary complications. So going with further with the cases, this is a 43-year-old male with a headache and visual disturbances, a large meningioma, a sphenoid wing meningioma supplied by the dural branches from the hypertrophied middle meningeal artery branches, sphenoid branches, as well as from the bile branches. This is the angiographic picture from the ECA, the large sphenoidal as well as the frontal branches of the middle meninges supplying the tumor. The patient also, the tumor was also receiving supply from the pile branches of the ophthalmic, ACA as well as the MCA branches. So we went ahead with the embolization of the ECA branches, and this is a pre and post embolization picture showing a good obliteration of the tumoral brush. Again, the surgeon was happy, it was a relative bloodless field for operating this meningioma. Another interesting case, a male patient in his mid-40s. He is a known case of high-grade leiomyosarcoma of the right maxillary sinus in the nasal cavity, and he had undergone a surgery followed by concurrent chemoradiotherapy. He presented in the ER with a rapidly expansile swelling in the temporal scalp region with fallen hemoglobin, and there was no extensive external bleeding and all, but the mass was expanding as per the tumor and rapid expansion was there. So going to the imaging pictures, the MRI showing leiomyosarcoma with ossification. This is a T2 hypointense lesions within the left maxilla and extending into the infratemporal fossa with a expansile scalp swelling in the temporal region, a lot of bleed in the SWI, and again this is a post contrast picture showing the enhancement and the inflammation on the scalp region. The CT followed by the CT angio, which shows a superficial hypertrophied superficial temporal artery as well as the posterior auricular artery, which is supplying the rapidly expansile scalp swelling. Since the patient was having a drop in the hemoglobin and the swelling was rapidly expanding, we took the patient for embolization. We first initially took the run, then we saw that though there was no active leak or any aneurysms from the superficial temporal as well as the posterior auricular artery, there was an intense tumoral brush from the STA as well as the posterior auricular artery. So we went distally. First we blocked the superficial temporal artery, then we went ahead with the posterior auricular artery, and after that patient didn't have any fall in hemoglobin. So this is one of the indications where the bleeding tumor can be one of the indications rather than the pre-op embolization also. Another case, 22-year-old male with a nasal mass, came for a pre-op embolizations. Unfortunately, I don't have the pre-op imaging. So this is a video showing the ECA embolizations. This is the lateral and the epi run showing the supply to this nasal mass from the spinopalatine branches as well as the descending palatine. So this is under the road mass, this is a microcatheter run, and slowly we were injecting the PVA particles with good penetration of the particles, and the blush was completely obliterated. So this is the final run, shows a complete obliteration of blush with this super selective cannulation of the spinopalatine branch from this. This turned out to be the nasal angioma. So another case, an intraoral vascular lesion in a 42-year-old male. The surgeon said it was bleeding. The patient had a bleeding episode from the buccal mucosa There's a highly vascular tumor, highly enhancing lesion from the buccal mucosa on the left side. This is showing the enhancement, coronal post-contrast image of the MRI. And the patient had a supply from the inferior alveolar artery, which is showing the tumoral blush and hypertrophied vessels, which was obliterated, and later on, the patient took out a avascular tumor, turned out to be a mucoepidermoid carcinoma of the buccal mucosa. Case number 7, this is a 70-year-old female with tinnitus and hearing loss. This is one of the cases courtesy of my friends. Typical tumor, posterior inferior to the inferior alveolar canal, internal auditory canal, typical as salt and pepper appearance, paraganglioma of the jugulate, highly vascular tumoral blush from the posterior auricular as well as the ascending pharyngeal artery. This was obliterated with the tumoral embolization without any further deficits from the patient. So other few tumors which also deserve some embolization, few rare tumors. This is a child presented with a mass in the nasal cavity, initially presenting as a facial nasal AVM, but however turned out to be a nasal glial. It's a published case from the AFMC faculty, and this is a nasal glial heterotopia which presenting as a AVM, where the supply was from the lateral nasal branch from the facial artery, which was embolized, and that further it was planned, the surgery was planned, and this is the final picture of the child. This is a published case. It's a nasal glioma. So the points to take from all these cases are, what is the indication of the tumor? So most from our setup, we always receive two indications. Either it is to prevent the bleeding or to reduce the bleeding. So we routinely do pre-op embolizations of meningiomas and the nasopharyngeal angiofibromas, and all bleeding cases post-RT, the CA tongue, CA buccal mucosa, this thing. So good preoperative imaging is definitely indicated. And above all, the choice of technique, we always prefer the transarterial. In very few cases, we have done hybrid technique, and a knowledge of the good angiographic anatomy and as well as complete angiographic picture along with the pre-op imaging picture is very essential. And above all, be aware of the dangerous anastomosis and always have a way to tackle them and to avoid them. The choice of embolic agents depends upon your setting. We always use PVA particles as well as the embospheres and coils in few cases, and be aware of the complications and ways to tackle them. Thank you so much.
Well, thank you for that beautiful set of cases, extremely good. And probably you understand how helpful this is for a patient's management, especially for a surgeon. You become extremely good friends with him. We'll come to the questions last. The last talk today is by Dr. Professor Nagaraj, who is the head of the Department of Neuroimaging and Intervention at CHIPMA in Pondicherry.
Over the next 5 or 7 minutes, I just wanted to show you 4 or 5 cases where you actually see these dangerous collaterals from the ECA, and keep it in mind when you embolize. Yeah. We'll directly go to the case 1. This we have seen many today. This is a JNA in the right nasal cavity. So this was one of the very old and earliest cases. So we did the common injection. We thought the ophthalmic is present. So this is the common injection showing the ICA. So we went into the selective ECA. We saw the blush. There was nothing, so we did the embolization. This is the AP of the same ECA. So these are the runs. A nice blush both in the lateral, and this was after we partially embolized. Then then we thought we'll go ahead with the rest of the embolization. Then we started seeing this meningolacrimal collateral filling the ophthalmic artery. And when you see the choroidal blush, this is a very dangerous sign. Any further embolization will probably cause vision loss. So one has to be careful, and that is the run showing that one. So this is you can see the meningolacrimal filling the ophthalmic artery. So it was not seen in the pre-procedural ECI run, but now it is seen. So it need not be seen in the pre-procedural run, but still you have to be careful. The thing is, you have to take frequently check injection in between your embolization also. And also we try to inject in different injection pressure. We did do a forceful injection and try to mimic the embolic agent injection. That will help sometimes to open up these collaterals. A posterior mass involving the posterior spinous process of the C1, C2 was very hypointense in MRI here with enhancement. So there was a doubt whether what sort of a lesion, and this was before the biopsy. So we did the angiographic runs. This was the right ECA. Again, so that was the ECA run, didn't show anything. Feeder, that is the AP and lateral. The lesion did not have much of a supply. Then we did the selective occipital run. We were not sure, so we went ahead. Then it started seeing this faint vertebrobasilar opacification. You can see that here. You can see no doubt about that in the AP. So this is one situation again. So one of the common location is the ophthalmic, and second thing is the occipitovertebral anastomosis. So this is the images showing the same thing, that is the vertebrobasilar filling from the occipitovertebral anastomosis. We didn't embolize this, and though there was a small the C2's intersegmental branch supplied to the lesion, but subsequently the biopsy showed actually it was not a tumor, but it turned out to be a pseudo gout actually. This is my third case where you have a old history of CVT. So he came with this sort of a CT and MRI picture. So a lot of collaterals or maybe a suspicion of dural AVF. This was the angiogram showing some vague vessels in the left temporal fossa, that is the CVT sequelae with collaterals. So we did the angio. This was the ICA injection on the left side. This showed there is a ophthalmic supply which is filling the dural AVF. So we went ahead and did the ECA injection. So you can see that it is filling from the ophthalmic and through the collateral this is the collateral in the foramen of rotundum, and then filling entering the deep venous system directly through the sylvian vein and also into the superficial system. So in case of dural AV fistula also, you can actually see some of these potential collaterals, because once it enters the ICA or vertebral system, it follows the venous drainage of the respective system, not to the extracranial venous system. So it is important to identify that. This is a companion case of the same. This was a right patient had a old history of head injury, which was very trivial. This had a superior ophthalmic vein prominence. That was the ASL showing that. So we did the angio, and the right ECA injection showed there was a ascending accessory meningeal from the middle adjacent to the middle meningeal with there was a ophthalmic drainage and also the posteriorly into the deep venous system here. So there was a vein which is going along it was not the basal vein but along the course of the basal vein into the deep venous system. And the ICA had a very small blush. Yeah, this was the ICA run. There was nothing much, no feeder from here. So the approach was either enter through the ophthalmic or through the posterior deep venous drainage, but we chose the accessory meningeal route and we did glue embolization, and that was a glue cast, though some glue went into the deep venous system also. But patient didn't have any symptoms, or because of that, you can see the glue going all the way up to that posterior part of the straight sinus. And after 1 month, we did the MRV, and he was fine and didn't have any symptoms. This was a case where there was a old infarct. There is another situation where you see these ECICA collaterals. This was a young 18-year-old boy with an old infarct on the small right prefrontal. You can see the flare here, except that small right prefrontal, everything was normal. So here, so there was a suspicion of moya. So we did the angio. You can see that ICA injection, ACA and MCA, the upper division are filling, the lower division is not present, but the patient had an infarct only in the superior prefrontal region. So we went ahead and did the ECA. You can see the ECA injection filling the entire inferior division of the MCA. So that means the ECA collaterals not only go to the what do they call conventional collaterals, they can even go to wherever there is an occlusion, and if there is a potential for collateralization, it may enter that area. So all these are all to be kept in mind whenever we embolize, try to do this, whether it is an AVM embolization or tumor embolization. This is my last case. That was a infarct, again a young 20-year-old, already had a large MCA infarct, and there was a left side symptom. So the neurosurgeon wanted to plan for a bypass, at least the left side, to save the ECICA. And imaging wise, there was a bilateral ICA occlusion, and moya was the diagnosis. Now we did the left vertebral first because that was the obvious vessel, and that showed the left MCA territory collaterally filling through the PCOM. But right side we didn't know, there was no MCA filling, already infarcted zone also. Now when we did the ICA injection, CCA, common carotid, you can see that the ECA is filling the ACA territory. You can see the ACA branches in the medial aspect are filling through the ECA-ICA collaterals. This was the same case, same situation on the left side also. You can see that here. You can see that ACA is filling through this ECA collaterals, the middle meningeal and then the basal or around the ophthalmic collaterals. So to summarize, so you can get a ophthalmic filling from any of these ECA branches, whether it is the facial artery or the internal maxillary artery or the superficial temporal artery. So one has to be careful whenever you plan embolization. And this middle meningeal can particularly it can have collaterally even from the opposite side, apart from the regular, all these ethmoidal and also the cavernous branches, and also in the posterior aspect with the ascending pharyngeal. Usually meningiomas in the skull wall meningiomas anteriorly are mostly fed by middle meningeal and posteriorly by the occipital artery and sometimes by the superficial temporal artery. The skull base meningiomas, usually the anterior skull base or posterior ethmoidal. In the sphenoid it will be the MMA, the petrosal branch, and more in the clivus it will be either the inferior hypophyseal or the ascending pharyngeal, or sometimes through the occipital artery through the mastoid emissary foramen. Sometimes you can have the pile supply from the pica posterior meningeal also. So these are the locations of the collaterals where you have to be careful: the ophthalmic in the orbit and the anterior skull base, the cavernous in the medial middle cranial fossa and in the infratemporal fossa. And as I mentioned, the primitive, there are nice articles if you go through to understand the anatomy of the stapedial system and the ophthalmic system, but I limit myself to mentioning and giving these examples of the collaterals. Thank you.
So that brings to an end to the session. So the QR was not working, so if any of you got questions, can you please ask? We can come up there. Yeah. Come. Please. So quickly, if you have any questions, can you just ask us and we shall just help you sort it out? Yeah, please. Yeah. He wants to know how much do you eat?
You are saying, right? So yes, that is wastage is there. So see, when it ends, you are not sure that after after that,
Where they can
you're
inject
going
further.
to stop. So you don't know the exact volume when you are going to stop. So it is very painful to see it going away in that tubing. But
No, but what will you do? You can't aspirate and use it anywhere else also.
so you can use DMSO if you know, right, you are stopping now. But most of the time when it doesn't penetrate or your picture is good, that is the time you stop. So once or twice when we knew that there is...
No, but having said that, how often do you prefer to use DMSO? I mean, like a Squid 12 or whatever. I mean, because we still use dilute loop in most of the head and neck tumors. It's much more cost effective, much cheaper.
No, but when we don't have to operate many a times, when it is very small, we use, and in fact, I use mostly Minox most of the time because it is much cheaper
When I use Minox,
compared to other embolic agents, because for direct puncture, it takes lots of volume. It looks like you will use less. It takes away 8 to 10 vials for a small lesion. So it's quite expensive.
And of course, this Minox,
You can use DMSO like we use in brain AVMs. We inject. Sometimes penetration is not happening. We flush with DMSO in between. And then again use the Squid or Onyx. So you can try that. I have not done it, but yes, it's very painful to see scalp veins coming out full of Onyx.
Also, I find in percute, unless the person is very dark skinned, the tantalum staining is pretty ugly actually. It looks really bad. Rashmi just brushed it off, but many people, now they're wondering which was better, the AVM or that stain, you know.
We always counsel them beforehand, and in fact, if we have patients of our pictures of our patient, we show to them. But for orbital lesions, it's really a boom. It's a boon because surgery is going to be devastating. The eyelid reconstruction is very, very difficult, especially if tarsal plate is involved. I'm talking more about AVMs or hemangiomas. So if we do the embolization with Onyx or Squid, and you can just leave them. Patient is also happy, surgeon is happy. Though some staining is there, but overall bleeding risk is gone away. That is the advantage.
Any other question?
I've got a question.
Yeah, Tarun.
Just
Well, I don't know how many of you know Tarun. I mean, I'm seeing Tarun after maybe 15 years. So
Yes.
Tarun's a practicing interventional radiologist in UK. He was close to London, if I remember.
Yes.
Yeah.
So no, a lot of my practice has changed more to best therapy now with the intraarterial bleomycin for subcutaneous lesions. So for example, the one you showed, maybe that was some time ago for the pinna or the face. I found that
AVMs also high flow?
I'm using.
Even for high flows, I've done a few cases of high flow, tongues and stuff, but
But
mainly,
we find it very good for slow flow valve malformations, even if you inject in the interstitium.
But we are using for AVMs now.
So how do you cause stasis with bleomycin?
So we have to mix it with, you use that 25%?
Yes.
This.
So how are you inducing stasis?
So
What
I
is
keep
your
a
technique?
balloon in the venous side.
Okay,
Two,
and
three
then
cases I have done, they were really high flow. I've not brought the cases. So we place the peripheral balloon on the venous side for the maxillofacial lesion.
okay. And Tarun, what do you do?
So it would depend. I've done some lips, some tongues, and in those cases, I've not had to put a balloon. I've just given bleomycin catheter directly and then injected best straight away. Sometimes you can time the bleomycin and give it intravenously and just wait for a few minutes and it gets into the system. But then best works really well. We've done a lot of lips, tongues.
Oh, I never use it for high flow. We use it extensively for slow flow
No,
I
malformation.
have
it's
used
begun
for
to
the
use-
lips, two lip AVMs I have done.
So in Germany, people are using it for quite a few high flows now on the shoulders and stuff. We've done 2 tongues.
No, because it's much better technically because of it shrinks
Yes.
and there is no cast over there. You know?
No. But having said that, I've had a really bad, not a necrosis, but purple staining, which lasted for at least a couple of weeks, which went then.
With bleomycin?
With best, bleomycin. If it's very aggressive, and if you overlap the things a bit too much, then
And
you can
how
get
often do you repeat the sitting if necessary? Once in 6 weeks or?
I haven't had to, bleomycin is
okay.
pretty effective.
I have
With best.
No, because of the
With best.
dosage, because we go, it's 1 unit per body cage, we have maximum of 10. So the problem is in a larger, for a child or something, we have to limit the dose enormously.
Yeah,
So
but with best therapy, you'd reduce the amount of bleomycin you need to
What's
give
the
anyway.
maximum
What
dose
is
of
best
bleo you
then?
have used for AVMs?
No, so, like for most percutaneous ones we would give 3,000 units at the time and then give best therapy. So instead of giving 10,000 bleomycin, we do percutaneous, you can reduce
So,
that
no,
a
when you
third.
mean best therapy, what do you really?
Electrosclerotherapy.
Or
Like,
you you combine it with sclerotherapy?
Yeah, we combine with
okay,
sclerotherapy,
okay.
with best electrosclerotherapy.
Okay, got it.
And that's very, very effective now
That's interesting.
AVMs.
for AVMs. Yeah.
Sclerotherapy, I didn't understand.
You know, with the best, where you have the probes, and I had some slides I could share later, but it effectively allows the cells to absorb the bleomycin, or the cell walls to allow the bleomycin to penetrate much quicker, and then cause cellular damage much better. And you have 40 minutes or two for the electrotherapy to work. It's very effective now. I found it very helpful. I believe a couple of people are talking to Luke and them, they're doing it in Singapore as well. In London, we've done it for at least 40 cases now. Large
Anybody else?
AVMs, you know, we used to use cryotherapy, now we're doing some BEST therapy.
Would like to know more about it.
Thank you. I mean, like, I'm a sort of odd man out. I'm a neurosurgeon who also do interventions. There are a couple of things which is very quite interesting different from my practice, what I do on interventions. One is the direct puncture of the nasopharyngeal masses, which you do. I feel if you can collaborate in terms of using a endoscopic guided puncture, because what did I see in the case what you showed us is the radio opacity advantage. You are not having a direct visualization of where actually you're puncturing. If you can guide in with the endoscopy and the navigation, you will get a better target than actually. So
ENT surgeons are usually there in the lab when we do the punctures. We never use these endoscopes because the space is limited. You have to put your needle, you have to change the direction, and then in addition the probe is there, because probe will be showing only the superficial part.
True.
And we need to go deep inside. So I think, and we are used to seeing the plain radiographs. Our mind is trained for that. So we find it much easier.
For venous malformations, it makes a difference. Not for a mass that is so big, where you may actually be able to just see it is some in, you know, it may be right at the posterior part of the quana or somewhere. It's definitely a very, very good suggestion. Anyone else has got a question, because we're running
from my
out of
side,
time?
sir.
Yeah.
To Dr. Rashmi.
Rashmi, the question.
Ma'am, I have got a question, ma'am. Ma'am, have you encountered any cast granulomas or infections when after doing the percutaneous embolizations? Because in few of dural AVF cases,
Lipidol based, yeah. It always happens.
It's all with Onyx and Squid. We have even seen extrudation of the cast granulomas from the dural AVF cast.
For a large venous
UAF cups
malformation.
like that, have you encountered any cases? And
It's Rashmi, what he's saying is, when we use this large volume of lipidol glue
Onyx
combination,
cast.
we get this glue granulomas, you know, coming out of venous things. Yeah, it's a known factor. Yeah,
So glue-
we excise it. Yeah, but in onyx not, but glue definitely. It's a lipidol that causes it, not the glue part of it.
Can you repeat your question, please?
how do you have you encountered any case of granulomas or infection of the cast? And in
So
case
you're talking about glue, or you're talking about DMSO-based agents?
DMSO based, EVH based agents.
DMSO base we have not seen. I have not seen at least.
With DMSO, I have not seen anything. Only if you talk about percutaneous, there's a skin staining, which is very apparent.
Tantalum powder stains.
Yeah. And with glue, we have seen
Granular,
granulomas.
yes, definitely.
In vein of Galen kids that we have injected glue, especially we have seen when we have done it in the neonatal period. I really don't know why. We have 2 kids who have come back later on, and for the next session, and in the post-CT, we saw the ring-enhancing lesions. Patient was asymptomatic. So they are proper ring-enhancing lesions, which are aseptic. We still give them antibiotics, cover them nicely, but they are glue granulomas, which we feel.
But you are talking percutaneously, yeah. So what we have seen is a lot of percutaneous. They keep extruding out almost, and we have to excise the whole thing. But we have only seen it with lipidol, especially when we use NBCA lipidol combination. I have never seen it with onyx.
They're even
Onyx also with DMS. Yeah, maybe.
direct puncture.
No, not from. We are not imported in a direct puncture technique. We have imported in the DAVF cases.
So was it like reused
They use
vial?
large volumes. You've never seen it.
New vial?
Okay,
have to look at your
I
techniques
think
also.
we'll have to conclude the session. Sorry, because we are delayed and everybody. But sorry for that. We started a bit late and we tried to keep it on time. So thank you once again to everybody, and thank you for a good audience early in the morning. Thank you, Rashmi, and everyone.
Thanks for the wonderful session.
Thank you, dear sirs and ma'am, for the amazing session. And for the next session, I would call upon chairpersons for chronic subdural hematoma embolization, Dr. Rashmi Ranjan sir from GKNM, Dr. Vishnu Prasad, Dr. Blaise W. Baxter, and Dr. Anbusellam sir. Please step up on stage. The last session's questions were verbal, but from now on, we will display a QR code which you can scan now, or you would have gotten a link in the faculty group. So you can scan this to ask your questions. You can choose the hall, you can choose the session, and you can ask your question there. You can choose to be anonymous also. Your questions will be chosen by the moderator to be discussed upon. And for the first talk of this session, I call upon Dr. M.A. Karthikeyan, who is a consultant neuro and vascular intervention radiologist at Dharan Hospital, Salem. Sultan of Salem to be true.
Good morning, everyone. So I thank ISVR 2026 and chairpersons for this opportunity. So we'll go for this chronic subdural hematoma, the talk, and my talk is on the introduction, like what is the basis for this chronic STH embolization, and what the key thing is an anatomy, because as such among the neurointervention procedure, the lower side learning curve is on embolization, but the key thing is the anatomy. So I will discuss on this. So the chronic subdural hematoma is a collection of blood products in an encapsulated space, in the subdural space. So the frequency is around 70 to 20 per lakh of population, which is twice the frequency of aneurysmal subarachnoid hemorrhage. And as the elderly population is increasing, the chronic STH incidence is also expected to increase. So the main problem in the chronic STH is a recurrence rates with a variable recurrence rate of 10 to 30%. And if there is a recurrence, and further chance of recurrences keeps getting higher. So why this happens? And so the initial hypothesis was the chronic STH happens because of the tear of the bridging veins. But this hypothesis failed because there are few things which we are not able to explain. So the STH doesn't happen immediately after the trauma, because most of the times the immediate CT scan is normal, and this happens over a period of several weeks after the trauma. And most of the blood products are chronic products, and many times that's a fluid mixed with blood. So these are also not explained just by the tear of the bridging veins, and these happens in the cerebral convexities, where if there is a tear of the bridging veins, usually should happen in more towards the medial aspect. So then the understanding of the dura mater layers helps to understand the pathophysiology better. So the dura mater is, although it's a single layer, it has composed of a periosteal layer which is close to the bone, and there's a meningothelial layer, and there is a border cellular zone layer which is an inner layer. So this border cellular zone layer is a key layer which is contributing to the pathophysiology. So what happens is when there is a minimal head trauma, there are loose junctions in the dural border cellular layer. Because of this, it got split because of minor hemorrhage. And as an attempt to, so as such in any other reparative process in the body, the body tries to heal. So it draws inflammatory cells and fibroblasts. So it leads inflammation and collagen synthesis at the layer. So this leads to formation of the outer and inner membrane formation, and as the inflammation continues, there will be neovascularization of the outer membrane, leading to a leaky capillaries. These neovascularization are not like a normal blood vessels; these tend to have a leaky capillaries. This leads to again more extubation and more blood leakage, and this becomes like a cycle. It leads to a continued inflammation, more exudation, and resulting in a complete chronic STH membrane with the blood collection within. So this is how the chronic STH will be there. So there will be a encapsulated outer membrane, inner membrane. This outer membrane will be having a more neovascularization compared to the inner membrane, and there will be keep exudation from this outer membrane into this potential space. And so all the studies have shown that these fluid within the chronic STHs tend to have more of inflammatory mediators like IL-6 and IL-8, and that becomes a basis of some of the medical management trials where they try to use anti-inflammatory and steroids to reduce the chance of recurrence. And apart from this, these fluids also tend to have more fibrinolytic activity, so it keeps increasing the recurrent chances and increase the chance of bleeding again and again within it. So how to prove this hypothesis is, so when we take a middle meningeal angiogram in the patients of chronic STH, we tend to see this small dots called as a cotton wool staining. It usually refers to the abnormal vascular networks which is formed in the outer membrane. So in some cases of very active bleed, we can see even some extensive blush within the middle meningeal angiograms. And the other thing is during the middle meningeal embolization, when we take a DAY-CT at the time or after the embolization or during the time of angiogram, we can see this membrane getting enhanced by your contrast and keeps exudate into this subdural space. So this sort of proves the hypothesis this neovascularization is derived from the middle meningeal artery, and by embolizing this middle meningeal artery can devascularize it so that you are breaking the cycle and continuous recurrent chances gets prevented. So this is again a DAY-CT showing this membrane enhancement because of, and again we can see that the outer membrane alone gets enhanced compared to the inner membrane, again proving the hypothesis that it is a dual layer membrane, and the outer layer neovascularization contributes to the pathophysiology. And next, the second part of my talk was an anatomy. So why we need to be very specific? Because it's a very straightforward procedure and straightforward embolization. But when we see the anatomical variance also only less than 1 to 2%. But the key thing we need to understand is the middle meningeal embolization, among all the trials, the number need to treat for the benefit to occur is 1 in 13. So you need to treat 13 patients for 1 patient to get a benefit. So when we have such a high NNT, we cannot afford to have any complication because it's an elective procedure, so that we need to ensure high safety of the procedure. So, and the safetiness is totally based on anatomy. So if you are very strong in the endovascular anatomy of the MMA, then we can avoid complications. So the middle meningeal artery is usually from the first part of internal maxillary artery. It enters into the foramen spinosum and then divides into an anterior branch and posterior branch. So anterior is supplies the frontal and parietal, and the posterior, it's a petrocomus supplies the posterior parietal and the regions. So a little bit on embryology so that it's easier for us to understand. So during the fetal stage, the middle meningeal artery is completely developed from the ICA, because the ICA first develops, then only the ECA develops. So initially the middle meningeal supply is from the ICA, from the petrous segment. So as the ICA develops, the middle meningeal artery will be supplied by the external carotid artery from the IMA, and then the ICA component slowly regresses. So once we understand it, then everything becomes simple. So the standard anatomy is from the internal maxillary artery, we will have this vertical branch, and then enters into the foramen spinosum at the level of skull base, and then divides into anterior branch and posterior branch, which is a frontoparietal and petroscomus branch. So at the level of before the entry into the foramen spinosum, it can give small tweaks, so which is a petrous and cavernous branch. So this petrous branch, even though it is very tiny, it supplies us the facial nerve and the greater superficial petrosal nerve. So we need to make sure we are crossing this branch as distal as possible, and this branch, if we are embolizing, this branch better to avoid, and if we cannot cross this branch because of very small vessel, always better to use particles, because the liquid embolies can have higher chance of penetration and high chance of a facial nerve palsy and abnormal taste sensation. So next is a small sphenoid branch. So this is another area which I will discuss further, and so this is an Adachi classification for the MMA anatomy. So based on the dominance of patterns, whether it's an anterior dominance or posterior dominance, and based on the level of bifurcation, this classification is given. It is more of a documentation purpose, practically not very much useful. And coming to another branch which is close to the petrous branch is a cavernous branch. So how to differentiate the cavernous and petrous branches? The petrous branch is usually directed superior, while the cavernous branch travels medial. So this cavernous branch anastomoses with the infralateral trunk of ICA. So this forms an ECA anastomosis. So again, so any branch before the before the level of foramen spinosum has to be crossed. One is to avoid the facial nerve injury, and another thing to avoid the ECA anastomosis and resultant stroke. And these branches, even if it is not very visible, sometimes usually well seen when Diana CT angiograms. So this is our cavernous branch, and this is a small petrous branch. And this is another case example where we can see there's a cavernous branch which is going and anastomosing with the supplying the cavernous sinus and anastomosing with the infralateral trunk branches. So the key thing is, even if we are not seeing it, so we need to make sure that our microcatheter crosses across the foramen spinosum, so that even if we are not seeing it, this branch is we are avoiding it. And coming to a microvasculature, so we know the middle meningeal artery courses close to the skull, and it travels within the periosteal layer. And the frontoparietal and the petroscomus branch are interconnected through a primary anastomotic network. So the diameter is close to 100 to 300 microns, while the main branches are 400 to 800 microns. And then these vessels pass through a perforating vessels which is relatively avascular in the meningothelial layer, and then connects across the border cells with multiple capillaries. So these multiple capillaries are around 10 microns in diameter. So when we are using particles, we have to make sure at least the particle size is less than 300, so that we are tackling all the primary anastomotic network at least. We can't inject very tiny particles like a 10 or 20 microns, because again it increases the chance of complication. So anything less than 300 microns is reasonably safe, and that's why probably the reason why the liquid embolics has a more tendency to penetrate into these perforating vessels and capillary network. That's why the trials are little bit favoring the liquid embolics. And we can see here, so this was an injection in the petroscomus branch, and through the anastomotic primary outer anastomotic network, we can see it is communicating into the other branches of an MMA. And the other thing to notice, the MMA also communicates on both sides, so the clinical significance is even if the chronic STH is on the unilateral side, better to embolize on the both sides, especially when you are using particles, so that the recruitment from the other side gets prevented, so that you are devascularizing the membrane as much as possible. So coming to an anatomical variance, so as we know that the initial MMA was from the ICA, so if the ECA is not developed, then we can have something called as a complete hypostapedial variant, where it processes across the foot plate of stapes, and this is usually very, very rare. So what we may come across is a partial hypostapedial persistent, where the IMA is supplied from the petrous ICA through the crore of stapes, while the internal maxillary will be still derived from the ECA. So how to identify is, so when you take a external carotid angiogram, we will not find MMA from the internal maxillary artery, and the ICA angiogram will have this vessel coming across this petrous bend and supplying the middle meningeal. So another possibility is it's a counterpart of your aberrant ICA, where your ascending pharyngeal contributes to the middle meningeal artery. And so we can see this is a top angiogram, this is an ICA, and you have a ascending pharyngeal artery which is continuing as a middle meningeal artery. So the next important variant we should remember is the MMA and the ophthalmic artery relationship. So the first is a meningo-ophthalmic variant. So what it means is your middle meningeal is a sole supply to your entire orbit. That means your central retinal artery is supplied from the from the middle meningeal artery. So how to identify it is, so whenever you are taking a middle meningeal angiogram, you identify whether there is a sphenoidal branch. So whenever you are finding a sphenoidal branch, we need to take a little longer injection to identify whether there is a retinal blush. So whenever you find a retinal blush, it means there is a patient that's a meningo-ophthalmic variant. How to confirm it is, you take an IC angiogram, you will not see ophthalmic artery. So if you are not seeing an ophthalmic artery and from the ICA, and you are seeing a retinal blush from the ECA, then it's a meningo-ophthalmic variant. So these patients we should not embolize with the particles or liquid embolics, because there's a high chances for the patients to give blindness. So the second thing is a meningo-lacrimal variant. So where your meningeal artery, this is relatively common. We will be seeing this, at least everybody would have seen who are doing MMA ablation. So this will supply only the lacrimal gland. So the point to note is, when we can see here, the lacrimal branch also communicates with the intraorbital branch of ophthalmic artery. But the thing is, the anastomosis is usually distal to the origin of the central retinal artery. So if you are using particles, suppose you can't cross this branch, and if you want to use particles are still safe even if there is a meningolacrimal variant. But when it's a meningo-ophthalmic, it's an absolute contraindication. And how to identify is, we can see the ICA injection is giving a retinal blush.
Last 2 minutes.
So the ICA injection is giving a retinal blush, and your ECA injection is also giving a small blush, but this blush is totally supralateral to the orbit, which is mimicking a lacrimal gland. So next is a recurrent meningeal variant, so where your middle meningeal artery is coming from the ophthalmic artery, and whenever you are finding a recurrent meningeal variant, it's better to avoid embolization. And again, so your middle meningeal is not from the IMA, and you will see it in the parenchymal phases, this meningeal supply from the ophthalmic artery. And the other common is, rather than a complete, it's a partial variant, where one of the frontal branches comes from the ophthalmic artery, where the parietal branch comes from the primary middle meningeal artery. So the clinical significance is, we can still embolize this partial recurrent through the primary MMA supply, and as we know, there is a primary anastomotic network between the frontal branch and your petrous comas branch. So there is we can have a penetration into the other branches, but it may be a little partial embolization, but this is safer to do. So anatomic checkpoints, when you are not seeing a MMA from the IMA, so it can be because of it can be if there is a MMA identified from the petrous branch, you can embolize if you can selectively cannulate and go distal. But if you just if your MMA is coming from the ophthalmic, better not to embolize. And we can have sometimes very rare origins like a trigeminal or basilar also can give MMA. Then these also better to avoid embolize. And when we are seeing a spinal branch, take a long injection. And if it's just a blind ending branch, you can still embolize safely. And better to cross this branch. If you are not able to cross, better to use particles. And if you are seeing a choroid blush which is coming from the ECA, you should not embolize. And if it is a lacrimal blush, we can safely embolize if we can cross this branch, otherwise use particles. And if your frontal branch alone not seen, it could be still a partial recurrent meningeal artery. You can still embolize from the MMA component alone. So just unusual pattern.
Time is up.
Just 30 seconds more, I'll finish it. So sometimes we can have abnormal supply from the scalp branches. This is from the occipital. And this is your MMA is giving this in a patients with stroke. This MMA can have contribute to pial supply. You should not embolize this. And you can see there is a ACA supply. We can see it may sometimes mimic it as a meningeal blush, but we need to make sure that it is not a pial blush. And whenever in doubt, take a dynacity. That will help you to understand. And these meningeal will have a extensive supply. So this was a patient post craniotomy and post MMA cauterization. We can see the entire bilateral middle meningeal was supplied from the posterior meningeal. So we know from our trials the middle meningeal is not 100% effective. So there are still certain subset of patients we can have recurrence, and these anastomotic network probably may be the reason for the recurrence. So this is another example where ICA is occluded, and when we take this patient was having a recurrent STH, and we can see this ophthalmic is coming from the ECA branches. And this was already recurrent. So what we have done is we crossed this spinal branch and just placed a coil because that is more safer. And this is a free paper available in JNS. It's a very beautiful paper. It helps to understand anatomy better who are starting this procedure. And thank you for this opportunity.
Thank you. Try this one. Okay, there we go. Hey, thank you very much for that very nice talk. A very important talk. Understanding the anatomy, as you know, will keep us out of trouble. This is a very safe procedure, but when we quote things like 1% to 2%, if we do 100 of them, we may have a complication. So I think very, very nice talk. And we'll go ahead and we'll just introduce the next speaker. We'll do have our talks, and then we'll open up for discussion. Remember, there is the platform to just send in your question if you like. We'll keep track of that. So let's go ahead with our next speaker, and that is Colonel Anesh Moimin. He's going to speak on the indications, technique, and embolic agents that are used in chronic subdural hematoma embolization. Thank you.
Thank Thank you, Dr. Blaze and the chairpersons, and thank you to Dr. Karthikeyan for making my job very easy. I will not go into any theory and just discuss the 3 agenda points that have been given to me, the indications, technique, and the embolic agents. But I'll just flip them over slightly. I'll start with the technique and discuss the embolic agents, and finally I'll come to the indications, which will lead to Dr. Sharat's talk after me. So how do we prepare? It is like any neurointerventional case, we prepare the patient. However, pretty much all cases, if the patient is cooperative, we do under local anesthesia. Only if the patient is uncooperative do we do conscious sedation or GA in our setting. We use a femoral access. On puncture, we give 3000 heparin. Usually I prefer to catheterize the patient. You never know what may go wrong during your procedure. We give 1 dose of antibiotic at the time of puncture and just 1 more dose after completion of the procedure. That is our pre and post procedure routine. Diagnostic angiograms of the IC and EC are taken. And this is the hardware that we have with us. Usually we have found pretty much in all our cases our 5 French diagnostic catheter, either a vertebral or a Picard based upon the anatomy, usually suffices for access as well as to serve as a guide for your microcatheter. The microcatheter in our setting, in our center, we use a peripheral microcatheter, either a ProGrade, Boston's Direction or Parkway, any of which easily accesses the artery. Embolic agents I'll come to. And long sheath, we have not used it in our center, but only if your anatomy is very tortuous, you have a difficulty in accessing it, can you keep a long sheath ready for extra stability. So, the angiograms, these have already been talking about. First take the IC angiograms, delineate the choroidal blush from the ophthalmic artery. Then just one more thing, on the IC angiogram on the frontal view, just see the extent, the thickness of the subdural and how the bile vessels are displaced, so that when you are embolizing, you'll get a rough idea. If you have any dural bile anastomosis, that may be an abnormal or you may be one of the sources of a stroke after you finish your procedure. Just something to keep in mind. So we take when you're doing a procedure, we put our diagnostic catheter in the distal EC or the proximal internal maxillary, connected to a heparin and a nimodipine flush the artery liberally to prevent vasospasm, keep NTG close at hand, and then once that is done, we take a microcatheter, access the middle meningeal artery, the anatomy of which has been exquisitely explained. And these are the angiograms. You can see the diagnostic catheter in the distal ECA, the middle meningeal and the superficial temporal are well demonstrated. And with a microcatheter wire, we have now in this image accessed the anterior division of the middle meningeal artery. And then you take slow, sustained microcatheter angiograms to delineate all the branches of the middle meningeal artery and the blush. And just as Dr. Karthikeyan has shown, one of our cases, a meningolacrimal trunk without contribution to the choroidal blush. Whenever you see this, preferable to always cross it. If you are unable to cross it, you can embolize with particles, but be very careful. The particle size should be definitely higher than 100 microns. The meningolacrimal trunk. So just be careful for the younger practitioners. Any vessel overlapping the orbit on your meningeal artery angiograms, be careful that there could be an abnormal communication with the ophthalmic artery. Okay, meningo-ophthalmic artery has already been explained. This is not a case of MMA embolization, it's a case of a keratoco-cavernous fistula, just to show a meningo-ophthalmic. Won't dwell on this. Now coming to the core point of discussion, and I'll probably be controversial here. What do we use? So PVA is gel foam is not an option because you will not get adequate homogeneous size. Coils are not an option because all you'll succeed in doing is blocking the artery proximally. So between particulate and liquid, Dr. Karthikeyan mentioned that all the trials are liquid centered. But if you show me any article that says a liquid embolic agent is better, I'll show you a similar study which says particulate is not inferior to a liquid embolic agent. And in our setting in India, I firmly believe that the cost of particles far exceeds the benefits of particles, because purely of the cost far exceeds that of liquid. In particles, you can use PVA or embospheres. Embospheres slightly more effective, slightly more expensive, but they have a more homogeneous size. Liquid, we know EVOH, Onyx. Now the disadvantages with liquid that I feel, theoretically yes, you get a better penetration, but I do not believe if your technique is correct, you will not get a good penetration with particles. Liquid, if you're unable to flush it out, you're planning a bilateral embolization, you're using glue, you're unable to flush out a catheter after removing it, now you have to use another microcatheter for the contralateral side. All this adds significantly to the cost. So in the almost 100 odd cases that we've done in our center over the past 3 years, we've used particle in all of the cases and we are very happy with our results. The size we usually prefer is 150 to 250 microns, again because we have to reach the anastomotic network, which is less than 300 microns, but sometimes if you get a very large artery or if you have some collaterals, you can use slightly larger. The target is to keep your particle size more than 100 because your ECA, ICA collaterals, even the ones which you cannot see, are usually less than 100, upper limit of up to 90 microns in size. So just a few technical points. We always use a polycarbonate 1 cc syringe for embolization. The particle size I've mentioned, and the particle should be very, very dilute. We do not use concentrated because if you use concentrated, all you'll do is clog the artery proximally, cause a reflux and cause your catheter hub. Use a very, very dilute suspension of particles in pure contrast and inject in very, very small aliquots of 0.2 to 0.3. Don't think that just because you've taken that entire 1 cc syringe, you've got to empty that syringe into the microcatheter. No. And I'll show this in, So this is, you've got your microcatheter in the anterior division of the MMA. Just give a small puff of particles, 0.2, 0.3 cc only till the proximal artery is opacified. Then switch over to pure saline and drive with slow push, drive the particles distally into the branches so that your capillary network is reached. The target of your embolization is to reach the capillary anastomotic network and obliterate the blush. Theoretically, again, you should embolize, what's written is you should embolize the anterior and posterior division separately, but if you are sure and you can keep your microcatheter very close to the bifurcation, you can easily get away with embolizing both trunks at the same time at the site of bifurcation. Now, an important method, you are not looking to clog or block the artery completely. If you consider the meningeal artery as a tree, all you're doing is trying to achieve a pruning of the artery, that is trim the distal branches, obliterate the blush. We are not looking to block the artery completely. If you go through the literature, some of the trials that are there will say that we use particles and then we block the artery proximally with coils. I think that is absolutely an overkill. I'm not sure how many people do that here, and I'm waiting to hear from the other speakers. But all you're trying to achieve is causing a pruning of the meningeal vascular system. This is exactly how you should expect your pre and post procedure angiograms to look like after you've embolized. And stop the moment you get even a slight amount of reflux into your microcatheter. You flush it out and remove the microcatheter, take a final shoot. Now, this one thing I have come across in my practice, again, I don't know how many people, this is not something I've read across very frequently, is the embolization of the accessory meningeal artery. Now, this is a very small branch, just arises distal to the MMA from the ECA, and 80% of its blood supply is extracranial. It supplies muscles, goes through the foramen ovale, and a very small, only 20% of it is used to supply the dura. Now, when we were doing our cases, I came across some angiograms in which you found a very hypertrophied accessory meningeal artery causing significant dural blush, especially in anterior subdural collections. And we went ahead and embolized these accessory meningeal arteries in those cases. So when you're taking a baseline ECA angiogram, look for the accessory meningeal artery. If it is roughly, again, I'm not found this written anywhere, this is just from a very poor level of evidence, that is my personal experience. If you find a reasonably dilated tortuous accessory meningeal artery with a dural blush, go ahead, cannulate it and do an embolization with this also. This will take you just about 10 minutes extra apart from a meningeal artery embolization, as in this case that I have shown here. Another case, in this case we did not have any cannulable MMA, and this accessory meningeal artery was the one significantly dilated meningeal artery with extensive dural blush, which we subsequently embolized. Just the three cases that we've done, the two that I've demonstrated here. Okay, so that concludes my first part on technique and embolic agents. So now let's go into the indications. So there are three things we need to consider. Do we treat the symptomatic patients or asymptomatic patients? What is the role of our embolization vis-a-vis surgery, before surgery, after surgery, no surgery? And finally, again a topic, should we do unilateral or bilateral even in a unilateral chronic SDH? So let's address the last thing first. Theoretically, when you do a unilateral embolization, the theory is that it can recanalize from the contralateral side. However, if you are able to reach the capillary bed properly with your embolic agents, in our setting we use particles, then there is no reason, just because of the collateralization, if your capillary network is blocked, there should not be a chances of a recanalization. We started our embolizations with bilateral, but now we've largely switched over to unilateral over the past 1 year, and we have not faced any recanalizations. I'm sure again most people are doing bilateral, and that is what the theory says also. So in the clinical scenario, you have these usual symptoms, patients usually elderly, mild to moderate symptoms, neurologically stable but some sort of impending neurological compromise. In this case, at least in our center, we go ahead and embolize the arteries first, keep a close watch for if they require a surgical evacuation. Then again, if they have a recurrent SDH, that is the patient has been operated somewhere, come back to us, there is a significant residual SDH. In them, of course, we have to go ahead and do the embolization. And then we have certain high-risk cases, younger patients, hematological malignancies on anticoagulants, antiplatelet drugs, and the surgeons are loath to go in and operate in these cases because of obvious reasons. Again, they respond very well to meningeal artery embolizations. So what are the demographic profile that we cater to? We cater to, of course, the elderly, as chronic SDH is a disease of the elderly, all ages, coagulopathy, present platelet abnormalities. A subgroup that is very common in our setting in the Indian Armed Forces, that is young soldiers, middle-aged soldiers who've had trauma somewhere in the hills, mountains, jungles. They have a SDH, did not merit burhole, but they come back to us with some level of chronicity, and then we've embolized at around 10 of these cases, and all of them have had good results, and I'll show them. So just show one example of each of these clinical subsets that I've spoken about. This is one of the classical acute and chronic SDHs. You can see the significant mass effect. Obviously, this patient requires a surgical evaluation first. Significant residue after the surgery, we embolized. You see the 3 and post 6 months post embolization, there's a complete resolution of the SDH. Again, this is a bilateral in a patient who was neurologically preserved, did not merit a surgery upfront, so we just embolized bilaterally, and again, complete response, SDH is gone at 6 months. So what we have switched over to now, if the patient is neurologically stable, we do not offer surgery, and I'll come to that subsequently. This is one of our oldest patients, for we have a follow-up for more than 2 years now. This is the one which I showed with the right accessory meningeal artery embolization. The pre-procedure, the patient presented, elderly male, presented with 2 seizures. We embolized the accessory meningeal in this case. 1 month post-embolization, the SDH is gone, and we have imaging for him for up to 2 years. There has been no recanalization of the SDH. Young female, case of acute leukemia with thrombocytopenia, severe thrombocytopenia. Surgeons were quite reluctant to go in and operate, although she was symptomatic. So we said, okay, we'll go in and embolize. We embolized. The only difference in technique we use here is we used a closure device in the femoral artery. Other than that, no changes. And again, at 6 months, whatever a malignancy is doing, her SDH is at least addressed. Okay, this is a soldier with trauma, did not get operated. And bilateral chronic SDHs, we embolized, again the setting, young male, post-traumatic chronicity, embolization, and the SDH is recanalized. You can think if this SDH persists, he was having, we don't know how symptomatic he will be, but he was having off and on pain, so we went and embolized and he had a good outcome. So in all the cases we've done, there's just one complication, and I should show that here. Elderly male, 84-year-old, I think we just embolized last month in December. Chronic SDH, lot of comorbidities, dual antiplatelets. He was symptomatic, but the surgeons didn't want to operate. So we did the embolization. It was quite an uneventful, smooth procedure under local anesthesia. But the next morning he woke up with a wrist drop and some monoparesis. And we did an MRI and he had these 2 small lacunar infarcts, one right sitting on the motor cortex. We revisited our IC angiogram, but we could not see any vessel drop off. This is the post-procedure IC angiogram. We could not see any vessel drop off, so we just attributed it to some particle going into a pile vessel which could not be seen. Thankfully, he's recovered well over the past 1 month, and now he's able to use his hand, he's able to write and sign. And he just came to us 3 days back with his post-procedure MRI. And you can see the SDH has significantly reduced, and we expect him to make a full recovery. So this is our practice. Now we have transitioned to that all chronic SDH which comes to the OPDs, neurosurgery OPDs are directly referred to us for embolization, and we pick and choose our time of embolization. Surgery is only done in complicated cases when neurological compromise is there. And if a surgery is required, we do the embolization either upfront or within 24 to 48 hours after the surgery. And we keep an imaging follow-up at least at 1, 3, 6 months, and subsequently as and when we feel like if the patient comes to us or the patient is symptomatic. So just to show this one interesting, when we started our embolization and had our cases, this was a WhatsApp communication I had with a very senior reputed neurosurgeon of our fraternity. So I shared my cases with him, and you can see the response at the largest. He felt that chronic MM embolization reflects poorly on the neurosurgery department. To where we are now, this is the referral which I got from our neurosurgeon at our hospital. This is how we all get cases now, that is right from the OPD they are referred to us. Again, before concluding, just 1, 2 more slides. What do you not embolize? Of course, you don't embolize an acute traumatic SDH. There is no response to that. And interestingly, this is one case which was referred to us from the neurosurgeons for an embolization. Young lady with a chronic SDH, recurrent headaches. That is why we are radiologists. We don't just treat the vessels, we look at the scans in toto along with the clinical. You can see there's a bilateral interpedicular angle effacement, bilateral uncal herniation in a unilateral SDH. So we did another MRI with contrast, and you can see the extensive pachymeningeal enhancement, and this is a case of intracranial hypotension, which was actually referred to us for meningeal embolization. You can see the SLEC in the dorsal cord. We did a CT myelo, the leak was localized, and we did an epidural blood patch. And this case actually was referred to us for an embolization. So you don't embolize all chronic SDHs. And this is a post 3 month, so
Time
the
is up.
SDH has gone just by that. And so, yeah, for my younger colleagues, look for SIH in all cases of chronic SDH. Take home points, keep it very simple. Watch for the collaterals. One interesting thing I've learned is look for the accessory meningeal artery. Aim for pruning, not for the meningeal artery occlusion. And actively look for SIH, especially in younger patients. With that, I thank everyone for a patient listening, and I thank the moderators.
So, thank you, Dr. Anish, for that wonderful talk on embolic, the techniques and embolic agents. I would like to call Dr. Sarit Kumar for the next talk on how to convince the neurosurgeon for referral for MMA embolization.
Good afternoon. At the outset, I would like to thank local scientific committee and the organizing committee for the invitation. And I have given a lot of talks on MMA embolization and chronic subdural hematoma, but this seems to be a little tougher than the routine talks. More like a socio-behavioral talk rather than the academic talk. Let me try like how it worked. The topic says how to convince your neurosurgeon or your referral so that you get more cases. Basically, there is no single point suggestion. It widely depends upon where you work, whether are you in the public sector or the private sector, and what is your relationship with your referring colleagues. So many things matters. And let me try what I have learned over last couple of years and how I could manage to get few of the referrals from our clinicians. So let us see, like before we go into what are the reasons, let us see what are the major reasons for non-referrals. If we start analyzing the reasons for not getting the adequate referrals, then it will be easy for us to sort out the issue and address it systematically. First and foremost is lack of awareness or expertise. Somewhat I should call it as therapeutic nihilism. They may say, okay, probably these won't work. We have been doing cases since many decades, and probably your embolization may not work everywhere. Such type of nihilism may be existing. You will get a lot of excuses initially, especially before we understand. And secondly, some uncertainties. These are the set of people who knows that this procedure exists and it may work, but they may say that probably we don't have still lack of adequate data, lack of level 1 evidences, so many other reasons. And the third and most important are the poor interdisciplinary collaboration or interpersonal relationships, especially when it comes to the trust or the ego issues. These are the one which takes over most of the cases. If you are not collaborative, or if you are more like confrontative type of nature, then probably you may not get good referrals. Then another reason in our setup where financial things come into picture are, they may say that, okay, if you do a procedure before our case, probably patient may not be left with adequate finances to get it operated. So it adds to the finances to the procedure probably, and that is the main reason where we may not give you all the cases even though if it is indicated. That may be one of the reasons. Then another thing is the fear of losing the control over the case. And neurosurgeons, as you know, or any other referrals, they think chronic subdural hematoma is a bread and butter for them. And losing these cases, in addition to already, there are several procedures. When I started doing my first case, when I asked for the first case, the junior most person was the unhappiest. Like he told, you have taken away all our cases already, aneurysms, AVMs, carotids, everything now. You are trying to take out our bread and butter, the chronic subdural hematomas. Don't do this for us at least. This was the first reaction when I did the first case. Still I remember that conversation. And before we analyze and go into each of them, let's see the next 3 slides, which says basically that everyone has enough cases with respect to chronic subdural hematomas. Chronic subdural hematoma will be the #1 neurosurgical procedures by 2030. Basically, it is due to increasing aging populations and indiscriminate use of potent blood thinners, especially like Brilliant all those things have come into picture now, more and more use of these potential blood thinners. And chronic subdural hematoma is not a benign disease. It needs multidisciplinary care. If you see the 6-month and 1-year mortality rate in these elderly fragile patients, it goes up to 26 and 32% respectively. It's no more a benign disease. It requires multidisciplinary collaboration as well. And if you see the incidence per 100,000 persons, if you combine all the common vascular procedures like unruptured aneurysms, ruptured aneurysms, AVMs, if you put everything together, still the chronic subdural hematoma incidence overtakes all of them combined common neurosurgical procedures, and the numbers are still increasing. And chronic subdural hematoma surgery, those seem simple, but it's not. Nearly 1/3 of the cases recur after simple bowel surgeries. It's extremely difficult to operate on individuals who are on blood thinners and with a lot of comorbidities, especially the elderly, frail individuals. So these are all the challenges which exist. So let us go to the first thing. I know it's very difficult to argue or convince a neurosurgeon or scare them, but the one thing which always works is by throwing the numbers, the data at them. Like if you master and summarize the highest quality data, like RCTs, meta-analysis, large series, and if you keep on talking with respect to these terms, they generally, they observe you, they watch you, and they get trust in you. And present the clear indications, contraindications, expected benefits, and known risks versus surgical alternatives. And we have so many trials. There are 12 trials going on. All the 3 trials with respect to liquid embolic agent has been already published, and even the recent one, membrane trial, is also published. If you see them, all the 3 trials and meta-analysis also, it has been proved that MMA embolization reduces the failure rate by 50% in almost all the cases. And these are the data which we should be knowing, and when you are talking or discussing with the referrals, you should be knowing all these things, and you should use these data to convince them. And respect the surgical expertise and and the shared decision making. To begin with, frame middle meningeal artery embolization as a complementary procedure to help difficult cases, and insist that it's not a replacement for surgery. Invite them to form a joint informed consent and allow them to have equal inputs in your discussions when you start these procedures, and use joint informed consent wherever it is appropriate. And if you are a beginner, if you don't want to risk in the early phases of your career, try to pick up a less risky cases like good anatomy and classical cases initially. Initial few cases are the one which are closely watched, and they build trust and confidence in your referring doctor. So offer to co-manage, take straightforward and recurrent chronic subdural cases to begin with, so that your initial results are good. And also, always educate them, because they may not be, they will be knowing about the procedure, they may not be knowing the clear-cut indications and contraindications. If you educate them, it always works well. Educate them regarding the indications and highlight that it's not for acute cases or those with acute progressive neurological deficits. Also let them know that it can be used as a standalone procedure if surgeons do not want to operate for various reasons and patient is relatively stable without progressive symptoms. And it's not a treatment for acute STH, so they get a lot of other cases as well. So you have to clearly define your protocols and take a joint decision making, educate them regarding the indications and contraindications. Then know your target referrals. The neurosurgeons, the neurologists, emergency doctors, critical care, and general physicians. These are the target doctors. So prepare an SOP in concurrence with these referral doctors and put a protocols in writing. Share it, once you make a protocol initially when you start these procedures, share this with your team. So get a consensus, and if you put a protocol, especially regarding how to select a case, what are the pre-procedure imaging, or what are if the patient is on blood thinners or antiplatelets, how do you proceed, what are the embolic agents of choice, why are you doing this, what is their impact on the finances, what type of anesthesia you will be using in most of your cases, what are the post-procedure joint care regarding discharge criteria. All these things should be put in SOP, and it should be shared with your team so that they know what you are doing and so that they are in sync with you. And always plan for cooperative clinical workflow. Invite your neurosurgeons to pre-procedure planning, especially in the initial cases, so that they get confidence. Keeping them in the loop helps in maintaining the trust and transparency. Offer combined clinical and multidisciplinary case conferences so that patient, when you are discussing, generally we used to discuss in our OPD, like the neurosurgeons used to call me and ask me whether can you do this case, is it ideal? Then we used to call the patient and sit, all the patients, clinician and the interventionist sit together, and because this builds a courage and trust to even the patients seeing our multidisciplinary team and the teamwork. So these are all very, very important initially. And it's important to take complete responsibility. Even pre and post procedures do not disappear after the procedure. Keep talking to the patient relatives every day, irrespective of the outcomes. Make a procedure packages, especially with respect to finances. And you involve the surgeon when you are making a package. And when you do a significant chunk of cases, host a evidence-based presentation. Most of the hospitals have monthly meetings. You can, once you do significant numbers like 30 or 50 cases, present these cases to your, in the intra-hospital meetings, involve the other specialties as well, invite them, and always acknowledge the referring doctor at the end of your talk and show it as a team presentation. When you are presenting, you should always share a typical cases like this. These pictures are ideally you should be sharing with the neurosurgeons or the neurologist, which can impress them, showing the enhancing membranes looking like a benign vascular tumor here, and you can show them the active leak, cotton wool active extravasation. All these pictures are very impressive. We should always share such presentation of the pictures with the clinicians. And also, such pre and post procedure CTs are very impressive to show them the leaky membranes, and pictures convince them more than your words. So pre-procedure and the post-procedure showing the leaky contrast into the subdural cavity, which disappeared next day. So these are the images which usually convince, because they speak louder than your words. And demonstrate the outcome and the transparency. Track and share real-world matrices, technical success, recurrence rate, complications, length of stay, reoperation rate, and patient-reported outcomes. Once the significant numbers are reached, do analysis and update your outcomes. Compare with the other world standard statistics. Keep updating this data to your referrals and share the same with them, so that they have a trust that what we are doing is matching with the standard numbers across the world. And show cases outcomes by comparing pre and post procedures, acknowledge them for the support. So such images and such outcomes are very, very impressive, and it gives a lot of confidence to the referring doctors as well. So in long run, procedures keep adding and scope of IR widens. But one thing which keeps you going is your attitude and your availability to your colleagues. Always be available, be humble, timely consult, and communicate clearly and promptly. Acknowledge the complications openly if there are any, and solicit your surgeon's feedback to improve your services. So it's basically a building trust and commitment with the team, collaboration work and not the confrontation. So working in a team helps a lot. First and the key step to the success. That's what I have observed. And take cases which are not suitable for neurosurgeons or recurrent cases in the initial stages, then combine them, and then offer the treatment for the combination. Like if you embolize, then let them do surgery. It is a win-win situation. They will not feel that they are losing numbers or the cases. And many times from the neurologists or the physicians, you will get a lot of cases which are stable neurologically, and you can do a standalone embolization, as Dr. Anish showed. So provide 24/7 case reviews via WhatsApp for imaging consults, tracking your outcomes collaboratively to build trust and data for a joint publication. Try to publish your work, and this technique in general, whatever I am telling, this applies to each and every procedure with respect to all specialties. So this is what I feel that in my personal practice, this has worked very well, working as a team and being available and humble to your referrals always, and being transparent to them with respect to outcomes as well as the complications works. And it's not very difficult to get referrals if you maintain this transparency and teamwork. Thank you so much.
Thank you, sir. It's an excellent talk.
Yes.
So knowing the theory doesn't work if you don't get patients.
Yes.
So this type of talks should be regular in all our meetings. I'll quote one instance. The current postgraduate of mine, her father is a neurosurgeon. So I told, like one day we are doing one chronic stage embolization. I told her, yeah, you are going to do a lot of these cases. Then she told me, sir, my father used to say I don't have any recurrence, so you are not going to get any embolization. So that is the attitude, so we have to understand that practical scenario. Thank you.
Thank you so much.
So I will invite our next speaker, Dr. Chirag. He will be talking on case-based discussion, chronic SDH embolization. Dr. Chirag.
Very good morning, and thank you organizers for having me here. I think this will be more of a gist of what we've already heard. in the form of few cases. So let's begin right away. 72-year-old male with gait instability, altered mental status and headache, so there's no problem. So you see chronic STH, both sides. There's a burr hole as well on the left side. So you do a middle meningeal artery angiogram, you find that typical cotton wool spots and you embolize it and it's done. You do a CT scan after 1 day and the status is the same. You repeat a CT scan after 7 days, the status is almost the same. And you repeat a CT scan after 1 month. So the question that residents often ask is, when should you kind of follow these patients with an imaging? So obviously, you don't subject these patients to a lot of radiation. There's no point doing an immediate CT scan because nothing will change because you've not taken out the fluid. What you've done is an embolization of the arteries. So we did a small study, 21 vessels, and this is what we found. The thickness progress of, so as a part of protocol, we did CT scans at day 1, day 7, 1 month and 3 months. And this is what we found, that the best time to do a CT scan in these patients is 1 month, where more than 70 to 80% of the thickness of the SDH has resolved. So 1.8 to 0.836%. We also analyzed the SDH volumes, which from 66 cc, a mean of 66 cc, it decreased to 21 cc, and which was at 1 month. So there's no need to do a follow-up imaging immediate after your procedure. So 1 month is a reasonably good time to get a CT scan done. And so the midline shift also followed a similar pattern in which there was a significant difference at 1 month. So learning pearl, frequent CT scans are not necessary to judge the response of middle meningeal artery embolization unless the patient becomes symptomatic. Obviously, in that case, you have to do it. Post-procedure CT scan at 1 month scan gives optimal information, and in this way, the excess radiation dose may be prevented. Obviously, you need to follow these patients, and the next duration that we do is 6 months followed by 1 year. Coming to case 2. Recurrent SDH, drained twice, patient referred for middle meningeal artery embolization. CT angiography showed this. So there is a complete occlusion of the infrarenal aorta, in fact the intramesenteric aorta I should say. So there is no access to the femoral route. You can obviously take the radial route, and so the next lecture will deal in detail regarding the same. So no problem, take a radial route, access the artery where you want to go, do the angiogram, right middle meningeal artery angiogram, do your embolization, and you do your job. Learning pearl, transradial access is easy and may be used for middle meningeal embolization. Age is actually not a criteria for taking the transradial route. If all the branches of, so one more thing that you would see here is, so you would see these impressions of the middle meningeal artery branches on the angiogram. So sometimes while doing a middle meningeal artery angiogram, you may not see one of these branches, either the anterior branch or the posterior branch. Don't suspect that it is not there. Don't embolize what you are seeing. Try to look for in the unsubtracted image. If you are able to see these impressions, that means the middle meningeal artery is there. It is either not seen due to some kind of embolus that you may have inadvertently put during your angiogram, or there is an alternate route or alternate source of the middle meningeal artery. So the next learning pearl is, if all the branches of the artery are not opacified in the angiogram, look at the unsubtracted image first. Arterial impressions on the skull surface indicate that MMA is present and there is a possible alternate origin or inadvertent embolus as a cause of partial occlusion during your MMA angiogram. Give vasodilators with heparin flush, wait for some time, and in all cases you will start to see the vessel. Case 3. 70 years old male with recurrent chronic SDH presenting with headache, ataxia and increased drowsiness. So this was immediate post-burr hole drainage, where you appreciate that there is the STA significantly hypertrophied, the MMA is very small. So don't just trust your ECA angiogram to decide whether the MMA embolization needs to be done or not. What you need to do is you need to go inside the middle meningeal artery, take an angiogram of the middle meningeal artery. Why? Because in the post-operative period, STA is bound to be hypertrophied because of increased inflammation, which actually you can appreciate in this next angiogram as an increased blush over the scalp in the post-operative phase. So increased blush here, and that is the cause of hypertrophied STA. The MMA is not small, but the STA is hypertrophied. So what you need to do here is go there, do your individual anterior posterior branch angiograms. This typically shows you a cotton wool typical appearance of the dura, and then embolize, and your job is done. So learning pearl, MMA may appear small as compared to ipsilateral ST on EC angiograms sometimes, showing apparently no significant blush. Do not consider aborting the procedure. The cause of hypertrophied STA is secondary to surgical drainage most of the times in the immediate post-operative period. Go ahead and complete selective MMA angiograms where you will see a blush, and then go ahead and embolize it. Learning pearl 2. Perform superselective angiograms of the anterior and posterior branches of MMA and selectively embolize them as far as possible. Although I agree that putting the microcatheter at the bifurcation may actually suffice most of the times, but just to be 100% sure that you don't do any non-target embolization, cannulate the individual branches of the MMA and then embolize. This also leads to better percolation of the dural vasculature. Next case, case 4, young male sports player, history of minor head injury, mild headache for few days, good GCS, large left-sided SDH, and this was how the patient presented. Large SDH, but in addition, there's a large hematoma along the Sylvian system. So this was operated with burr hole, found to have underlying temporal arachnoid cyst, which was drained, along with the SDH, which was drained. This was the resolving bleed, and 4 weeks later, the patient presented again with symptoms of worsening right hemiparesis. There was a midline shift as well. You do an angiogram, IC angiogram, you are able to see the impression of the chronic STH. So lateral view of the IC angiogram, you are able to see the ophthalmic artery origin and the meningo-lacrimal anastomosis here. This is that branch. This is that branch. Arrow is not seen. Right. So this is that branch, which is the anastomotic channel going inside the orbit. Lot of orbital brush, but no choroidal blush. Lateral view, again, lot of orbital brush here. This was the branch. So in this case, what you may need to do is either superselectively cannulate distal to this anastomotic channel, or use some method by which you can temporarily block it and then do your embolization. So in this case, a coiling was done of this vessel, and subsequently embolization was done using 200 microns of PVA particles. So this was the pre-operative and the post-operative. And the ICA angiogram showed a well-filling ophthalmic artery. CT 3 months later showed complete regression of the STH. Companion case. So again, 75-year-old male with an underlying hypertension and diabetes, past history of STH, burr hole 1 year ago, posterior circulation stroke under evaluation on DAPT, recurrent STH. You do a right CC angiogram, you are able to appreciate the middle meningeal artery here, but you are not able to appreciate the origin of the ophthalmic artery. Again, here distinctly you are able to identify the choroidal blush from the ECA angiogram. I'll show it to you again. So you take your microcatheter distal to the origin of the vessel. So this was the vessel which was originating, and distal to the vessel we've taken the microcatheter, and subsequently, so this was the vessel which was giving a choroidal blush. Go distal to it, anterior branch and petrous branch, again distal to the bifurcation. Make sure that you are significantly distal. So this was liquid which was used here, and ensure that you are significantly distal to this anastomotic channel. So this is the other way by which you can be sure that you are not embolizing the anastomotic channel which is giving the choroidal blush. So learning pearls, identify the EC ophthalmic collaterals. It is very important. Look for the choroidal blush. Protect the ophthalmic collaterals. Either go super selective as distal as you can, or do a prophylactic coiling of that anastomotic vessel, or use a liquid embolic, again going distally. The next question is, which is better, particles or liquid embolic? In this case, again, debatable. So we use particles most of the times, but then there will be other operators who are comfortable with liquid. So I don't have personal opinion of one versus the other. What about long-term outcome? Particles versus liquid embolic. So this is a small study that we did. Although we favor particles, but then out of the particles, so this was the PVA particle, day 1, day 7, day 3 months and 1 month and 3 months. Almost both the particles, embospheres and PVA behave the same. So the regression in STH is similar with both the particles. You can use either of them, which you think is suitable to you and which is easily available, financially kind of useful. Liquid, don't have personal experience, but obviously liquid also serves the same purpose. Another companion case. IC angiogram, you are able to identify the ophthalmic artery here, there, but you see another branch rising from the ophthalmic artery going along the convexity, and you appreciate this is going along the convexity along the expected course of the middle meningeal artery. So in such cases, at times you may not be able to find the middle meningeal artery originating from the ECA. So this becomes a relative contraindication, I would say, for doing a middle meningeal artery embolization. Learning pearls always diligently look for alternate origin of MMA, especially in those cases where you don't find MMA origin from the EC angiogram. Ophthalmic artery origin precludes chances of embolization unless MMA is hypertrophied arising from the ophthalmic artery and deemed cannulable by the operator. Vertebral angiogram may be done when rarely posterior meningeal artery is dominant and it is seen to supply a major part of the convexal dura. I haven't come across any, but this was just a thought that came to me, so I'm sharing it with you. Last case, recurrent STH. You do an angiogram. Again, middle meningeal, EC angiogram, middle meningeal artery, very well seen. The standard appearance, anterior branch and a posterior branch. You go into the anterior branch, embolize. So this was the good blush, you embolize. You go into the posterior branch, into the Peters branch, again, this was the angiogram. Good blush again, posterior part of the dura, embolize, and this is the control angiogram. We are assured that you've done a reasonably good pruning of the vessels, so your job is done. Now, the next part is, the next question was, in fact, the previous question was discussed by a speaker, whether you need to do bilateral MMA embolizations in a case of ipsilateral or a unilateral SDH. So in this case, so what initially I used to do was do a bilateral angiogram, bilateral embolization, even if there was SDH, but over a period of time I realized it wasn't actually serving any benefit. Why? So this was a case which was interesting. So when I did the left-sided embolization and I went ahead and did the right-sided angiogram, this is what I saw. The right-sided EC angiogram showed clearance of all the vessels except the meningeal artery. This means that there is somehow a stasis achieved in the distal part of the middle meningeal artery branches of the contralateral side due to embolization of the left MMA, which would ultimately can be extrapolated as you have possibly embolized the midline bed and possibly a part of the right-sided paramidline dural bed as well. So actually you don't need to do bilateral embolization. So learning pearl, good embolic penetration can sometimes be judged by taking a contralateral ECA or a middle meningeal angiogram, and bilateral MMA embolization can therefore be avoided in most of the cases. Thank you. I would like to acknowledge my residents, Dr. Anshu Mahajan and Dr. Manisha, for sharing a few cases. Thank you.
Thank you, Dr. Chirag, for the wonderful exposition of your cases, and we'll have some discussion later. Next, we call upon Dr. Vikas Bhatia to deliver his talk on transradial approach to neurointervention.
Good afternoon, everyone. First of all, I would like to thank the organizers for having me here. And my topic is a little deviation from the wonderful presentations which were in this session before. So I'll be talking on transradial access to neurointervention. So if we talk about radial and femoral access, now we have to know that femoral access, it is just like our close friend. It is less irritable artery. We have a long-term understanding with most of the hardware, and it is compatible with the vast literature and our own experience. But if we talk about the radial access, it is more like a new lover which has entered in the life of the interventionist, and it is a little irritable and has a long learning curve, and interventionist has to hold on to this technique with patients in the initial few cases. But trust me, once you get a hold of it, it is beginning of a lifelong romance with this artery. And actually both radial and femoral accesses, they are two roads to the same destination, that is to do the neurointervention. So if you want to understand why still the popularity is not much, because of we still have certain barriers to the radial access, which are in the form of psychological acceptance, learning curve, anatomical factors, hardware issues, and right case selection. So we'll go one by one with that. So regarding psychological acceptance, it is very important that all of us should know that even if we don't want to do a radial first, we might need a radial in many cases. So consider this patient which we did. He's a very obese patient and only on dual antiplatelet. So you really want to avoid a femoral complication in this type of patients. So such are the candidates in which the radial access has clearly shown more benefit. And other benefits are the superficial location, no significant structures in the close proximity, any injury whatsoever is less detrimental, the puncture site complications are less because the artery is easily compressible, mobilization of the patient can be done early, and the hospital stay is reduced. And of course, it is very comfortable to the patient as well as to the resident, because they don't have to do the compression of these patients and they can just put a radial band to these patients. So another case just to show that you may need a radial in many cases. So this is a case of aortic occlusion, as you can see here. And patient also presented with the left MCA thrombus. Left MCA thrombus. So in this case, because the aortic, the femoral access is not there, so we went ahead with radial access and we could do this mechanical thrombectomy. So inevitably, you will have to use radial access in your career, so it is better to get used to this. So next step is the learning curve. So if we talk about the learning curve, it will depend on whether you are using a right radial, a distal radial, or left radial, and your difficulty in initial few cases will be in that order, as seen in our own experience also. For right radial access, we published this paper that how to adapt to the transradial approach in your clinical scenario, and we found that there are various factors, including the aortic factors and the vessel angulation factors, which can influence your radial access. And we found the learning curve, if you are already doing femoral for a long time, it will be around 30 to 35 cases initially, but if you are new to the intervention, then you may need at least 50 to 100 cases before you can do all of the cases with the radial access. So very important when you are starting, that patient preparation is very important. The patient should be made to understand that what we are doing, and you should keep this comfortable cushioning around your the DSA bed, and then you extend the patient's arm and keep it in comfortable position and clean and drape it. Then regarding local anesthesia, give a very small amount of lignocaine, around 0.5 ml. But if you can give a NTG paste or prilocaine ointment 15 to 20 minutes before the procedure, the chances of any pain and thereby the spasm and eventually the radial artery occlusion will be reduced, and the patient will be very comfortable. Pain is one of the reasons which can be avoided by using these simple maneuvers. So cardiologists, they love to do a single wall, but we are very comfortable with doing a double wall, and I would recommend it, because, and always in ultrasound guidance, because chances of any dissection are less whenever you are using a double wall technique. One difference from the femoral is the use of a cocktail, and usually a combination of a heparin and calcium channel blocker and nitroglycerin can be used in these cases. And you should dilute it in 10 ml saline and keep it separately to be inserted after the sheath insertion. But we recently did this study, and it is recently accepted in Indian Journal of Neurosurgery that actually between verapamil plus NTG, you can choose a NTG alone, and we found there was no difference. So actually in patients with negative inotropic or chronotropic effects are suspected, you can actually avoid the calcium channel blocker and use only NTG and heparin in these cases. So then you can just place your sheath and flush and cocktail, and you are good to go for these cases. So distal radial access, again this paper was published from our institute, and we found this to be also very useful and actually comfortable to the patient. Here what we do is that you puncture the deep branch of the radial artery and you do not touch the superficial branch, so the chances of any radial artery occlusions are less. And also because you are puncturing the anatomical snuff box, you are keeping the patient's hand in the neutral position. So in an awake patient, this is a very comfortable position to the patient as compared to the conventional patient when the procedure duration can be more. If we talk about the left radial access, you can just place the hand on the left groin and then you can do your procedure. It will mimic like a left femoral access. And if you do anatomical snuff box puncture here, that will be very useful to the operator as well as the patient. There is no need to go toward the left side of the table. You can easily do it from the right side of the table. So again, we published, this paper is recently accepted, in which we did left radial access in 32 patients, and we found that technical success was in 100% of cases. The only issue is the left ICA catheterization from the left side. As you can see here, there can be a steep angulation when we are going from the left radial to the left ICA. So in the literature, the success rate of left ICA catheterization is very less and reported from 8 to 50%. But we described this technique, which is the reflecting the wire technique, for use of for catheterization of ICA. What we do here, because many times when we are putting the catheter, it tries to slip and fall into the aorta. So what we do is that we reflect the wire from the aorta and take it to the petrous ICA, and then simultaneously we move the catheter into the petrous part. So by using this simple maneuver, again our rate of success of both IC catheterization from the left side was increased. So the next challenge is the anatomical factors. The most important thing with which most of the operators are afraid is that a small radial artery diameter. So that is why there can be limitation of using these wide bore catheters. So consider this case, this is a ruptured aneurysm from the basilar trunk. As in this case, as you can see, the radial diameter was 1.9 mm, but we wanted to use a wrist catheter in this case. So we are currently doing this study. And what we did was, just before putting the sheath, we gave a subcutaneous antigen injection in the 0.5 ml of 500 microgram dilution. So by using this simple maneuver, again you can see the arterial diameter increased from 1.9 to 2.6 mm, and we were able to use a 7F wrist catheter through this, and we were able to perform the coiling, and there was no radial artery occlusion in this patient on follow-up. So again, this study is being conducted, and we found that whether we can use small radial arteries, because in literature more than 1.8 mm arteries are recommended. So in these 20 patients, we were able to, which were less than 1.8 mm in diameter, we were able to do the procedure in all the cases. The only criteria we keep in mind is that the vessel to sheath diameter should be more than 1. So if the arterial diameter is less than 1.5 mm, use a 4F sheath, and in 1.5 to 1.8 mm, you can easily use a 5F sheath. And these patients, two of these patients shows a asymptomatic radial artery occlusion, but still it is a feasible approach which can be used in many of the cases if the femoral is not available or any other contraindication. Another important anatomical factor is presence of these partial loops, which can be seen particularly in the elderly patients. And here nothing to worry, all you have to do is take a road map, and easily you can take your wire under the road map and catheter and do the procedures. But sometimes you can have these complete 360-degree radial loops, which can be challenging, and you can see there was difficulty to cross the 035 wire. So for these we have described our own technique, mother and daughter technique for these type of loops, and it can be done by use of a prograde microcatheter and wire. And here you can see that easily the wire and microcatheter, they were crossing, and once they have crossed, then you can just maintain a gentle pull, and then you can advance your diagnostic and therapeutic catheter. So again, a radial loop is not a contraindication, you just have to be a little gentle in these cases. You may encounter radial artery variants, which in about 1% of cases. So this was one of the patient, and when we were doing the procedure, patient experienced pain, and also I experienced a resistance in passing the long sheath. So in this case, the NTG 200 microgram was given. Also we gave midazolam and reassurance, but still the movement of the catheter was very sluggish. So there was no relief. So carefully we took the catheter out, and you have to be very gentle here, because very fast withdrawal can lead to even avulsion of the radial artery, but we were lucky enough that we were able to take out. So sometimes you can encounter these things, and when we took a check run, you can see it was a brachioradialis variant which has caused this type of problem in this case. So we did a femoral conversion, and this is the check run, the spasm is gone, and you can see this brachioradialis variant. So if you encounter these variants, you just have to be careful with your cocktail and be gentle with the movements, otherwise they are not a contraindication for a radial access. So always take this chakra. This is the normal right and left radial artery. This is the brachioradialis variant, and this is the hypoplastic brachioradialis variant. So it is my advice that whenever you put a sheath, always take a check run of the radial artery. Sometimes you can encounter a radial artery perforation as seen in this case, but again, you don't need to worry. You can just carry on with your procedure. We put a blast long sheath, and because of the wide diameter of this blast sheath, there was a tamponade effect, and we could do our coiling case comfortably, and check run post procedure. You can see that the perforation has sealed off. So just use a wide bore catheter, and small perforations does not matter in the radial artery. You can have aortic tortuosity and hardware issues in these cases, which can be problem. So use a power of tower in these cases, that is use a long sheath, use a guiding catheter, and if required a distal access catheter. Particularly if the patient have a tortuous aortic arch, in these cases this has to be done. So again you can see a tortuous artery and the catheter tendency to fall down, but if you use a long sheath here, you can see that everything will get straightened, and you will be very comfortable in doing all of your procedures. So again a case, you can see a tortuous subclavian artery with the difficult origin of the vertebral artery. So these cases may require sometimes different catheters. So here we used a Ravi MG catheter to hook this artery, and over that catheter we could place our guiding catheter and could do this coiling in this case. So sometimes you may need these backup catheters, but most of the time you will be comfortable. So one of the very important issue is the hardware for the radial, but luckily now the radial specific catheters have come, which are providing new hope, and the basic principle in all of them is that there will be a good proximal support and very good distal trackability. So this is a 58-year female, and you can see that incidentally there was the patient had headache but no SH, and incidentally on MRI there was presence of this right PCA dissecting aneurysm, and CT angio was also done to see the arteries, and you can see this dissecting aneurysm here. So we took the patient for DSA, and you can see there is the occlusion of this right subclavian as well as the right CCA was occluded in this patient, and everything was taken care from the left side. And from the vertebral run, the diagnostic was done from the femoral side. You can see that there was a subclavian steel in this patient, and also note that how tortuous these vertebral arteries. So we have two situations. The vertebral arteries are very tortuous, and also they have become precious because of this vertebral steel phenomena. But still, in this case, we took a Sophia 6F catheter, which provides great trackability in these cases, and we were able to take it quite distally and perform our flow diversion with the coil in this case. And on follow-up, there was no radial artery occlusion. So even in these precious arteries, radial access can be done by use of new catheters. Another case, you can see this subclavian hump here, tortuosity, which can be hindrance to the radial access, and also there was a difficult origin of the vertebral artery. So in this case, again we had to take a Ravi MG catheter, and over that we took our, this is the second new catheter, which is the Armadillo catheter, which provides great support as well as tracking mode in these cases. And again we were able to do a flow diversion in this recurrent aneurysm case. Another case, you can see this steep angulation between the ICA and the subclavian, and when you do it without a support, there will be a tendency for everything to fall down into the aorta. But we use the BMX 81 in this case, and which provides a greater ID, and you can see that it is wonderfully tracking over this area and provides the support proximally, and we were able to do this MCA coiling in this case. This image here can show that how a wonderful support proximally as well as distal trackability is provided by these catheters. So we have now wonderful catheters which can be used for radial access. So finally, right case selection. So after discussing all this, whether we should go for a radial first, still there are anatomical factors or hardware factors. So I will just say that as of now we should use a radial wise approach, and it should be a case wise discussion, because there may be situations which are radial approach preferable and radial approach limitations. So radial preferable as of now are posterior circulation pathologies, young patient, less tortuous subclavian arteries, bovine or close origin of left CCA, femoral access is not possible, but with increased experience most of the cases can be done. So this is a radial preferable case, 24-year female presented with stroke, and you can see this basilar occlusion here. So comfortably you can go with the right radial access, and the Sophia catheter was taken here, and over a 6F short sheath, and We also used a stent retriever in this case, and this was the final result. There was a little clot migration, but for posterior circulation strokes, you can go without thinking for radial access. There will not be much difference than the femoral access. Another case of a ruptured left pica aneurysm. So for the left vertebral pathologies, it is very easy to go with the left radial approach and very comfortable also. So again, we use a 6F radial sheath, and you can see a neuron catheter going here comfortably, and we were able to do this coiling in this case. Another case, 60-year-old male, and we can see this grade 4 SAH in this case, and this ACOM aneurysm. So while doing a diagnostic femoral previously, we noted that there was an aortic tortuosity, and you can see that how tortuous everything is here, which can be difficult with the femoral also. But we also noted that it is a bovine arch which was present, and when there is a bovine arch, it is very easy to go by radial approach. You don't even need to form a Simon's curve here, and directly the wire will enter into the left CCA and provide adequate support, and you can go ahead, and the coiling was done here with excellent support to the microcatheter, and we did an unassisted coiling in this case. So another case, 66-year female with rupture, and you can see this vertebrobasilar junction aneurysm. This patient also had the same issue. You can see the vertebral tortuosity and subclavian steel. The radial diameter was also small, and so that means again that this vertebral artery and the radial artery are precious, but still we were able to take our radial access in this case and could do coiling in this case with very great support. So in these posterior circulation pathologies, radial access is actually very good for as compared to the femoral access. So this was the final run. So if we can have some limitation cases in which radial approach may be less preferable. So in this case, when we were doing the diagnostic angiograph, repeatedly the catheter was going into the descending aorta. So wherever you suspect that you are not able to form a Simon's curve, it is basically because you are dealing with the aberrant subclavian artery, which was seen in this case. So radial is less preferable in this case. Again, as I told, you can have these less stable guiding catheters, but can be by taking a power of tower or using a long sheath and guider, you can easily mitigate this problem. For tortuous subclavian, again, if you use a long sheath, you can do most of your cases. But if you find that there is a lot of tortuosity and lot of traction on the radial artery, it is better to go to the femoral, our old friend. So with this, I would like to conclude here that radial access is an equally competent access route for endovascular procedures, and learning curve and training of the interventionist and improved hardware is all needed for greater acceptance. So this is one of my painting where I want to show my love for painting as well as for the right radial access. Thank you very much.
Great. Thank you very much for those great talks. We'll open it up now for maybe a discussion and questions. We do have one question that was entered in on our platform from Dr. Reddy. It was addressing, do we do, I think, the MMA embolizations under local or general anesthesia, and also vasospasm. If we use the liquid embolic agents, there can be more irritation. The patient can experience some pain. So, what is, a concoction maybe to help minimize that? Do we have any? I see Anish is up. Do you want to make a comment? Is there a mic? Can we grab a mic? Great.
Yeah, in our practice, we do all cases under local if the patient is cooperative. We take the patient under conscious sedation or general anesthesia only if there's a neurological compromise, the GCS is low, post-procedure, only then do we take the patient under general. Otherwise, all cases under local. And vasospasm with regard to NBCA, maybe others, we have done all our cases with particles. We do not use, and as I've said, once we place our catheter, we give a liberal infusion of heparin and nimodipine in the diagnostic catheter, and that generally alleviates any vasospasm in the distal ECA.
That's a good question actually. If you are doing under local anesthesia and you put your diagnostic catheter in the MMA or in the ECA, there may be a spasm. In that condition, yes, we have also noticed if you give nimodipine, patient becomes irritable. It causes severe pain. If you are giving nimodipine into the ECA branches, so when patient is not sedated, not paralyzed, it causes severe pain. So we avoid nimodipine. If there is a spasm, we give NTG.
NTG if there is spasm, but in the infusion nimodipine,
with infusion
no issues.
also, if spasm develops, better to give NTG rather
yes.
than
If
nimodipine.
there is spasm, we give NTG.
And once you give nimodipine, patient becomes restless and he won't cooperate, you cannot finish the procedure.
We had excellent talks by all the speakers. Just a couple of comments. One is about anatomy of middle meningeal artery. We had a lot of discussion about normal anatomy and its variants. Just before taking a patient for MMA embolization, it is better to see the CT scan which was done earlier and look for foramen spinosum. If you don't see the foramen spinosum, it is almost 100% sure that that side middle meningeal artery anatomy is not correct. So something is wrong there. So you have to bear in mind when you are doing the angiogram. Second thing is about the referrals to the neurosurgeons talk by Dr. Sharad. As a neurosurgeon, I would definitely say that chronic subdural hematoma surgery is not a simple one. In my last 3 decades of experience, I would say that I had seen mortalities, severe morbidities like neurological deficits, where a subdural catheter poking the brain causing ICH, subdural turning into empyema, medically refractory seizures, and tension pneumocephalus, and inadequate drainage because of the thick membranes and other things. So all sorts of things are there. But I would say that now with institution setup practice where you have internal radiologists available or neurologists and neurosurgeons who are doing endovascular procedures, in the last 2 years we have referred many patients for MMA embolization and they have done successfully well. So I'm sure even in Chennai and in all the neurosurgical conferences, you will find one paper or other about this MMA being discussed. So what I'm trying to say is the awareness is coming up. The referrals also will come up depending on the availability of the persons in your setup and area. So I'm sure definitely this will take up and will come up in a big way.
Yeah, just to conclude, just a quick this thing on embolization of axillary meningeal. I think before we embolize, it's better to do a DynaCT to confirm that it's actually supplying the dura. In many cases, from the distal IMA, the deep temporal arteries may be there, which may supply the which is supplying the muscles, mastical muscles basically, which may be misinterpreted as abnormal dural blush. So in such cases, it's better to do a DynaCT to confirm and before embolizing.
One last comment, Dr. Vikas. Excellent talk. So I liked your last comment, we are not neuroradialist or neurofemoralist. We should be patient-centric. If the femoral is best for the patient, let's go for the femoral. No, I prefer radial, so I should go for radial first. That should not be the approach. That's what I liked in his concluding slide. And as you said, if posterior circulation vertebral arteries, bovine, it's a cakewalk. But in other conditions, I think femoral, because there are papers which shows asymptomatic diffusion restrictions. If you do transradial versus transfemoral, you get more of hits if you do a transradial rather than transfemoral. Thank you. Any take on that?
No. Any technique comes in any field, patient is always first. No other option. Patient first.
We definitely see a trend, obviously, going towards radial, and I think it's a great platform. I mean, certainly for diagnostic catheter work in the U.S., most practices have gone to using radial as the mainstay. Certainly for treatment, I think, as you pointed out nicely, with the nicer catheter technology for support, we're going more and more on the treatment phase for aneurysm, stroke, et cetera, to exploring radial. It's still, I think, a work in progress. And like you pointed out, I mean, it's good to understand the different pitfalls that can kind of happen and maybe what candidates might not be good candidates for radial. But yeah, it's definitely, I think, the migration of the way our access is going for sure. So that was very nice talk.
Thank you very much.
So one last question before you conclude this session. Should we do MMA embolization in chronic SDH and moyamoya disease? So basically we have to see if your MMA supplies the pile collaterals. If it supplies the part of brain parenchyma, better to avoid it. Because if you do, patient will develop a stroke. So if in moyamoya, if you find MMA is collateralizing the ACA or MCA branches, better to avoid the embolization.
Yeah, I agree. I think you don't want to, cut off an important collateral pathway, and so that would be probably not a good candidate. Again, I think on the spectrum, I agree. I think chronic subdural hematoma embolization is probably going to be our #1 procedure in about 5 years' time. So it's we showed that there's going to be a very big patient population, and it's a very safe and efficacious procedure, as we're finding out. But you certainly do want to err on the side of safety. I mean, I think when you have any kind of question about dangerous anastomoses or whether I can accomplish the treatment safely, it's very like this question about cutting off a potential source in a moya for how someone is collateralizing. I think not a good candidate. Don't do your embolization on that patient.
We'll conclude the session.
Yeah, so I think are we ready to move on? It looks like we've got a larger room now, so I think thank you for everyone's participation. Those were fantastic talks, and enjoy the rest of your sessions. Thank you.
Thank you so very much. A big round of applause for our fabulous speakers, fabulous moderator, superb sessions. The best of the best are joining us for ISVIR 2026. Ladies and gentlemen, are you having a great time learning? Yes? Yeah, I'm going to take that as a yes. But most importantly, there's something amazing here that I'm witnessing. We live in a very distracted world, and it's wonderful to see all of you use your phones, take those videos, and to be fully invested in it. It's a wonderful feeling indeed. I request you all to please take your seats and settle down. I do see the community coming together. I do see all of you interacting, but we're going to witness something fabulous on the stage. We are going to be witnessing the Penumbra Lightning Bolt launch right now on the stage. So I urge you to please take your seats and settle down quickly. Can I please request you to take your seats very quickly so we can continue the proceedings of the day, ladies and gentlemen? I invite Mr. Shyam Kupuratnam, the country head of Penumbra, to do the honors and lead the session forward. Ladies and gentlemen, with a nice big round of applause, can we welcome Mr. Shyam onto the stage? Can we do that? Yes, we can. That's wonderful.
Thank you for that great introduction. So I am Shyam Kupuratnam. I'm with Penumbra. So I really want to thank the organizers of ISVR and the entire IR community for our great partnership. Penumbra, we have been thankful, we have been honored to work with the entire IR community in India and across the globe to help patients with our innovative device. Talking about the innovation, so we, as Penumbra, we are very focused on thrombus aspiration. So in the vascular side for treating PE, DVT, and ALI, we had a lightning flash, and this great coincidence, we are lucky, always we are lucky with ISVR. So 2 years ago in Jaipur, we launched our flash, and this year, luckily, we got the approval for Bolt exactly 12 days ago. So we are honored to launch our Bolt family of products at this session here. So to launch this product, so I would like to give a brief introduction about our product. So here is a video about the Bolt product. As we are playing the video, I would like to invite our IR community friends, Dr. Girish, Dr. Shioren, and all our IR community friends to come on the stage. I'm so happy to announce we got the device imported on Saturday afternoon at 12 o'clock, and Dr. Shioren, he had a case, and then he did our first Bolt 12 case on this Saturday. So even though we are launching now, it's been used. Dr. Shioren, please come on the stage. The entire community, please come on and help us. Dr. Cherian, please. Dr. Girish, please. I want everyone who Dr. Lijesh Kumar, please.
Introducing Lightning Bolt, the latest computer-assisted vacuum thrombectomy device from Penumbra. Drawing power from the Penumbra engine, Lightning Bolt is the first of its kind to offer Bolt mode, or modulated aspiration, designed to rapidly remove thrombus and restore flow. Setup is simple. Connecting to a non-pressurized saline bag, Lightning Bolt is able to vent off the high-powered vacuum to adjust clot engagement pressures intraprocedurally. Lightning Bolt's control panel intuitively guides you through setup. Priming the system to make a wet-to-wet connection enables a full fluid column to be established between the catheter tip and tubing, which is important to maximize the effectiveness of clot modulation. Lightning Bolt is paired with Penumbra's 7 French catheter. The catheter's hypotube design maximizes the inner diameter similar to the inner diameter of an 8 French catheter while maintaining a low profile. Compared to continuous aspiration alone, Lightning Bolt overcomes friction that builds at the catheter tip. Bolt Mode's ability to modulate aspiration is designed to accelerate clot removal. Let's dive into the mechanics of the next generation of computer-assisted vacuum thrombectomy. Lightning Bolt's dual clot detection uses pressure differential and flow-based algorithms designed for quicker clot detection. In a patent vessel, the system samples and seeks thrombus to reduce potential blood loss. Let's slow down the footage to better see what happens when clot is detected. When engaged in thrombus, the algorithms will intuitively initiate Bolt Mode, modulating between full aspiration and ambient pressure to break the friction. Let's rewind and watch again in slow motion. The Penumbra engine provides near absolute vacuum of negative 29 inches of mercury. Lightning Bolt uses the saline to vent off the high-powered vacuum and rapidly switch to ambient pressure, represented here as positive 29 inches of mercury. Rapidly alternating between the engine's vacuum and ambient pressure, Bolt Mode hits the thrombus repetitively with the full force of vacuum, fatiguing the fibers of more organized clot. These interprocedural pressure changes are designed to more rapidly remove clot than continuous aspiration alone. In real time, Bolt Mode will modulate up to 12 times per second. Lightning Bolt is designed for frontline endovascular thrombus removal as the most powerful and advanced arterial thrombectomy system to date, and the latest in computer-assisted vacuum thrombectomy from Penumbra.
This is a game changer. We recently launched this in the US a year ago. So I'm lucky to have this product launched immediately in India. So this is the latest technology that is available in Europe and US now. Within the last 6-9 months, we were able to bring it to India. So thank you very much. Now to celebrate this, I would like to invite everyone to come and we'll cut a cake and then we want your best wishes and luck for us. And looking forward to saving a lot of lives with these new product launches. Thank you. I invite Dr. Sheridan to talk few. He just did the first case a couple of days ago, so if he can share his experience, that would be great.
Thank you, Shyam, for the opportunity. So Bolt is nothing different. The catheter is same. The aspiration system has got smarter and better. So what they claim is it's 3 times faster than the regular one. And honestly it is, especially for the subacute and kind of little fibrotic chronic stuff because it has that modulation aspiration system. It breaks up at the tip of the catheter. So as of now, we have done 3 cases and the results were good. And it's faster with smart intelligence, so less aspiration of blood. So thank you, Sham, and best wishes.
Thank you, guys. And we have this device in our booth. We have a hands-on training session as well. So please reach out to us. We can answer all your questions and which product to use where. So with that said, let's play the second video. And thank you, guys, everyone.
Many congratulations on the successful launch, and thank you so very much. A sweet moment indeed at the ISVIR 2026. Ladies and gentlemen, next up, we're going to be doing a session, and this is the industry talking to each and every one of you. They want to hear from you, they want to share their concerns, and that's exactly what we're going to do. And this session will be led by Dr. Lennon J. D'Souza. He's going to be the one leading the session forward. And just a humble request, if there are other members from the industry who are not part of this session, we just want to remind you that your lunch for you, for your team members, is served elsewhere. So just keep that in mind. And may I quickly request all the dignitaries to please take your seats. This is a very, very important session, and when it begins, we're going to close all the doors. So please quickly settle down, take your seats. A lunch-on symposium, first of its kind in 26 years, ladies and gentlemen, so indeed it's unique.
Good afternoon, everyone. Do I have everyone's attention? Hi, everyone. I'm Dr. Lennon D'Souza. I'm an associate professor of interventional radiology at Father Muller Medical College Hospital in Mangalore. And I'm a current executive committee member of ISVIR for the year 24 to 25. And here we have our first ever lunch symposium on what we thought is going to be. Can we have a round of applause, please? Yes, we're going to have our first ever lunch symposium on what we thought is a very, very important topic. And this is basically compliance without compromise. So this is basically a joint discussion and a joint dialogue of our ISVR and interventional radiology and our EC team with the industry. I was supposed to be joined by Dr. Pushpinder Singh Kera, but unfortunately his flight got cancelled. So I'll be leading us here. And I would also like to invite our EC members to come and occupy the sofas right in front, as well as Dr. Rohit Nair, Dr. Manish Yadav, Dr. Jinish, and other senior IR faculties also who would like to partake in the discussion. I would love to have you up in front. From the industry, I would like to call respected members of the industry, starting with our number one sponsor, Involution. I would like to invite Mr. Gaurav Agarwal and representatives. Can we have a big round of applause for Mr. Gaurav Agarwal and the other representatives of Involution? Please take a seat on the dais. From BD, I would like to call Mr. Shashi Bhushan Sahu. Mr. Shashi Bhushan Sahu. Or any other representative from BD, please come forward. Please come forward. From Merrill, Mr. Dev Shah, or any other representative from Merrill, please come forward. Yes, I can see them there. Please come. From Penumbra, Mr. Shyam. From Boston, Mr. Abhinav, Mr. Nitin Zadbuke, please come forward. From Girbe, can I have Durgesh and Vikas? And from Termo, could we have Rajesh, please, from Termo? Could I have some more mics on stage, please? Could I have some more mics on stage? So ladies and gentlemen, as we know, ISVIR is getting bigger every year. It's been 26 years and it's getting larger and bigger. We have more and more members joining ISVR, as well as we have more and more participation from industry as well. And we see this collaboration going forward with the years to come and getting even bigger and better. So that's why we thought that this might be the appropriate year to ask you all also what is your perspective from what you expect from us, and some of our concerns also. And I'm going to keep it like an open house. So all of you all who are having lunch also can anytime feel free to, if you want to ask a question, you can please stand up or raise your hands, and we'll pass you the mics as well so that you all can ask questions as well. And let's make this very, very interactive. So I'd like to start with Mr. Gaurav Agarwal. Yeah, so I think this is the first time Involution is participating with ISVIR, and as we know, if all of us turn our heads, those of us who are facing the stage, if we turn our heads to the left there, you can see that currently Involution is #1 in sales of cath labs, in refurbished machines, #1 in selling coronary balloons in India and stents, and probably #3 in selling stents as well. So let me just ask you, what, as part of the industry, what is your expectation from a medical society like ISVIR?
Thank you very much for the warm introduction and for calling us on the dais. This is the first time that we've made our debut at ISVIR. Extremely glad to be part of this industry. Just a slice of history. I started my career nearly 30 years ago as a sales rep with Boston Scientific, as a therapy specialist for stroke management, selling GDC coils. So it's wonderful to be back in the community after 30 years. As you mentioned, Involution last year became the #1 selling cath lab in the country, beating the giants, some very, very large, well-settled, entrenched companies. And we now have 530 installation of our cath labs across the country, and about 18 cath labs outside India. And this year, we are looking at getting MDSAP approved, which gives us access to markets like Brazil, Japan, Australia, etc., and US FDA approval later this year. On the stent side, we started our journey pretty late in 2023. We sell over 10,000 stents a month now across the country, every month. We are likely to get CE mark. Balloon, we've been #1 for a long time. Our expectation from this meeting really is to explore avenues of how we can become a more significant player, providing solutions
in the radiology side, so we see ourselves as a solution provider, not as a product provider. And we'd love to explore synergies of products that we can bring both on the imaging and the intervention side.
Absolutely. So I think when we think of involution, we always think of how they are really revolutionizing what is the more affordable cath lab currently in India, with the initiative of Make in India. And I think definitely there are some challenges and there are some roads ahead that involution has to take, because I think initially the catering was towards cardiology, and now I think the avenue is opening more towards interventional radiology. And with our numbers increasing, I think definitely this is going to be a very synergistic combination.
So I think for the first time in Asia, a manufacturer has launched a dedicated DSA lab with rotational angiography and 3D reconstruction with a large panel, 30 by 30 panel, which is our premier NV30 right across the room. We've demonstrated a live cath lab. I would urge all members of the radiology and neurointerventional community to please visit us, get to play with the cath lab, see the loops. We already have 2 installations of this machine, and we look forward to very vibrant discussions over the next couple of days.
I would now like to go to Durgesh and our representative from Gurbe. So I'd like to ask you, what are your most common concerns or barriers that you face when it comes to deciding to sponsor any an ISVR event or any activity?
So first of all, Dr. Lennon, thanks a lot for giving this opportunity. I would say the barrier which was there, which I think you as well as the recent ISVR committee, they have actually removed that barrier. I'm very sure all my colleagues as well as me, this would be the first time we would be sitting on a dais. Generally, we always are either out of, thank you. So either out of the hall or maybe sitting over there. I think this is the first time we have got, I would say, the opportunity to sit on the dais and discuss this with you. So I think this is one of the fabulous things which you guys have done it. And I would say you may continue this. You may understand from the industry what exactly they want. Initially, I think before this ISVR, Dr. Deepa and the team, they had also kept a meeting with the industry people to understand what exactly they wanted, what exactly they needed. And the best part was that I think most of the things, I think they have incorporated. So again, I would like to thank you for this as well as the entire ISVR committee. Thanks for this. Thank you.
So Mr. Shyam, I'll move on to you next. So what type of visibility or engagement do sponsors value the most? Is it just brand placement, interactions, education, collaboration, leads? What do you think is the direction of this?
Thanks. That's a great question. Again, I want to sound what my colleague here said. This is the first time ever, I think, we are sitting on the opposite side. So, but thank you for that, for the organizers, the ISPR being proactive or forward thinking. So what are the things that we expect? This is a nice way of collaborating between the IR community and the industry. So what we expect out of this is the education piece is the key, awareness piece, and how we can collaborate, because we go into we learn a lot of new things from the podium speakers and from across the world. So the main couple of things that I like that has helped us in the past and it's going to help us is this education piece, and also not only the branding, but again bringing the awareness about the therapy or the devices. So these are the things that I would highlight.
Thank you. Abhinav, if you don't mind, what do you think ISVR should we move towards more structured platinum, gold, silver tires, or flexible modular sponsorship options, and why?
Thank you, Dr. Lennon. And I think thanks a lot for giving us the opportunity. As some of my colleagues rightly mentioned, that we feel very honored and privileged to be on dais and sharing our views, what we as industry have to suggest to the ISVIR. So I'll just take a little backseat and let me play the devil's advocate over here, because everyone wants to listen to the nice feedback, right? So let me focus on some of the real challenges we as industry face every year. So the first feedback I would like to give that please, if possible, please refrain from keeping ISVR at least in the first 2 weeks or first 15 days of the in January, because as multinational, I face a lot of difficulties in collaborating, getting the approvals from my APAC or international, approvers, because they take Christmas and New Year's leaves very seriously. They are not like Indians, like, if I am sitting on my holiday, I'll still open my laptop and try to do some of the work, but they take it very seriously. So it becomes very difficult for me to get the approvals. So if ISVR is kept after 15th of January, it makes my job easier to get the approvals, and at the same time, we would be able to give the sponsorship amount, the sponsorship amount on time. So it feels very awkward sometimes to say no, that we are running late, in crediting the amount and all. So this is the biggest problem which we face as an industry. And secondly, that I would like to recommend that whenever you are structuring the conference, please be mindful of the recent guidelines by the Department of Pharmaceutical, UCP, MPMD, which we all know, right? There are a lot of restrictions which we as industries is facing, and although it is only for industry, not for the medical societies, but it would be easier for us also to execute some of the things and make the conference, a better experience for all the delegates and all the doctors and all the fellows, if some of the recommendations are also kept in mind. And what are those recommendations? I think we can talk offline about it.
You can talk about it.
So
The
there are a
stage
lot
is
of
yours.
restrictions. So I just want to recommend that maybe we can have a session by a lawyer where he can decode the code for you to understand that what are the restrictions for industry, right? So that it can be better incorporated by the societies whenever they are, because whenever we say no, sometimes it is taken, little in a wrong way. So it is equally important to understand the code also, that what are the legal implications for us as an industry. So I think I would like to recommend that maybe we can have a session on this particular UCMPMD for doctors to better understand the code, because there are a lot of penalty, and when I'm saying that there are serious penalties, there are serious penalties, sir.
I understand.
And as far as your question is concerned, sorry to take this in the last. As far as the tiers are concerned, there is no challenge we have faced so far. I think the organizing committee of last year's, this year, have been so flexible in taking care of our request, and we have been fairly okay with that. So I think that's not a problem. So thanks.
Okay. Do you see any future with more flexible? I think we have been relatively flexible.
I think nobody has been very adamant about the sponsorship. I'm talking about the ISVR. So we have always seen the flexibility from your side. So
And we're always very appreciative of Boston Scientific. I think we all always say that Boston Scientific is probably a IR first company.
Thank you, sir. Thanks a lot. I remember, since he clapped, so I remember we had a serious discussions about some of the expenses which we could, save in last year's ISVR on something which we found was not valuable for the overall experience of the conference. So we are happy to partner. We are happy to help you advance the latest education. So Boston Scientific has always been the first one to support ISVR. So we will always be there. So
Thank you. Since Dr. Rohit Nair clapped, I'll ask you the next question. So how important is what we call ROI transparency? So for companies to sponsor, how important it is for their return of investment, and should ISVR, what do you, because you're not an EC member, so I thought we should get a neutral opinion. Should we provide post-event analytics like engagement metrics or delegate interaction reports?
First I have to, I'm feeling a bit jealous because I'm, each time from hour 0, I've been comparing what the Kerala ISVR was before to what teams. We are sort of neck and neck now, but this is sort of taken to a different level. So congratulations to the executive committee and the organizers for having this session. See, for the companies, talking to the company side, we had a few chats, as we said, after the conference. I took a lot of feedback, which is informal feedback. So they have got this attributable revenue and the total investment. So it's very important for them to know what is the return of investment. That could be in the way of how much the people have interacted with them, how many leads they have got, how many leads to conversion, but that is something which a company can give. See, it's a continuous process. I think as an ISVR, we should be absolutely transparent with ROI. We should give them, we should know and share it among all communities, along with the industry, as to what were the footfalls, and how much was the engagement matrix, how many people visited them, and then over the few months, the company has told back, the CVF got so and so. See, for example, now Involution has got this new cath lab coming up, which hospital has then taken over that lead. So, so it is very important that you have that return of investment in transparency. So I can tell you for a fact, many companies, obviously I speak to Boston, Penumbra and all, and after the Kerala ISVR, I'm pretty sure you have seen an increase in the revenue in Kerala. So I think it should be measured in some way and should be shared. And it's fair to them. Because I think without the industry, it's very difficult to conduct these conferences at such a level.
Also, sir, I would like to add, so whenever a multinational company like ours, partners with you, so we don't look at the ROI, but we look at the VOI, value on investment. So for us, the value is how many new doctors are getting trained, right? How many new physicians are attending the sessions inside. I have seen some of the conferences where the speaker is speaking and there are hardly 4 or 5 physicians are sitting. So it reflects bad on our part, right? So we'll always look at the value, not on, business will keep on happening. But we look at the overall value, that how many new physicians are getting trained, what value we as industry is bringing to the conference, be it the stall, be it some of the workshops, be it some of the sponsored sessions. So that is something which we really focus on rather than the business.
I think when it comes to all our industry sponsors, most of them have kept value forward. And we know that with some amount of workshops that happen here and the interactions that happen here, and even this lunch symposium where we are giving you, it's basically to bring all of them in front of you and for everyone to understand how important this relationship is. Durgesh wants to add something?
This lunch symposium has been very, very one of the best decisions by ISVR, because I always thought that Indian food is not, our conferences are not, can't replicate those bento system which we see in Asia Pacific and other conferences, but it has proved, to be something which was there. It has proved it as a wrong thing, and I think this can bring people inside the room. So I think that's a good decision by the
Yeah, and I think that credit goes to Dr. Deepashri. It was her idea completely to bring this lunch symposium, just replicating a system that is there abroad and also giving an avenue for everyone to be there in the hall at the same time. Yes, Durgesh?
So in addition to what Abhinav has said, apart from ROI as well as the VOI, the one thing which I would say every industry which actually looks into, but hardly anyone talks about it, is the treatment the industry people which they get. Though I have worked into maybe a cardiology, orthopedic, urology, I should say that the treatment which we get in the ISVR, it's flawless and it's like one of the best treatment what we get.
Can we have a big round of applause?
Yeah, the inclusiveness which the ISVR committee as well as the entire intervention radiology fraternity which they do it with the industry, it doesn't seems like, okay, he's a doctor, he's from the company. So there is no even a single penny difference which we find. To be very frank, and I'm being very frank enough, when you called us, when Dr. Deepashri ma'am, when she called us for this industry meeting, I had a feeling that only maybe 5 or 6 would be there. Only the moderator would be there and maybe only 1 or 2 people would be sitting. But such a hall, such a houseful hall, to be very frank, At least I was not expecting it. And I should thank the entire IR fraternity as well as the committee to have this lunch symposium during this time to have the entire fraternity over here.
Yeah,
so thank you. Thank you very much.
I would like to add that almost everybody was very reluctant to come on stage. And now I'm seeing everyone who was reluctant is now finally on stage. Yes, sir.
Yeah. Hi, my name is Neeraj. I'm representing Teremo.
Correct.
First of all, I would like to thank you all for your support and guidance that you are giving us day in, day out. I have one or two concern, or I would say comment that I wanted to highlight on this forum.
So I mean, that was my next question to you actually.
Oh, okay.
So my question to you was, how can ISVR improve the on-ground exhibitor experience? So you can answer this question and also you can address your concern.
Okay, thank you. So as per all-ground experience is concerned right now, I'm seeing it is a flawless experience that we are getting right now. Improvement as per my understanding, I don't think right now, because the place you have selected is one of the beautiful places in India. The spread of conference from like, even you're talking about your health, maybe we can do the stepathon, walk, because one heritage hall is I think 400 meters from here and one is 200 meters. You can like very well balance the health paradigm shift also. So that way you are managing it well, and moreover it's well coordinated, well executed, I believe. And I'm happy. As industry partner, I think we are happy for the treatment that we are getting.
Yeah. What about your concerns? You said you mentioned you
the
had some
concern is something. It's not exactly the concern. Being a MNC company, we are little bit sometimes stuck with Make in India. So majority of the product are beautiful product. Most of the MNC companies are having. But because of MNC company tag, we can't supply the product which is not produced in India more than 50% of its content, right? So that way we need to together look into that fact that we need to have some kind of relaxation on some product which is very, although, so we have relaxation when there is a product which is only produced by MNCs. But if it is a product which is being produced by MNCs as well as Indian company as well, then there is no priority for any MNC companies are there in current guideline.
But let me stop you there, because I think that's more of a governmental issue than something that we can control.
Yeah.
So I think when most of us, I think sitting in this hall here, I think everyone who faces y'all can say safely that the first wire we used is a Teremo.
Teremo wire, yes.
Okay, is the Radifocus glide
Teremo,
wire,
yes.
and the first micro catheter most of us used is a Prograde. And most of us have our comfort with it, although now we have more toys to play.
Yeah.
But I think that way the whole community is with you. And maybe governmental restrictions is when we get maybe a little stronger is something that we can advocate to governments as well.
You can support us in this journey because
Certainly.
Yeah.
So we are working very strongly on scheme related problems, and also these things on how we can collaborate more with industry.
Thank you.
Just wanted to add a couple of points.
My next question is to you. So as we know from the time Merrill has walked in, Merrill has had no problem with sponsorships. Merrill has had no problem with giving us all the products in the world to try out on. Can we have a big round of applause for Merrill? One of the strongest companies to enter and help us innovate in interventional radiology. So my question to you all is, how can you all collaborate in educations, in fellowships, training programs and research without biasing the content? So, it should be unbiased, but how can you collaborate in this manner?
Hello and namaskar to everyone. Myself, Sudeep Khanna, I'm representing Merrill Life Science. Just to answer your queries, that we have Merrill Academies, which are spread across pan-India, not only at Vapi, Gujarat, but at Delhi and at Kochi, and in foreign lands also. So we encourage education. We encourage what all modern technologies are there that has to be practiced. So we have all set of infrastructure, all set of products, all set of manufacturing that is being lined up. We want to openly do collaboration with ISVR in terms of enhancing the training what is required. So there is no doubt and there is no second thought how we can do. Everything is set in terms of infrastructure, in terms of what all things are required. We just require your collaboration in terms of how it has to be implemented. At the end, it will be beneficial to the patient.
Correct. So I see even Termo has opened a beautiful skill lab in Delhi as
Thermo
well.
India Skill Lab. Recently, we placed our cath lab over there, which is Mazdu 1, and we welcome you all for doing knowledge upgrade with us in Thermo India Skill Lab.
So I think even things like how Gerbe has kept a hands-on glue session with the glue and lipidol on how to use it. All of this is how you can basically help us to, advocate more training and to ensure ultimately that our patients get the safest outcomes. And at the same time, using products is a consequence of doing good procedures. I do believe. Dr. Arun, a few comments from you?
Yeah. So we being a part of ISPR understand your problems related to the sponsorship, what can be done. But I just want to highlight also one thing that at least 5 companies in the Kerala conference has not given the sponsorship what they have promised. And has happened over and over years, many a times. So just please take care that ISWR is still very gentle in spite of the agreement. The money has not reached us, but still have not taken any action. Please do take care.
So I do think that, commitments, of course, important. And this is what keeps this running and what is going to drive participation and work and everything else. So, Mr. Shyam, I just want to ask you, what would a truly industry-friendly, yet an academically strong ISVR look like 5 years from now?
So 5 years from now, so there'll be a lot of simulations and a lot of hands-on workshops. It will move towards in that area. So instead of didactic sessions where the podium speaking, so that will become more. Yes, it will be there, but more it will go on to. Even this morning, I was in the stroke workshop. It was, even though at 8 a.m. in the morning, it was very well attended. So I think that's where this partnership will go next. This is a nice way to, everyone is here. So I think simulation and the hands-on training, so those things will become part of, a lot of companies will start keeping workshops within their booth. That's what I've seen in the Western world also. Nowadays it's happening. So more hands-on, that's what I'm envisioning 2 to 5 years from now.
And maybe we can see the integration of AI and robotics 5 years down the line, because today our rapidly increasing economy is heavily investing in AI and robotics and technology. The speed at which the technology is growing, maybe healthcare is a profession where we can see a lot of integration of these technologies upcoming in the next 5 years down the line. And I think interventional radiology is one of the fastest evolving field currently. So,
yeah, so
definitely
interventional radiology is as old as interventional cardiology. Actually older, but everyone, whenever you say you're an interventional radiologist, they say, oh, that's a new branch. So this is something that we have to break, and of course get out of this, and we are going to be the front runners in time to come. Dr. Manish Yadav, do you have something to say?
Yeah. As a ISVR community and as an industry point of view, I think what is required is, as you all mentioned, that you want more and more people to learn about your products, more and more people to understand these procedures and go ahead. I think that's where this having an industry-driven focused programs or focused procedure-related conferences where ISVR can collaborate with the industry and have just 1 day or 2 day programs that will help to bring in the young people to the program, and not only have big conferences, because probably the learning gets little diluted with the big conference. To have a very focused on a very disease-based or a procedure-based program that's where we want the industry and the ISVR community to move forward to.
Dr. Lennon, can I add to what Mr. Shyam just answered to your question? What I feel that what ISVR should be exploring in next 5 years is to also include some of the live component, if possible, because what we have observed in all the training programs.
So I think the National Medical Council has some guidelines on this. So there are going to be some challenges to this. It's something that we have thought of and explored. But with those things, and of course, remember, as interventional radiologists, our focus is always patient first. And patient safety should not be compromised in any of this. So that is the challenge of incorporating that, but it's in our mind. I also would like to bring forward that, you know, we are in the day and age of social media and marketing, and we, as a specialty, we'd always want the patient to reach us first. So how do you think the industry can support us in this? From involution, shall we start with the involution? How do you think the industry can support interventional radiology to reach the patient first?
I think I'd like to answer this question by taking 2 steps back. When we look at the global interventional, we are primarily a cardiovascular care company. But when you look at the global market for cardiovascular care and the market for interventional radiology is about 70% of the global cardiology market outside India. But that gap is glaring in India. For example, in India, you do about 1.1 million PCIs or angioplasties, whereas the number on the interventional radiology side is about 1/10 of that number. You know, so my vision and dream would be that as Indian companies, and I'm not saying some of the multinational companies, they do not need to be made in India. They can make in India. The Prime Minister's vision is not to have a promoter of Indian origin making in India.
No, that's not my question. So my question is, how does the industry help us to reach the patient?
I'm exactly coming to that. Before we came into the cardiology segment, the cost of setting up a good cardiology cath lab setup was about 5 crores or more. We made it accessible, affordable, and available for tier 3 cities to have a cath lab. And that's why today, when we started in 2019, there were 160 new cath labs installed. Today, there are 600 new cath labs installed every year. I think as the cost of treatment comes down, and that is tied inherently to making in India. As the cost of treatment comes down, I genuinely believe that interventional radiology will become 70% of cardiology even in India. Because globally, that's exactly the situation.
Abhinav, would you like to add anything on how industry can support interventional radiology to grow? Especially when it comes to public perception and patients understanding that I have this problem and I should go and see an interventional radiologist. So how will the industry support us in this?
Thank you, Dr. Lennon. So I've been working in intervention radiology field for last 10 years. And what I have seen is post-COVID, there is a drastic change in the efforts which industry and a lot of physicians, they are taking for the patient awareness. So I think as industry, we can definitely help physicians and partner with them with quality content, because that's something which is allowed to us as per the current guidelines. We can definitely work and help them create some of the impactful messaging and the content. So that is something is possible in the current purview.
So my request to all of you is to also look at the digital aspect of it.
Yes.
Okay? So I think all of you all should consider partnering up with all of the interventional radiology physicians to make our digital presence more known, because not all of us come from a very strong marketing background, but you all do have the machinery behind you for this, and partnering up with us is a win-win situation. Dr. Uttapa, you had something to add?
Thank you, Lennon, for the opportunity. I have a suggestion to make, and this is stemming from a personal experience. The Karnataka State Chapter, our flagship conference is called CIRCON. And when we were conceptualizing the workshop, we actually engaged with every industry person to do the workshop jointly. So you had an interventional radiology faculty and a representative from the industry, and we had a common hall, and I think we had well over 30 stations where the industry was kind of spearheading the workshop. So I just wanted you guys to brainstorm, maybe not now, to see if that is a good idea, because some of the points which you raised might get solved there. It is basically what I'm trying to say is that we have an interventional radiology faculty, and so basically the science and the commerce of interventional radiology should be more transparent, more open, but we request you guys to kind of take ownership of the workshop, where ISVR obviously will take a big role in making sure the quality part and the academic part, the evidence part is taken care. So just a suggestion to brainstorm for the future. Thank you.
I'd like to have two more comments and then a last comment from the industry. So first, Dr. Blaze.
Well, it's fantastic to see the collaboration between industry and the treating community here. India is such an exciting community for what's going on, what you're doing, and certainly a lot of the innovation and things that are happening here. One thing I just wanted to encourage from, say, a perspective we had in the U.S. was very much looking at things that you can partner together as you're doing. One of the things for us was looking at educating the government, the people that empower some of these decisions, the money, kind of people on common projects. We did a very successful Get Ahead of Stroke campaign, and that was aimed at basically keeping the government aware of the movement and things that were happening in the field. And so that would be a nice collaborative effort that industry and the treating community could do together here in India as well.
Dr. Leland, I just wanted to add one thing, and the suggestion is that the registry of the cases that can also be worked out. That's a very, I should say, pressing point that we are taking a very sincere effort from all the sides. But somewhere we are, documentation thing is a question mark in terms of what type of cases pan-India or certain sectors are doing, so that we could promote that particular therapy, or we will just getting a clear picture what exactly are we heading towards, what is the gap, and what is the global standards that are matching. So that can, as an industry or from ISVR thing, that we can work on.
So Sudeep, so IR, like you are doing, you people all are doing wonderful jobs. So what I like to add, so what I expect from you people, as you know, if you come to publication standards, Indian IR papers, if you say why you cannot publish in any JAM, why you can't publish in Lancet, why you can't publish in good peer-reviewed PubMed index journals. So in that case, you have to pitch in, because there are many centers, standalone centers, single operators, they do many procedures, many beautiful procedures, lot of device they use, but they don't have anyone to write, or they don't have time to write. Why don't you collect and collaborate with such operators and compile the data and put it in the index paper, so that we'll get more visibility, and also it will help us, right?
So I agree. Dr. Rashmi Ranjan himself has written a paper on the use of Optura in carotid closure, and so actually he's promoting you. So you all should make it collaborative, such that it makes it easier for him to write more such data. I think we are reaching the end of this session, but before we end, we always need the presidential address. So I would like to hand over the mic to Dr. Shyam Kumar for the closing remarks.
Thank you, Lenin. And on behalf of the society, I thank all of you who are sitting on the stage. That's okay. Okay. So, and thank you all of you for giving your valuable remarks. I have only one request. It's a very small request, but it's an important one. January 16th of January, that was the day Dr. Charles' daughter did the first angioplasty in the world. And this particular day is being celebrated as a Global Interventional Radiology Day. So I request this can be done together. So how we are going to post in our respective social media, going to celebrate in our own areas with the hospitals, patients. So we request your contribution to Global Interventional Radiology Day in whatever capacity you can do. So some idea how you can do it? Anybody?
So Dr. Shyam himself has initiated a reel making competition, which most of the reels will be shared on January 16th. And I urge every participant here also to participate in this. And from the industry itself, you've got the marketing machinery, and but you have only 8 days to go. So you all should get on it and help us promote awareness about Global Interventional Radiology Day. The more that it is shared, the more people get to know about it. There's more awareness. When there's more awareness, there's more reading about it, and consequently, it translates into patients, better care, and support to industry. Dr. Vimal Someshwar also would like to add something.
Unfortunately, I came a little late, so I don't know whether this has been discussed or no, but the number of people participating or doing intervention has increased. The society has increased very big now. It's definitely has a potential to grow more, and it should grow more. What I'm finding now is that the younger lot will have to work harder to get patients. The number of procedures that have increased are tremendous. And some of the procedures that have come in are directly competing with our other existing procedures that were being done. Example, let's say prostatic artery embolization, genicular artery embolizations. Some of these procedures, your doctors will not refer to you. And that's where I personally feel now the younger doctors should get into social media. And let's see that the patients come to you directly rather than being a tertiary care physicians. The general practitioner to the consultant to interventional radiologist, no. We should now have directly patient coming to us, and that's where industry and the society could join hands and formulate or help in social media presentations of all these conditions. So that is probably will increase the pie. So probably that's how we should work.
So I think that is our probable concluding remark is we need more help with social media, getting ourselves out there. We need more awareness for Global Interventional Radiology Day. Can I hear everybody giving me a big round of cheer? Yeah, we need more awareness for Global Interventional Radiology Day on January 16th. And the more people are aware of this, ultimately translates into better care for all of us. Thank you very much, everybody, and have a good day.
Thank you so very much. Making a happy and healthy India together. Thank you so much to our industry leaders. Thank you so much, Dr. Lennon, for leading such a beautiful dialogue forward. Can we give it up for Dr. Lennon, please? Give him a nice big round of applause. That was fabulous, important, pertinent questions. Everything was asked, rightfully so. Thank you so very much. Ladies and gentlemen, we have something very, very special that awaits you. May I please request you to take your seats, to settle down. Thank you for making the lunch symposium a grand success. But I promise you what's next is definitely going to blow your mind. So please take your seats, settle down so you can make the most of it. Take a moment here to applaud all our wonderful sponsors, ladies and gentlemen, who have made ISVIR 2026 possible. Give it up, ladies and gentlemen, come on. Thank you. Thank you so very much. It's a very big photograph, I know. Thank you once again. You know what, my dear wonderful doctors, when one of the specialists was showcasing their work on the screen, another doctor next to me said, well, that is a work of art. I do know that every person in the room is an artist. So we have an amazing artist who is going to come here next up on stage. And like the human body, let me tell you, dear doctors, the instrument, especially the percussion instruments, also have a body, also have a head, also have a tail, and also have a rhythm. So leading this forward will be a multi-percussion expert since the age of 7, music therapist, multi-percussionist, and author, Aditya Kamakshi Nada. And he has made a request. Can I request all of you to look that side? All of you, can you please, wherever my hand is pointing, can you please look in that direction, please? Can all of you look this side? Yes. Are you ready for this? Only one person answered. I know you're paying attention. Thank you. Are you ready for this?
Check.
Wonderful.
Check,
Yes.
Check. Woo, 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 woo. Louder. Louder. Are you guys excited? I need more energy, guys. Are you guys excited? Much better. So I want all of you to reduce the noise. Shh. Shh. Guys at the back. Shh. We've been talking all day, right? We've been hearing a lot all day. So just 1 minute of silence can bring so much of calm within you. Just don't do anything. Don't see your phones. Just be silent. I'll just give you 10 seconds. Just be silent. Guys at the back? Yeah. Shh. Breathe in. Breathe out. One more time. Breathe in. Breathe out. One last time. Feeling better? Tangida nagadiku tarigedin, nut tangida nagadiku tarigedi, tangida nagadiku tariged talangadin, talangadim, de tangida nagadiku tarigedin, nut tangida nagadiku tarigedi, tangida nagadiku tariged talangadim, talangadim, de tangida nagadiku tarigedin, nut tangida nagadiku tarigedi, tangida nagadiku tariged talangadim, de tangida nagadiku tariged talangadim, de tangida nagadiku tariged talangadin tadim, talangadin tadim. Shri Gurubhyo Namaha. So, I saw a few raised faces and a few raised eyebrows. What is he doing? How did he do that? Right? You guys are wondering what this is. So this is called a konokol. And I use this in order to communicate with my guru when I was 7 years old. You guys are wondering, how does he use this in order to communicate? Well, why not? Music is a form of communication, right? Music is indeed a tool that can be used in order to express how we feel. As a certified music therapist, that is exactly what I do. I use music as a tool to communicate. You know what's the fun part about this? Today, we are going to use music in order to communicate. Does that sound interesting? Had good lunch? Okay, I'm going to wake you guys up. Does that sound interesting? Superb. So, I'm going to give different beat patterns. It's not going to be complex, very simple beat patterns. And you guys are going to use this very unique instrument that we all have today. Any guesses on what the instrument is? Yes. God has gifted us 2 hands, right? We are going to clap, snap, and make music together. Let's go. Let's start very slow, and then we'll slowly spice things up. Okay? I want all of you to just listen very carefully and do the same thing. So this activity is called monkey monkey. You know why? Because monkey is ape, right? So there's just one rule during this whole activity. No talking. We're just going to use only music in order to have a conversation. Great? Wait for it. Whenever I show my hand is when your turn is. Okay? Louder. Come on, guys, you can do better. Give yourselves a round of applause. Is that all you got? Come on, guys. We made music together. That's a win. How are you guys feeling? Everybody woke up? That's great. So just simple clapping can do so much, right? So the next time you feel bored, the next time you feel exhausted, the next time you feel tired, the next time you feel that you have low energy, just clap and you'll instantly feel better. Thank you so much. I hope you have an amazing rest of the afternoon with a lot of learning and a lot to take back. That's me, Aditya Kamakshanada, signing off. I'm a certified music therapist. If you loved what you did and you want to connect with me, I'm right here around the conference. Love to talk to you. I make you realize your own rhythm. Thank you so much. Enjoy life, celebrate rhythm. Thank you.
Thank you, thank you. That was fabulous, Aditya. Thank you. Give him a nice big round of applause. Ladies and gentlemen, artists are the ones who make the world beautiful along with doctors. And one thing I now know is all of you can actually clap pretty well. I've been trying since morning. But nevertheless, we're going to have Dr. Pooja, who's going to lead our post-lunch sessions forward. Ladies and gentlemen, give it up for our next on-stage host, Dr. Pooja. Wonderful to see a woman in the IR field. Yes, here we go.
Good afternoon all. So I'll be introducing our chairpersons for the afternoon to discuss about acute stroke and ICAT. So first I would like to call upon Dr. Periya Karuppan, intervention radiologist from Kalingar Hospital, Chennai. Next, Dr. Blaise Baxter from University of Chattanooga, and Dr. Shankar Balakrishnan from Rela Hospital. Thank you all.
The same session? Okay, great. Well, we're all warmed up with our clapping, so we will open up our session on acute stroke and ICAD. Let's invite our first speaker, and that's going to be Dr. Manish, who's going to give us a talk on current indications for mechanical thrombectomy. This is including the extended window, large core, and low NIHSS patients. Thank you.
Good evening, everyone, for this post-lunch session. So the first talk is on mechanical thrombectomy. Most of the people who are doing any type of stroke probably know more about it than anything else about stroke. So why we are talking about mechanical thrombectomy is this is a field or a procedure which is evolving very rapidly. So every few months we have a new paper either throwing us new challenges in terms of widening the horizon of thrombectomy, or it disproves our previous belief and we talk about something new. So basically diving into the topic, what are the current standard time windows? So thrombectomy has been driven by time, and also recent evidences has shown us towards another metric, which is the amount of brain which is salvageable. And making a decision for thrombectomy is combining these two things. At what time period, how much brain is salvageable so that you can go for a thrombectomy. So that's what kind of summarizes the entire talk. So basically we had this standard time window where up to 6 hours you take everybody presently, with NIH and the large core stroke being evident there. So this was the highest level of evidence which was available, NIH more than 6 and aspect more than 6. Then the time was extended from 6 to 24 hours, again with a very high level of evidence. And then came the ultra extended time period where we offer thrombectomy in very few selected cases up to even 48 hours. So what are these extended time window trials? Diffuse 3 and DAWN, we know about it. They brought down the number needed to treat, which was one of the most in entire medical field. Even NNT was brought down to up to 2 for a very good favorable outcome. Both of these studies relied on perfusion imaging to identify patients who had significant penumbra and the core was smaller to be eligible. Then came the large core shift. So what they made is even the large core patients were eligible for thrombectomy. and the largest meta-analysis or the Atlas meta-analysis, which was published in 2025 with 1,800 plus patients. They had a very good improvement in MRS 0 to 2 of 27%, and number needed to treat for this particular large core was just 4. And it was, a benefit was seen across all aspects. And even the large cores up to 150 ml showed significant benefit. But is this can be applied directly to India? Probably we'll talk about it in few minutes from now. About the tension trial, again, this was a large, successful trial on large core infarcts. They included 3 to 5 aspect score, and the average time was up to 17 hours. And they had a significant improvement in MRS 0 to 2, where patients were doing relatively well. A major fear was in large core was a symptomatic intracranial hemorrhage. That's where this trial showed that the intracranial hemorrhage rates were not significantly higher compared to the controls. And then came the Rescue Japan limit, which was a significant shifter again. Based on MRI, then it improves the window up to 0 to 24 hours. MRS 0 to 2 was 28% in thrombectomy group versus 14%, and it had a number needed to treat of 7. So it was widely believed that if you have a large core, the treatment to recanalize is futile. And all these studies also demonstrate the Swiss cheese understanding of a core, where the entire core is not infarcted, it's just the islands of viable neurons which are there, which we are trying to salvage in the large core thrombectomies. That SELECT2 and ANGEL aspects brought in the CT perfusion era. Both had close to 350 patients in both the groups. CT perfusion was the guided. Again, they showed a very good improvement in the MRS 0 to 2. Then about the tension trial, which bring it again the extended window success up to 24 hours of aspects 3 to 5. And the endpoint was 0 to 2 MRS at 90 days. And it showed that there was significant benefit with endovascular therapy compared to the medical management. And it opened the window for the ultra extended window up to 16 hours. Then the last trial with an average aspects of 0 to 5, they had close to 250 patients and up to 24 hours window. They showed MRS 0 to 2 of 24% versus 12% in the control arm. Number needed to treat was 8, and safety and the symptomatic intracranial hemorrhage was comparable. This was the Tesla trial, which again aspects of 2 to 5 showed up to 24 hours. They used utility weighted MRS, and endpoint had a positive efficacy signal. So all these trials have shown that large core in the extended window is possible and is definitely beneficial than the medical therapy alone. This is a Magnum meta-analysis where it was involving the Rescue Japan limit, SELECT2 and ANGEL aspects, around 1,000 patients with aspect 3 to 5. The MRS 0 to 2 was double with endovascular therapy compared with medical therapy alone. And it showed benefit in all aspects, even 3, 4 and 5. And we know the safety profile was similar to the control group. So basically, what we do is standard window, probably everyone gets into for a thrombectomy up to 0 to 6 hours. Extended is aspects more than 5, and large core is obviously 3 to 5, where the core volume is accordingly proportional to that. What are the guidelines say? A small caveat is the guidelines, all the trials, they get incorporated in the guidelines over a period of time. It's not that the evidence is there and the guidelines change. Probably it takes 6 months to 1 year to 1.5 years time lag when the guidelines change compared to what we have the evidence. But it's a rapidly evolving field where the practice should evolve as per the evidence. And the guidelines will follow over a period of time. So we have class 1 evidence up to 6 hours and up to 24 hours with the use of perfusion. But with the large core trial, even probably up to 24 hours, everybody will be likely to be eligible in an ideal world. But the story is little different in India. Class 2A, it can be extended up to 48 hours, and the large core for 2A with a good clinical imaging mismatch. Class 2B is the milder stroke, and which is something which is controversial with a large vessel occlusion and a minor stroke. That's where the uncertainty is. Low NH that is something which is evolving, and we have 2 trials which are nearing completion, which is the ENDO-LOW and MOSTE. These are working on low NH trials where you have a large vessel occlusion, the patient is not very symptomatic, and we are wondering what to do with them. Whether to offer thrombectomy with the risk of whatever procedure and the cost involved versus to just follow up. And we all had our mixed experience in this particular scenario. We are looking for to what the evidence says, and probably in some time we will have a better idea on that. So basic clinical decision making is confirm large vessel occlusion and a vessel imaging with CT MRA. Assess the time window and the MRS, how was it, whether the patient is eligible for thrombectomy. If it is within 6 hours, you go by the aspects and take them for thrombectomy. If it is more than 6 hours, do a perfusion imaging and look for the core and the penumbra mismatch. Or another surrogate is a clinical and imaging mismatch, or a core and a clinical mismatch, which will help us to identify tissue which is viable and offer them thrombectomy. So safety profile, obviously, we have seen very good intracranial hemorrhage rate is not very significant with thrombectomy. And with the evolution in technology, more softer devices and more ideal devices being available, probably the complication rates have come down in all these patients. What we have to look at is somebody who has MRS of more than 1, severe hypoxia and other comorbidities, probably they may have not so favorable outcome. So we have implications in terms of, we have a criteria which are expanding. Perfusion imaging has become a core of it to identify and prognosticate. Look at beyond time, look at the tissue salvageability. Milder stroke is something which we are looking at probably to have evidences in those areas and integration of AI. Bit about posterior circulation. This was the basics and attention trial which opened up the window for the posterior circulation thrombectomy. Then the Bausch trial, which was like extended this window to 24 hours, again demonstrating an NNT of just 4.8 with a very good profile in terms of mortality and morbidity in an already morbid or severe disease. Then the best trial with vertebrobasilar occlusion again demonstrated, it improved on what the basics and the attention demonstrated to us. The Veritas collaborative meta-analysis published in 2024 with 1,200 patients demonstrated that increase in the MRS 0 to 3 by 2.5 times. So the therapy is effective in, quite effective in posterior circulation where the natural history of disease itself is not very good. That brought us to selecting better patients for posterior circulation stroke. So the PC posterior circulation aspects came in. The collateral scoring of the posterior circulation again help us to select patients better for endovascular therapy, identify people who are likely to benefit more from this. NIH less than 10, mild basilar artery stenosis. Again, the current recommendation is class 1 for anybody having NIH is more than 10, but the caveat is NIH was designed for anterior circulation, not for posterior circulation. Class 2A for NIH 5 to 9, and do consider collateral status, because when we see a basilar artery occlusion, although the patient may be fine now, but they may deteriorate over a period of time. So then we are left wondering, we should have intervened early to have a definitive better outcome. Vertebrobasilar tandem occlusions again, It's an important area where we see a lot of these vertebral occlusions migrating and producing occlusion of the basilar. The recanalization and the MRS and the mortality rates are comparable in both the arms. Briefly about medium vessel occlusion, there was a few years back, there was a significant excitement over the medium vessel occlusion trials, looking at M2, M3 and distal A2, A3 occlusions at 12 hours. But then the distal and the discount trial failed to show any significant benefit. This is probably much more selective patients where we need to look at it's a very, very locant area, very early stroke, whether this will help or not. And the risk of the procedure in these smaller vessels is significantly higher compared to more proximal large vessel occlusions. So we talked about this standard window 0 to 3. Almost everybody gets in with the current guidelines. Even the large core, you can take it. Extended window, you have to look at the perfusion mismatch. You need to identify significant penumbra before we do it. The new criteria for large core is you need to have core volume less than 150 ml and up to 24 hours, and pre-stroke MRS should be 0 to 1. Low NH with LVO, we talk about we are waiting for these two trials to give us some more information before we jump into low NH LVO, but then this practice has to be individualized and discussed with the family what they want to do and how good they are with the procedure. Procedural time and door to groin, we need to stick to and maintain high standards for this therapy to be successful. Keep a simplified decision algorithm. You need to have a plane, you need to have a vascular imaging, and in extended window, you need to have a perfusion imaging. We spoke about this. So in the posterior circulation, we have evidence that definitely thrombectomy works and it is better than medical therapy up to 24 hours of period, and the endovascular therapy has definitely better outcome. So what we do in India specific is basically we need to understand that when we take large core, probably not all of them will do well, and we will have to look at a very good rehab unit to make a good outcome out of this. So this has to be discussed with family in detail because this incurs a significant amount of cost, not only at the initial stage but at the rehabilitation stage where this has to be significantly understood. The family has to be involved and have a good discussion whether they want to consider, especially in the large core areas. Posterior circulation, again, it's something which is unpredictable, but we need to look at the imaging, look at the collateral scoring, and what the family can do.
Time is up.
I think we can take all the questions at the end of the session. Just we'll call the next speaker, Ajay from PGI, Premier Teaching Institute. He will share his experience, standard technique and cases.
A very good afternoon. First of all, I'm very much thankful to the organizing committee for inviting me for this talk. And secondly, I would love to thank for the organization of that small music session, because most of the speakers, they are afraid of speaking in post-lunch session. But because of that small music session, the splanchnic circulation is redistributed toward the brain side. So thanks for doing that. So I'll be talking about the stroke standard techniques and very basic techniques. So can I ask in this house who all are practicing the thrombectomies? Other than, to my belief, whosoever is working for the liver, splanchnic circulation, uterus, or anywhere else, they can very well do the stroke cases as well. So mechanical thrombectomy, history-wise, it was started somewhere way back with Mercy, then stent reverse, aspiration, and then combination of these different devices. Somewhere in 2004, Mercy, then Penumbra 2009, stent reverse, and the use of stent reverse totally changed the game, and now the stroke treatment is the central part of neuroradiology, and thrombectomies are very much standardized. So what are the indications? Large vessel occlusion within window period, availability of infrastructure, and the most important thing is the skill. That's why we all are here. And in India, affording patient has to be there. So protocols, individualized protocol, institute-based protocols has to be there. Workflow can be different from my institute to other institute, but the aim is rapid and safe restoration of the blood flow. And avoid GA if possible. Whenever the patient is comfortable, try to avoid GA. Take out the clot in one piece, avoid fragmentation and distal migration of the clot. Once the clot is going into distal vessels like M3, M4, then that will create more and permanent ischemic burden. So these are the steps. First, the wire has to be crossed across the thrombus, then microcatheter is crossed very gently. Then, so in these schematic videos, this appear very like easy, but it is not that easy, but not that difficult also. With the proper training, and so we can help whosoever is doing endovascular work anywhere. They can help the stroke patient then and there. You just need skill, a lab, and the techniques. So at times there are clots, RBC rich clots, they are relatively softer, but there are clots which are fibrin rich, and they are very much jittery to take out, and these are the patient which may need the double stent or additional aspiration catheters and all. So aspiration technique, again, everything is same, but we use the large bore catheter, and those are taken directly till the face of thrombus, and the thrombus is aspirated with the help of aspiration device. Again, I am saying this appears very much easy out here, but it is not that easy. But if your technique is right, you can help most of the patients. So whatever hardware we are having right now in the neurointervention armamentarium, you can help most of the patient. So this is a stroke hardware like puncture set, long sheath. Long sheath is must. Once you have placed a kind of highway from your groin to the common carotid, then you can pass on so many things, and you can keep your long sheath then and there, and you can do you can take pass whether the aspiration or stent river again and again. The use of balloon guide catheter. So nowadays the use of these catheters has been decreased because of Solumbra technique, and you take your the aspiration catheter along with your stent directly to the face of the clot. So these are the multiple devices: Solitaire, Trevo, Revive, Aprio, Capture, and you can use any of these, but the most reliable are the Solitaire and other simple devices. So now we will see the stroke step by step. So this is the catheter, the diagnostic catheter, and the long sheath behind it. So we can see only ECA system is filling up. Then we are putting the long sheath along with the guider with the help of this wire which was already placed inside. Then this is the run with the help of a diagnostic run with the guider keeping. So we can see that the MCA M1 segment, distal M1 segment, there is occlusion and nothing is going beyond. The very important thing to deal with stroke is that this is a blind procedure. Like in other cases, you have your smart mask or you have the mask or roadmap. But in stroke, this is totally different. You are not going to have anything. So you have to take things blindly. And these are the shapes. One should not use either this or this shape because this will can go into the subintimal location and can cause dissections and perforation. This can go into the side wall perforators, and when you are not seeing, you have placed your microcatheter into some perforator and then you have opened accidentally your stent river into that small perforator. Definitely it is going to be ruptured. So this is recommended because this loop, this takes the larger vessel even if it is not seen, and because the leading edge is this way, it is not going to enter into any perforator or into any dissected segment. So this is the microcatheter has been placed, and this is the microcatheter run. Distal MCA is patent and the stroke burden is between the distal M1 and this MCA segment. Now the stent is placed and this is the run. Still it is not open. So pulling out the stent, we pull out the open stent along with the assembly of microcatheter. The suction is on, 50 cc dual lock syringe is kept, and you have to make the suction on the device. And if balloon guide catheter is there, you have to inflate it first and then take out. So this is the result. And it is very much satisfying. The stroke cases are very much satisfying. They improve then and there on table if the patient is reached in time and the technique is right. So then you have to check the collaterals for future prognostication of these patients. And in this patient, we can see it is having collateral through ACOM, and from the posterior circulation also, the PCA is also giving pile collaterals to the MCO. So this patient had a very good outcome. So these are the cases. In this is the CT angio, right M1 is occluded in this segment. The distal vessels are seen because of good collaterals and reformation, and these are the best patient to do. In this particular patient, then just see the loop of this to the technique I told. So distal vessel, then we can see the clot here. It is sitting here. So the stent is 2/3 beyond and 1/3 across the clot, and then just take out. This is the fish which is taken out, and this is the result. So another case, in this we are having the tandem occlusion, we are having stenosis in the common carotid origin, the ICA origin as well. So first thing is to go distally and take out the clot distally, because if we take out the clot distally, the collaterals are there from the ACOM or this thing, then the brain is going to perfuse even if the proximal stenosis is not opened. So first we have to take care of the distal circulation, and this is the stent, and this was very severe, more than 95%. So stent was placed then and there. This is another case. This is after first pass, but if you see carefully, all the vessels are not open. This segment is still absent. So you can go and into the particular branch and can take, so this branch was opened, now it is in this branch. So with the stent reverse, we can go into different branches many times. This is the posterior circulation, the stent placement, and so this is the case with aspiration. Left M1 segment is occluded. This is the microcatheter run, and this is the first. This case was taken for stent reaver only, but it didn't open. So this is the solitaire, and then it was upgraded to the aspiration plus stent reaver, and we can see this is the aspiration catheter, which is directly pushed till the face of the clot, and with the combination of these two, the case was done. And so the endovascular management for stroke plays a central role, especially for large vessel occlusions. Extended window advancement in hardware and skill promises lot more achievements. So this talk was very much basic, and this was giving just an idea. But if you want to learn more and you want to go to the Pro Max level, then we are going to have the annual conference of Indian Society of Neuroradiology, which is going to deal with the neuroimaging as well as the state-of-art neurointervention techniques there in city beautiful Chandigarh. So all are invited and will be very much welcome there. Thank you.
Very good talk, sir. Thank you. We'll take the questions at the end. We'll
Yep.
call the next speaker. Santosh is from KMCH. He will address double stent retriever in the current context, how to match the cost, when to use double stent retriever.
So after the elaborate talk by Dr. Ajay sir on the basic techniques for mechanical thrombectomy, we would venture into some of the advanced technique. So we'll review the double stent retriever technique, how it has come into vogue and how it is being evolving over the past few years. So why should we have this double stent retriever technique? See, we have a single stent retriever technique, we have a suction which is adapt first technique, and we have a combined technique which is called Solumbra, and whatever names we have called it all these years. So what is the necessity for a new technique? So whatever conventional techniques we have a variable success rate, and the success rate reported in literature is between 55 to 85% depending on the technique used. And many of our cases, if you have seen, they take multiple passes with different techniques, and finally we sometimes may fail, although it is a fraction of our cases that we failed in the past. But more important is the first pass effect, FPE. The first pass effect is very important. We have seen time and again that the first pass recanalization is going to matter to the patient. Whatever the final result is, the highest outcome or the best outcome is got when the patient has got a first pass recanalization. And that is quite low in certain situations like an ICAT occlusion, where the voluminous clot is lodged at the ICA bifurcation, and the conventional techniques may fail in most of the situations, and the first pass effect is as low as 30% in these cases. And that is where the double stent retriever was used when a single stent retriever, a combination of suction and stent retriever, could not actually take out these bulky voluminous clots at the bifurcation, initially as a rescue strategy, and now it is increasingly being used as a first pass strategy, with a first pass efficiency of 69 to 77% in various studies reported in the literature in this particular cohort. So how is it different? So you can see that the single stent retriever technique here, it works by engaging the clot by incorporating the clot into the fishing net, which is the stent retriever, and pulling out the clot in a single pass. So you may get it or you may not get it in a single pass. You have to repeat the passes with different techniques or so. But compare it with the double stent retriever technique here, and you can see that the clot is being entrapped between the two stent retrievers while it's being pulled out. And we'll see what are the biomechanical advantages of this double stent retriever. First and foremost, the surface area of contact with the clot between the two stent retrievers is definitely higher than what we achieve with a single stent retriever. So it acts like a fishing net. So the surface area of interaction between the device and the clot is greater. The second effect is like catching an object with a single hand versus catching an object with two hands. So that is a pincer effect. It traps the clot between the two stent retrievers, allowing it not to fragment or break and distal embolize. The third point is it reduces the interaction between the clot and the vessel wall. So that's what you can see here. It entraps the clot between the two stent retrievers and minimizes the interaction, which is a key player in white clot or fibrin clot. Even after multiple passes with the device, like a stent retriever, because of the repeated interaction with the vessel wall, the clot becomes dehydrated, becomes more tough, and it becomes more rubbery. So that effect is actually reduced with the help of a double stent retriever, and that's how it works for a fibrin clot. The best use of a double stent retriever is in bifurcation occlusions. In MCA bifurcation, we often may find a dilemma because the clot may proceed into from the M1 to one of the divisions, and we have no control on which division we enter with the microcatheter and the wire. So when we deploy the stent retriever from one of the divisions into the M1 segment, and if the clot has been into the other division, then we may risk of actually breaking the clot and not taking out the respective divisional clot. So that is a problem with bifurcation occlusions, and that key disadvantage is taken care of by using two stent retrievers, because you are going to go into both the divisions and take out the clot as a single unit. In ICA bifurcation, it works in a different scenario because most of these clots are bulky, voluminous, and not actually engaged by the suction catheter that we use, which is of current generation that we are using in India. Whereas it may be a different scenario if the ultra large port suction catheters come in the near future. But for time being, these bulky clots are actually difficult to get hold of by the current devices that we have on at this point of time. And often what we have a situation is the clot while retrieving breaks into the AC, and then it is a mess. You go into the distal AC and retrieve it back. Sometimes you succeed, sometimes you fail, and it becomes a mess. So there, a second stent retriever in the AC actually acts like a filter. So this is a key important factor in preventing distal embolization to new territory, particularly into the ACA. Last but not the least, in long clots, it's not very rare, it's not very uncommon. We have been seeing quite a lot of cases with long clots with a cardioembolic stroke, and even in situ thrombotic stroke in a large atherosclerotic burden. So what we have to do is we have to keep this, our length of the stent retriever is fixed on 40 mm in most cases. Some stent retrievers are longer, but not much. So what we can do is we can keep two stent retrievers in series and actually cover the entire length of the clot. What you get is an 8 centimeter of coverage of stent retriever, and that you can use as a durable strategy in a long clot. How do we move about doing the procedure? So you can either do it with just a balloon guide catheter and two microcatheters. So what microcatheters we usually use now are the 2-1 system microcatheters, because most of these stent retrievers now are 2-1 compatible. So we take 2-1 microcatheters. That is essential for a double stent retriever technique. So we can either take it directly through the balloon guide catheter in a standard stent retriever only technique, where a balloon guide catheter is parked in the high cervical or petrous segment, and then you take two microcatheters and into each of the division of the MCA as shown here, the superior and the inferior divisions, and then deploy the stent retrievers and pull them out. Or you can have two stations down below where you have a base camp of a balloon guide or a long guide sheath, and then you can have a suction catheter which is at least 071 ID. So this 071 ID is important because you need 2-1 micros to be taken distally. So that is the ID which accommodates at least 2-1 micros. So you can use any of the systems of in ID more than 071. And here we are seeing the stent retriever in the ACA as well as in the M1 segment. So this was an ICA clot. So you can either use it with just with balloon guide catheter or with a balloon guide catheter and suction in the current generation suction catheters are more than 0.71. Moving on to the intracranial occlusion. So how do we succeed in cannulating both the divisions? It is just a luck most often, sometimes our skills. So what we have to do is we have to allow the J-tip to go to the one of the divisions as what we have been seeing in the last lecture. That is a standard microcatheter navigation technique across an occlusion with no vision distally. The second microcatheter has to be maneuvered into the other division. You may succeed or you may not succeed depending on your experience. Sometimes what helps is actually taking a collateral run. Suppose if it is an MCA bifurcation, you can take an ICA run which shows the pile collaterals reaching up to the clot, and you may sometimes see the other division coming down, so you can actually try to cannulate at that point. And here you have to definitely use an angled wire, not the J-tip, because you need to maneuver and enter the other division. So once both divisions are cannulated and the microcatheters are placed distally, the microcatheter runs are done, you are sure that they are in different divisions. You can actually deploy the stent retrievers either simultaneously or one after the other. This is called the parallel DSR deployment technique. So the second technique, which is uncommonly used, is a stent-in-stent technique, where the first stent retriever is deployed and then it is easier to see the other division, and then you can actually cannulate the other division through the stent retriever and then deploy the second stent retriever. This is not very commonly used because sometimes we may face difficulty in passing the microcatheter because it may hitch across the first stent retriever. So that is the point. We use the first technique where we use a parallel DSR deployment. Sometimes you may enter the same division, that is not a problem. You can still use double stent retriever technique. Even though it enters the same division, it will have the same mechanism of pinching the clot, if at least in the M1 segment. So once the stent retrievers are deployed by whatever technique you have done, so you have to pull them both together. If you are using a suction as well, you pull the suction along with the two stent retrievers together as a system and not the stent retrievers alone. So if you are using a balloon guide only, you can just pull both the microcatheters along with the stent retrievers in one go. So what is the evidence that has been given in the literature till now? There was a systemic review and meta-analysis published in AJNR in 2024, which examined around 128 patients which were published in literature up to that point of time. And in 68% of these patients, the DSR technique was used as a rescue strategy, and final successful recanalization was achieved in 92% of these patients. In 31% of these patients, it was a primary strategy. And in patients who the strategy was used as a primary recanalization technique, the first pass efficiency was around 77%. So that is quite high compared to the 30% that we get with a single stent retriever or an adapt technique with large clots. And as first line technique, it was examined in only one randomized trial, which was twin-to-one trial, which was terminated prematurely because of higher efficiency of the dual stent retriever technique. The first pass efficiency was around 47% versus 24% in patients whom the single stent retriever technique was used. The worry with using two devices or two stent retrievers in a small vessel like an MCA or the divisions is whether there is an increased risk of intimal injury to the vessel, or whether there is a chance of shear of the perforators of the MCA leading on to more of hemorrhagic complications. But these meta-analysis and the randomized trial both have shown that the rate of symptomatic ICH was not significantly different. Although there was a slight difference, it was not statistically significant. So the worry about complications was not substantiated by all these trials. So we have sent our experience at our institute for publication, and this is the experience in the past 1.5 years. We have done 24 cases. We are not doing as first line strategy for all cases, but we are choosing the patients based on MR SWA imaging. We are seeing the amount of blooming clot, whether they go into both divisions of the MCA, or more commonly we have been doing it more for the ICA occlusions, the distal ICA occlusions, the T occlusions, where our standard techniques fail most often and we end up in lots of distal embolization. And we have found a technical success of final reperfusion TC2C3 of around 80%. first pass efficiency of 60%, symptomatic ICH rates of 12%, and clinically successful outcome in 50% of these patients. So these are some of the patients. I have 3 cases to show. So this is a patient who presented with the left MCA syndrome. You have a left MCA occlusion, and you can see in the SWI blooming that both divisions of the MCA have got the clot extending into. So this is a situation where we have to take 2 stent retrievers because we risk of losing one of the divisions with the first pass. So we took 2 stent retrievers into each of the divisions, 1 stent retriever into each division. Most often when we do this DSR technique in MCA, we use 2 4mm 440 Solitaire X, and this we did through a long guide sheath and a suction catheter. And this is after the first pass. You can see there is a TC3 recanalization. Of course, there was some subarachnoid hemorrhage in the post-procedure CT, but the patient was not symptomatic for that. The second case, again, left
2 minutes.
MCA syndrome. The patient had a left distal ICA occlusion, and if in the SWI you can see the white arrow points towards the clot projecting into the A1 ostium, and the black arrow is pointing the clot towards the MCA M1 segment. So it is a bifurcation clot going into both ACA and MCA, and this is a situation definitely will end up embolization into the ACA, and it's going to be a Messier procedure. So here a single pass of the dual stent retriever technique, where we have taken 1 stent retriever into the AC and 1 into the M1 segment and to the M2 segment, actually successfully recanalized it in the first attempt. There are no complications after it. This is the last case I want to show here. You can see a very bulky clot starting right from the cavernous ICA. There was a pseudo occlusion on the carotid angiogram, and here we wanted additional protection, and we took a balloon guide catheter up to the petrocavernous segment, and then we took a suction catheter all the way up to the clot and 2 microcatheters into the ACA and MCA, and then we could actually retrieve the clot in first attempt, and you can see a TC3 reperfusion in the first attempt. Sometimes you may find difficulty in entering the ACA. What you can do is you can take a second puncture, take contralateral injection, and find out where the A1 joins the clot into the IC on the opposite side. So to take home, DSR strategy was double stent retriever strategy, started as a rescue strategy, but now has been improvingly efficient. It's being used increasingly in as a primary strategy in certain group of patients, particularly in ICAT occlusions, MCA bifurcation occlusions with clot extending to both divisions, and also fibrin clots. There are multiple biomechanical advantages we have seen earlier. ICH rates are comparable and can be employed with just a balloon guide or with a suction as well. Thank you.
Thank you very much. Thank you. Nice talk and interesting technique. We're going to just again save our questions for the end, so I'll invite our next speaker, who's going to be Dr. Rasmaranjan, who's going to speak on periprocedural management of stroke and its complications. Oh, it's actually Rashmi. Hey, Rashmi.
So my talk will be on periprocedural management of stroke, which is less often discussed. So let me start with this slide. So in stroke patients, even if you do a successful procedure, even if you do a TK3 fast pass, never ever tell to the attenders that he will be walking back home, because if you see this, most of the complications that occur after strokes are medical, not neurological, and complications are extremely common. If you see this Rantas trial, 95% of the people out of 280 stroke patients had at least 1 complications. So what are the complications? You name anything, it happens in stroke patients. The most common cause of death after stroke, especially the ischemic stroke, are brain edema, cardiac abnormality, and the pulmonary embolism. And the other medical complications like aspiration pneumonia, UTI, bed sores, thrombophlebitis, anything can happen. That's why we always say it's better to have stroke units, because units dedicated solely to the care of stroke patients decrease mortality and improve the outcomes. So we can classify the complications into 2. One is related to our procedure and another is not related to our procedure. So not related to our procedures are neurological complications like stroke progression or stroke recurrence. Patient come with a stroke NIHSS 5, and he deteriorated, so the stroke progressed, or you have done a thrombectomy and next day he got another stroke, so that is called stroke recurrence. Brain edema and seizure, these are the neurological complications, and there is a lot of medical complication as you see there, DBT, PE, the swallowing abnormality, the aspiration pneumonia, UTI, because you will be giving blood thinners, so patient can develop GI bleed also. So remember, the patients, those who are having cardioembolic stroke, they are more prone for getting a second stroke. You should be very, very careful. And the most lethal complication which happens after stroke is brain edema that can happen after a large ischemic and hemorrhagic stroke. So in stroke unit, if you see the mortality audit, the brain edema, the pulmonary embolism and the cardiac abnormality are the major cause of early death. Coming to the mechanism, the pathophysiology of brain edema. So there are two components. One is cytotoxic component, another is cytotoxic edema, another is vasogenic edema. And the brain edema may begin within hours, but usually it becomes obvious 1 to 4 days after stroke. But sometimes, if there is a malignant MC infarct, it happens within first 24 hours. So the patient comes with high NIHSS. If you do a CT scan brain, you will see a large area of hypodensity, and those patients, they die, and the mortality is almost 80% in malignant MC infarcts. So one slide about the pathophysiology. If you see the neurovascular unit, this is the blood vessel, the endothelial cell layer, the tight junctions, then comes your astrocytes. And so once the ischemia happens, the sodium potassium ATPase fails, so there occurs the gradient, osmotic gradient between the astrocytes and the interstitial cells, so the ions and the water enters into the cell. Then comes the ionic edema, where there is increased expression of plasma lemmal channels and the transporter of endothelial cells, which cause increased water and ion transport across the astrocytes. And finally, the vasogenic edema happens, where there is destruction of the neurovascular unit, blood-brain barrier breaks down, and all the intracellular component become the interstitial component. So this is the basic mechanism, basic pathophysiology of the edema. So not only this, there are certain other factors which contributes to the cerebral edema in stroke patients, like it's an inflammatory response, the venous component also happens, the matrix metalloproteinase, the aquaporin proteins. So all these combinedly contribute to formation of cerebral edema after stroke. And we should not forget the immobility complications, because stroke patients will be immobile, so they will develop ulcers, they will develop contracture. So we should have a good physio, good stroke unit to take care of these patients. Now coming to our topic, we have done the thrombectomy and patient had complications. So what all complications can happen? So start with puncture site complications. As you know, in all procedures, we take an arterial access and we can have a hematoma, we can have a dissection, we can have a artery rupture, so we know how to manage those things. Then another most common thing which happens while we are taking a long sheath, the catheters inside the brain, the vasospasm and dissection. If you push it, whatever the long sheath and catheter we are taking, the blood vessels of the brain are very prone for spasm and dissection, so should be very, very careful to avoid these complications. Reperfusion edema, we did a good procedure, TK3 flow, but the patient developed edema and patient deteriorated. Post-empty hemorrhages, this is one of the dreaded complications which the stroke thrombectomy specialist fear of. Then happens embolization to new territory, like worsening of stroke. We removed the clot from M1, the part of the clot went into A2, A3, then the patient didn't recover. Then the reocclusion is another complication which can happen. So one paper is there which showed almost 20 to 30% of TK3 cases reoccludes within 24 hours. Then of course device related complication, which I am going to discuss with the case examples, and AR embolism, which is a dreaded complication, can happen during thrombectomy. So if you see the frequency, so hematoma almost up to 10%, 2 to 10%, and vasospasm is up to 25% of patients can develop. Dissection, perforation is another complication which can happen in 5%, because all are like blind procedures. You don't know where your wire is going because there is an occlusion. You are passing the wire, the catheter blindly, so it can perforate the vessels. Distal embolism can happen up to 6%, and we will see how we manage those complications. So the reperfusion edema, we did the procedure. Then the ICU doctor, the stroke unit doctor should know what all clinical things he should look at, so that patient can be shifted for the imaging, and the neurosurgeon can take over for a decompression or evacuation of the hematoma. So these are the clinical features we should we should examine the patient when the patient shifted to patient shifts to ICU after our thrombectomy procedure. So this raised ICP is a dreaded complication. If ICP goes beyond 15 millimeter of mercury, usually this is fatal for the patients, and especially for posterior circulation stroke. When you are doing thrombectomy, you should be very, very careful, because any amount of swelling can compress the brainstem and patient can die. So if you suspect a raised ICP, so what we should do? We should avoid unusual head and neck position. Patient should be flat. We should avoid fever. We should avoid increased CVP, overhydration, hypoxia, hypercapnia, and agitation. And we should hyperventilate the patient to reduce the carbon dioxide concentration. We should start mannitol, glycerol, and hypotonic saline to maintain osmolarity between 300 310. But this osmotic therapy is effective only when the cell endothelium and membranes are intact. Once vasogenic edema develops, it doesn't work. Some centers they give steroid, but it is not much role to play in cerebral edema. And of course, craniotomy is life-saving. Let us see this example. 62-year-old male, 4 hours, he was found unresponsive. They came to our emergency department. We did an MRI. We found there is posterior circulation stroke. You can see superior cerebral artery territory infarcted, and there is a distal basilar, mid and distal basilar clot. So first pass, we removed the clot. Patient was intubated and shifted to stroke ICU, and the ICU doctor called, patient is deteriorated, and he has dropped to M2 from M5. So immediately we did a CT. We saw the cerebellum is full, the fourth ventricle is compressed. So immediately patient was shifted for decompression. The suboccipital craniotomy was done, and patient at the end of 3 months, patient was MRS3. This is another young male, 3 hours, NIHS 20. You can see there is a large infarct, large core infarct, and there is M1 clot. We did a fast TK3 flow, but you can see after TK3 day 1, there is some midline shift, the edema started developing, and we have done a decompression because we know this patient is going to deteriorate. So we done an early decompression. Post decompression, patient developed hemorrhagic transformation, but at the end of 1 year, patient is MRS3 and doing his job. He joined the duty. This is another case, 72-year-old female, NIHS was 15. He had a large left MC infarct with an M1 clot, aspect was 0, but they came early. We did a thrombectomy. This patient luckily didn't develop any complication of reperfusion edema or hemorrhage, and he was MRS2 at the end of 3 months. So another complication which talk about is reperfusion hemorrhage, which is the most dreaded, the most feared complications. In this meta-analysis, if you see, up to 40% of patients develop hemorrhage, but only 5 to 6% become symptomatic. So let us see by example. This is a young female, not very old, 42-year-old female with NIH major stroke, and he had also abnormal uterine bleeding. You can see there is an infarct in the insula and the left gangliocapsular, and there is tandem occlusion, left IC-MCA occlusion. So this is a bovine heart, so we did transradial, we did the thrombectomy, we removed clot from the MCA, we did a stenting of the ICA because the ICA was closing. At the same setting, we did the urinary embolization also. So this is the advantage of being an intervention radiologist, because he had AUV and you cannot give antiplatelets because there is a stent. So we did the urinary embolization in the same setting, but she bled, and we did a decompression, and the post procedure was stormy, but at the end of 1 year, the MRS was 4, and she is doing her activity with some support. So this is another case, posterior circulation, vertebral basilar occlusion, unresponsiveness, some patchy infarct in the brainstem. We did a thrombectomy, and it was a successful procedure, but the ICU doctor called, patient's pupils are dilated and fixed when shifted to ICU. So we had a massive brainstem bleed, and patient succumbed. We could not save this patient. So how to classify this reperfusion hemorrhage? There are two classification we use, ICAS classification and Heidelberg classification. ICAS is very simple, HI1, HN2, HI2, PH1, PH2. PH1 is less than 30%, no mass effect. PH2 is more than 30% with mass effect. And these PH2 hematomas are dangerous, and you should be careful. And not all hemorrhagic transformations become symptomatic. So how to classify, how to define which hemorrhage is symptomatic? So we have NINDS, ICAS2, ICAS3, and SITS-MOST. SITS-MOST is the most pragmatic, which say if NIHS drops more than 4 with parenchyma hemorrhage 2, then we say it's symptomatic SICH, and we should treat those cases. So if you see, if you don't do thrombectomy also, those stroke patients, it's a natural progression. Almost 40% of acute stroke don't do anything, don't thrombolize, don't do thrombectomy. These patients land up in hemorrhagic transformation. This is the study, the autopsy study of stroke patients, which was published in the NEJM journal. So the mechanism of hemorrhage, why it happens naturally, why it happens after thrombectomy is poorly understood. There is some research going on which I am going to show. So these are the mechanisms. There are some direct factors, some indirect factors, the involvement of matrix metal proteinase, there is disruption of blood-brain barrier which ultimately leads to hemorrhage. So in untreated patients, it rarely occurs within first 6 hours, but if you treat either by thrombolysis or thrombectomy, they may bleed earlier. And we know BP is one of the variables which controls hemorrhage transformation. So there are papers, if you see this Enchanted trial which came in Lancet last year, so they have compared the strict control of BP within 130 to 140 versus 180. So they saw there is no significant difference. So basically what they are telling, less than 180 is sufficient. We should not be so strict in maintaining BP to 130, 140. And ECAST-2 trial which clearly defined that if you keep BP higher after your thrombolysis thrombectomy, then the chance of hemorrhage transformation is high. So you should maintain BP below 180. And also there is a close relationship between hemodynamics and hemorrhage transformation. So current guideline says that you should keep the BP below 180 by 100 for at least 24 hours because autoregulatory parameters are deranged and the brain cannot buffer BP for up to 3 months. So these are the two examples. If the BP variability is high, you can see there is hemorrhage transformation, and if this BP variability low, there is no hemorrhage transformation. So of course decompression craniotomy is the life-saving procedure, those who develop it, and you should have low threshold for posterior circulation. And there are research going on, matrix metal proteinase, so people are trying silostazole, people are trying BB94, minocycline. There is a trial, MINOS trial, which showed that minocycline might help in those patients, and of course hypothermia might have a role. So we have a scoring system to see which patients can develop hemorrhage transformation. So this is called TAG score. So if time to reperfusion is more, if your blood glucose is more, aspect is low and early venous, there is a chance that patient is going to bleed. So you can tell to the patient attender, yes, this patient can bleed because his TAG score is high. So this is the flowchart what I said. So how to manage hemorrhage transformation after your MT. So procedure related complications, so all these things can happen because we are reusing our hardware, stent detachment, artery perforation, artery dissection. So stent detachment, so potential causes are like tortuous anatomy, heavy calcium can cause, and if you are reusing the device, stent can detach. So this is one of the case sent to me by my colleague Dr. Rinoy from Kerala. He was doing this thrombectomy, so this stent got detached. So what he did, he deployed another stent retriever and pulled the stent out, and finally he could achieve TK3 flow. So if the flow is not there, you can detach the stent. If flow is there, no need to detach stent, you can leave the stent there and continue your antiplatelet. Post-empty vasospasm, we used to think it is a benign thing, but this paper came last month, I think, and they said if iatrogenic vasospasm is there during thrombectomy, the outcome becomes poor if there is no vasospasm after your thrombectomy. And flow limiting dissection, this is one of the complications you should manage. Non-flow limiting dissection, you can follow it up. If there is a flow limiting dissection like this case, you can see. So you have to stent it, and we stented this case because we created a dissection while pushing our long sheath up, and we have to stent it to salvage this. And non-flow limit dissection, no need to stent, you can follow it up. Embolization to new territory, if it is a large branch like this case, A2, so we did a thrombectomy, it's a tandem occlusion, we removed clot from ICA, we removed clot from the MCA, then the clot went into the A to ACA, we went there and we removed the clot from A to ACA, and patient did well. Vessel perforation, because it's a blind procedure, this is a case where we are doing a vascular thrombectomy, the wire perforated the perforator to the thalamus and it caused bleeding. So if you find such type of complication, don't panic, you just calm down and don't pull out the microcatheter. If there is a balloon guiding catheter, you can inflate it. If BP is high, you can lower the BP, and finally if it is not stopping, you can either deploy a coil or a glue and finish the thrombectomy procedure. And other complications like, so 1 minute more. So intra-procedure CCF can happen, and sometimes if you do multiple passes, people say double stent retriever, multiple passes, but these are not benign. This can be harmful. Like this case, they did multiple passes, they thought it's a spasm, but when they followed it up, it turned out to be a dissecting pseudoaneurysm. So these vessels are not very stiff like our peripheral vessels, they are very supple, so you should be very, very gentle, very, very careful while doing thrombectomy. And air embolism, you remove the clot, some air got sucked in, you could not achieve a complete reperfusion. Even if you remove the clot, you can see a large infarct, so you should be very, very careful. Your assistant, your infusion pumps should be air free, or else you can land up in all these complications. So my take-home message is, remember, successful MT does not guarantee a successful outcome. MT is a safe procedure but in a trained hand. Natural history of stroke would have been better than a futile or complicated MT. And in India, we use a lot of reuse device, so we should take proper consent and we should be very, very careful while using those devices. And once complication happens, you should manage it in the cath lab and outside the cath lab in the stroke unit. So dedicated stroke units must be there for robust outcome in stroke patients. Thank you so much for your kind attention.
So the next topic is indications for stenting in ICAT, current evidence and future directions by Dr. Sukaljan.
Good afternoon, everyone. I'm thankful to ISVI for this opportunity, respected chairpersons and my friends here. So I've been asked to talk about the indications of stenting in ICAD. When you talk about indication, it's something like more of a theory, and it's really, really boring to talk about theory, and at this point of time when everyone is yawning and falling asleep here. So we know ICAD, it's around 10% of all strokes, and fortunately or unfortunately, it happens with us, Asians. And so if you talk about the literature, there is a bit of scarcity of the literature from the Western world. And you know that the pathophysiology, how the stroke happens from the intracranial, the problems is quite different from the carotid issues. So obviously, the indications of treatment, the technique of treatment, and the evidences are also a little bit different. So as for example, let me start with this case. So when we started about okay, lose connection. So yeah, so this patient had left-sided infarct, and obviously you have a very tight stenosis. So when we started at that point of time, when the stent was not that kind of user-friendly, we started with balloon angioplasty. And obviously, you know that for the intracranial, it's always submaximal balloon angioplasty, and we do not go for hyperinflation of the balloon. Or when you use stent, it has to be submaximal. So after that, these fall in disfavor, and we started using stents. And because when the new thing comes, we as an interventionist want to use it more and more in our patients. And at that point of time, I didn't know that you know, sometimes only the balloon angioplasty can also very good result unless this study got published from China. Again, China is doing a great job in intracranial atherosclerotic treatment, and they are coming up with so many studies which are really, really encouraging for all of us. And they did balloon angioplasty, and you can see that there is a really, really difference in outcome with balloon angioplasty as compared to the aggressive medical management. So obviously, the risk of submaximal angioplasty is definitely less as compared to the stents, and it can offer a relatively kind of durable opened vessel for quite a long time, and the patient can get benefit. So when you talk about carotid stenting, do you think it's anything beyond the bifurcation? So when you go beyond the bifurcation, the lesions we deal are different because the vessels are changing, the pathology is changing, the stents are changing as compared to the bifurcation, and also the behavior of the stent also changes, and obviously we do not have much, all of us do not have much learning curve for those stenting. But in some cases you can get good result. In cases you may not be that lucky, and also the type of the lesion can vary. Like in this patient who had a left-sided stroke, so obviously this lesion was quite different. So which stent you are going to use in these patients, we do not know. There is no such trial which can tell us that you can. So obviously it's your gut feeling, it's your expertise, how you deal with these lesions. So I'm telling you, you may come out with good result, but you may not be lucky at all the time. And so when you go little bit up in this, in the carotid, again, the vessel completely changes from here. The adventitia is not that thick. You do not have that much strength for the vessel to hold. And in that case, what we feel probably a balloon angioplasty and a self-expanding stents work better. But we do not have that much of evidence in this territory as well. But when we started talking about the indications and the evidence behind the intracranial stenting, we see there are a couple of meta-analyses, the randomized trials, and also the single device publications, which miserably fail, unfortunately, when we talk about its comparison with the best medical management. And it started with Sampris, and if you see the NIH registry, there is around 10% risk of acute stroke in 30 days after carotid stenting in the intracranial MCA or other intracranial stents. But one thing which is promising is that it is quite low in the high volume centers. So that essentially tells us that we need some time to learn about this disease and how we deal it must change. Now, if we see 30-day events in VISIT and Sampris, it is definitely not encouraging as compared to the medical management. But if you again see the risk of stroke at 30 days and risk of stroke beyond 30 days, that definitely changes. That means the patients who did well with the medical management early, that didn't do well later down the course. So the treatment which you are kind of accepting as the best modality of management is not sustaining for a long time. So that is the point you have to understand. So there are other publications which has come up, like the effect of stenting plus medical management versus medical therapy alone. This study has been published, and it resulted with not much of difference. And this is a one trial which came up with a little bit of promise. And again, this has been published from China, where by this time they gained a little bit of expertise which stent to use and how these lesions should be dealt with. And if we see wingspan, there are two trials, WAVE and WOMAN, which has been again published, where we see that with this device, the primary event rate has definitely has come down as compared to those previous things. And also, it shows the effect of that, and it tells actually, it emphasizes that only high volume centers with previous good track record should be selected to get a good result. Again, here the wingspan study, it is quite promising in this study which has been published. You can just go through that. So this is the kind of quite a busy slide. So this is of all the trials which has been published, where we see the VISIT, Sampris, WASID, and ECIC bypass have miserably failed to show any benefit of intracranial stenting, except these WAVE and OVEN, which showed promise in the later part of time. And if we compare the drug-eluting stent with bare metal stent, again, the drug-eluting stent did definitely well. Because of the fact that the chances of the neointimal proliferation with this drug-eluting stent is much lower. So, and this is statistically significant, although this was with one particular stent. But if you see the meta-analysis of the randomized control trial of the benefit of the drug-eluting stents, of course we are using the drug-eluting stent because it's all the cardiac stents what we are using nowadays. And it shows benefits. Obviously, there is no second thought that we have to use drug-eluting stent. But when we talk about the non-drug-eluting stents, how does it really matter? Now, this is another recently published, again from China, which showed really low rate of event, around 3 to 4% of the events which has been published. So these are the trials, obviously, we can cite with our patients. And so at this point of time, the fact remains is that only the symptomatic patients with more than 50% of the stenosis with failed medical management. So beyond that, there is no indication. And let's come to one or two examples here. On the right side, MCA, put a drug-eluting stent, you can come with a very good result. We see this, the CT scan, there's no bleed. Now, another patient on the same right side with a coronary stent, very soft and supple coronary stents you can track, but one thing is that again, you have to undersize the coronary stent and you have to take it very slowly and deploy to get a good result. And this is the diffusion, a very tiny lesion on the left side. Now, when you approach the bifurcation area, the things become a little bit difficult because when it is approaching bifurcation, you have to select like which branch you have to go through. And with your expertise, definitely you can go ahead and do that. But not all the cases can, behave in the same way. So this is another patient on the right side, exactly the same kind of lesion on the bifurcation, done exactly in the same way. Put the coronary stent, a very good result. At least in the angiogram, you can see all the perforators, but the patient comes with an infarct, second infarct. So it's not reproducible. So that's the point. It's not reproducible because you are not dealing only with the stenosis, you are dealing with the perforators here. And when we talk about the perforators, the incidence of perforator-related strokes are much more in the posterior circulation as compared to the anterior circulation. One more example here, the patient has got a tight basilar stenosis. We did with the balloon expandable stent, beautiful result, but the patient had a more infarct. The infarct size is increased. So in this case, obviously, the Credo stent has come, they have published their result, but I think the posterior circulation, because of very soft balloons, these stents probably are more predictable. And this is the patient's diffusion on the right side, done with Credo, and the patient did well, there is no problem. And one more study that has been published, what is the effect of the neuroform stent, because this stent didn't come to the market for treating the intracranial stenosis, but of the fact that these stents are very easy to deploy. You can go for a sub-maximal balloon angioplasty, and shows this study. It's a multi-center retrospective study, again from China. Again, it shows a clear benefit with very, very low complication rate. Now, when we talk about these lesions, we have to talk about what is the bailout intracranial angioplasty and stenting when you are dealing with mechanical thrombectomy. Now, this is again the study which has been published. All this, everything is there in the net. There is, you can just go ahead and treat that. So I'll come to the result of this study later. Now, this is one such case. The patient with a left-sided infarct, and we did mechanical thrombectomy. We use a combination of stent and the suction always. And you see there is a tight lesion here in the left MCA. Now what we do, we give tirofiban infusion and we wait for an hour or so and we see whether the vessel is collapsing or not. But if the vessel collapses, there is no other way. You have to go ahead and put a stent. So this is the way, but in most of the cases, we do not like to use stents in the acute case. Because of the problems, and this patient did really, really well. And when we talk about the result of this study, we see that again, in large volume, when we talk about the large volume, they do not show any benefit. So where do we really stand here? So obviously we have to see each case by its own merit and then go ahead and do that. So there is, we have talked about the stents, the balloon expandable stents.
Last 2 minutes.
Yeah. So balloon expandable stents, self-expandable stents. Now, there is nothing much left with the with the stents, only thing is that until unless we get a very soft stents which can be taken without much problem. But what are the future directions where the authors are thinking? That is identifying obviously the patient who will benefit from the therapy, identifying the correct patients, the role of plaque vulnerability. If we see by MR imaging the plaque is more vulnerable, probably we have to wait for some time. There are results which has been published. And we do not, all these trials have been based one fact that it has to be a tight lesion. But what about other things like the collateral flow, the infarction pattern? If it's a large infarction, so if it's a large infarction already has happened, probably they may not be a very good case to take. The location of the lesion, the hemodynamic status, so everything has to be considered. This has been published the computant flow dynamics we do not have in our machine now, but it shows the effect of shear stress and how it changes the prediction for the future stenosis which can happen proximal or distal. So this is very interesting article which has been published. And also we are thinking about, talking about the endothelial dysfunction, how we can see along with the high resolution MR imaging and also some of the platelet function expression which can really change the way we look at the intracranial atherosclerosis now. But the balloon angioplasty with drug-eluting balloon is again coming in a big way when we talk about minimizing the lesion, minimizing the complication of these technique. And obviously, drug-coated balloon may further improve the efficacy of the balloon angioplasty by using anti-proliferative compounds. So coming to conclude,
time is up.
At this point, we are really not backed up by the robust scientific data, but in our Asian countries, the data is coming up and it is helping us to develop this technique in a much better way and to understand the disease and come out with a better result. Thank you.
Thank you. That was actually the last talk in our session. Dr. Gupta is not with us at this moment to give his talk, so we can open it up for discussion. A couple comments that just came to mind during those great talks. I think ICAD is still one of our biggest challenges, and there's a lot of exciting work going on right now in developing better stents, better strategies, better things. OCT is going to play a role, I think. A couple things just in my experience with understanding in an acute case scenario, whether you're dealing with ICAD, some things that are helpful. Obviously from the patient presentation, someone that comes in with a relatively, they have a large vessel occlusion, but their stroke scale score is very low, especially if they're an elderly patient. That kind of makes you think that, okay, why would they not have a higher stroke scale score? They probably have, better developed collaterals because they have an underlying lesion. I kind of like to think technically when you J or wire, if you go, normally the vessel is an open vessel filled with clot. If there's an underlying ICAD stenosis, I call it the wire test. Your wire will get hung up there, and so that should make you think, okay, that's unusual that my wire is getting stuck and I can't easily go across where the occlusion is. And then obviously just looking at the, if you take your angio image, if it's not a meniscus, sort of clot bulging this way, it's a taper. Again, think underlying ICAD. You can drop a stent retriever. If I think that, I'm suspicious. I often drop a stent retriever and then do a run, and you can then see your underlying stenosis. So those are some, things that are helpful just when you're trying to understand an acute, vessel occlusion, whether you think it's an underlying ICAD stenosis. But let's open it up. Any questions or things on the talks?
Another takeaway from this symposium for 1.5 hours, since only very few are doing stroke interventions, few peripheral IRs, we need to start these stroke interventions. One of my moderators, a neurologist who does some stroke interventions, we need to be aware that at least peripheral IRs, the stroke population is phenomenally increasing. Similar to Chinese, we also have high incidence of stroke. We need to maybe peripheral IRs select the cases properly, like proximal IC occlusions or MC occlusions, maybe get us some guidance and go for an aspiration, which is a slightly safer technique. You can go for an aspiration. When you can get a result, then you can go distally. One of the speaker, Reshmi, showed some distal migration of the clot going into A2 and removing it and all. My mentor, Professor Gupta ji, is there. He used to tell enemy of the good is better. Never go for the distal lesions initially itself. Stick on to the proximal like an ICA, MCA, M1, that is much better. Initially aspiration, if it doesn't work, go for the Solumbra technique. Because the stroke burden for a country like in Europe, it's also increasing. We need to, once we show some results, referrals will increase. Because neurologist is also, maybe he might give his comments, he's also doing a stroke thrombectomy, all neurointervention procedures.
So mechanical thrombectomy is the patient selection is very important, and your techniques is the MR images will give a lot of information what clot we are going to deal with, and everybody will develop their own techniques also, and sometimes we need to choose a technique as the double stent technique. When you are seeing a saddle type of thrombus which is lodging into two territories, that is not going to get away easily, and once you do the first pass and if it doesn't pass and the vessel lumen is very irregular, you're dealing with ICAD. And the role of intra-arterial tirofiban is coming up, is we are using it in ICADs to see like when you give tirofiban, the lesion gets better, and then it sometimes avoids the stenting also. And the more you put the stent, like 3 passes, the vessel is definitely going to get injured. And an injured vessel is always going to reocclude again and again. So 3 passes, like change your techniques, use tirofiban as a supplementary and see like, and sometimes you don't need to deploy the stents. In dissections, keep the stent retriever open for a while. It will stabilize, and then it's same like when you open the balloon in a perforated vessel, it seals the perforation, same way the stent, if you open the stent retriever and keep it for a while, the flow goes, the brain cells receives blood, and then don't deploy the stents, withdraw it. Of course, it's cost effective, but you can see the dissections healing off during thrombectomies.
Do we have some questions? Anybody?
Yeah.
Don't be shy. Yes.
How far IVUS will be helpful in ICAD in deployment of stent as well as doing balloon plasty, plain balloon plasty? IVUS.
So IVUS, you want to use IVUS for the ICAD?
Yeah. Any data or any?
As of now, I think for neuro, IVUS is not available.
Yeah, we
the
have
same catheter cannot be used for coronary.
So we started using intravascular ultrasound for ICADs, especially it's a 3 French thing. It has to pass through that narrow segment. We have to take it distal across the stenosis, and it's an automated pull which will scan up to the things. It will give a lot of informations. If you are going to see a fibrin ridge, like throughout the fibrin ring, this circumferential, it's almost a burnt out vessel. When you put a balloon or a stent, it's going to dissect. That information is very useful with IVUS. And if there is a lipid core, like means it's letting us the ultrasound to pass through, and it's not getting reflected. Those are soft blocks where a balloon and stent works very well. It also gives information like what are the perforators are arising from.
Really.
So most of the blocks are inferiorly located and superiorly the perforators will be arising. The snow plowing effects. So when you inflate the balloon, the blocks around the perforators gets pushed into that perforators and causing lenticular stria. In fact, that can be avoided when you use IVUS. So mostly you can look at the fibrin and the calcium, active thrombus on the surface of the block. All these will give an information, and also you can choose where to land the where to land the stent and choosing the length of the stent will be very useful in IVUS. Only thing is a 3 French
is
it should allow 3 French to pass through.
Any other questions? Sharad?
Patient comes to you with, let's say, at 3.5 hours. So would you prefer to bridge it, or you would directly take the patient for thrombectomy? Because I've seen.
Can you please repeat it?
Yeah. So a patient comes to you at 3.5 hours. So you give IV TPA followed by mechanical, or you would prefer to take the patient directly for MT?
Yeah, I think certainly the necessity for it is in question. But from just a medical legal point of view in U.S. anyway, if they're eligible and they're within the time window to get lytics, they still receive it. A big caveat of that is if you have a carotid T occlusion, as we all know, or tandem occlusions, lytics are not going to have an effect, or a large clot burden. So as long as it doesn't slow down the process, if it's, if someone's presenting to my hospital or we have a pretty well-oiled machine, we can often, say, hey, let's just take the person right to the cath lab. I don't know, in India, have you basically gone to TNK versus TPA?
Time is
now
up.
most people giving TNK?
Yeah, so
of
TNK.
So I would say with TNK, we are seeing some of the larger vessel occlusions recanalize, and we're certainly seeing a better success rate in all the M2 type of clot, burden. So I encourage people to get lytics, especially if they're a transfer or anything, or there's going to be some time. Give them TNK because it can definitely help in those scenarios.
So the problem we face is MT following TPA. There is fragmentation. There occurs some kind of distal clots which we cannot actually see on your angiogram, but on MRI and the patient's clinical neurological assessment, the patient is usually not that well as we've seen when we take the patient directly for MT. So that's a personal thing which I felt in the last few cases of mine. So that's why I thought.
Yeah, I think, there's obviously it's a more effective lytic agent, and I think the clot is a little more friable, fragile. So, I think technique-wise, it probably favors a little bit of aspiration where you have a more controlled, just deliver, the proximal face of the clot and vacuum it out with a lot of clot manipulation. If you use a stent retriever, cheese cut, some more fragile clots have a higher risk of fragmentation, I think, in that scenario. So probably favors, if they have lytic, especially TNK, to do an aspiration and do minimal clot manipulation.
Right. Thank you.
Yeah, just one comment, sir. There is a trial which they have done successful TK3 recanalization. They injected TPA inside the blood vessel. And they showed that if you are injecting TPA after successful recanalization, the functional outcome becomes better. They say it improves the microcirculation. So we thought that if you do thrombolysis, take for thrombectomy, patient might be worse, but this trial is showing something opposite. If you inject TPA after thrombectomy, the functional independence become better. Within window, yes.
Yeah, we did. We've sort of come full circle a little bit with that. I think like that there is cleaning up some downstream and this whole futile recanalizations where you get a vessel open. There's a clinical mismatch. The patient doesn't do as well as you'd expect. And the theory was that there's probably some microcirculation damage in those cases. I don't know how big a believer, truthfully, I am in that. I think I'm a minimalist a little bit in hemorrhagic transformation, stacking, all of those things, and even the when to quit. I think in a lot of cases when you certainly if you're starting, the main goal is to open the proximal occlusion. If you open that M1 occlusion and there's a little bit of M3 distal stuff, some pruning of the branches of the tree, I would favor almost quitting at that stage. And I've looked over time on MRI how many of those branches, those way distal ones, take a diffusion hit, and it's very, very few. In other words, clinically, when you restore the flow in the main occluded vessel, flow is a good lytic, and it'll often lyse that smaller clot burden. But I know that there is a, people are doing, putting a little bit of lytic in after to try to, kind of clean up any fragmentation. But I think I'd be careful, especially if we're doing more extended time window patients, for sure.
Thank you. Since we are lagging in time, we'll wind up. Thank you, the organizing team, for giving a wonderful opportunity.
I request all the presenters for the Extreme IR session to be ready with the presentations. You can submit them on the desk over there. We'll be taking down the wall and then we'll start the session shortly. Thank you. All, we can start the Extreme IR session right now. I request everyone to be seated for the session. Everyone, please be seated. I invite Dr. Saurabh Kumar onto the stage. Dr. Saurabh Kumar. Extreme IR.
So it's a 10-year-old male child with a history of liver dysfunction, refractory ascites and recurrent melena for the past 1 year, now presents with hypertension and severe anemia. After initial hemodynamic stabilization and endoscopic vessel bleeding control, CT imaging was performed. So CT image, there is almost absence of all the hepatic veins. The portal vein is replaced by collaterals. No intrahepatic or extrahepatic portal vein is there. No splenic vein. The proximal and mid SMV is also replaced by collaterals. So it's basically a total chronic blood cherry with total extrahepatic portal vein obstruction. And the only in last image we can see a prominent umbilical vein draining up till the junction of left portal vein. So there was persistent melena and clinical deterioration, and surgical opinion of splenectomy or is also not viable as there was no shuntable vein. No route for conventional tips or dips, neither the transhepatic, transsplenic or transmesenteric route was available. So then the umbilical vein access was innovated in this case, but unconventional idea. Despite limited confidence, we proceeded with the umbilical vein access. So we planned portal vein recanalization with dips, PVR dips through the paraumbilical vein access. So we first punctured the umbilical vein and 6 French flexor sheath was inserted within. Then we used multiple wires and catheters were used to negotiate the tight stricture and fibrosis. So both the soft end of Terumo hard end, then command wire was used. Then when the wire goes inside, the catheter doesn't go, so we use special catheter, seeker catheter was used, which has a hard and sharp end. So the portal vein starts to open up. We found a way to reach till the distal end of the portal vein and enter a prominent enlarged dilated splenogastric collateral. So we thought that we should make this as an inflow towards procedure. This is a large dominant. The first image is showing dominant splenogastric collateral. We balloon dilated the tract. However, the tract was frequently collapsing. Likewise, we also reached the mesenteric collateral and was able to dilate that also. So we then, after dilating the portal vein tract, we tried to connect the both. We started dips planning. We approached to the transcaudate route, and we initially start with the balloon-assisted tips. We make the fluoroscopy target as a semi-compliant 8 mm into 40 mm balloon. However, when we puncture the balloon, in this image we can see the puncture the balloon, the wire just stuck in the last image, so the wire doesn't go off in the distal portal vein. And the balloon, when we retrieve the balloon, this is a distal ruptured fragment of the balloon which stays over the wire. So to retrieve it, we did a ballooning over the second wire and balloon trapped the fragment. And with the help of snare, we retrieve that trapped balloon fragment. So with the help of snare, we retrieve the trapped balloon volume. This is a trapped balloon, broken balloon fragment. So now we have already tried balloon assisted tips. So now we set the target as a snare. We use as a target for the snare assisted tips. So with the help of snare, we are able to negotiate the wire from the IVC, so SVC end into the hepatic. This is a wire which is gone inside the umbilical vein, venous access route. Then by pushing the wire, we are able to finally push the wire into the main portal, recanalized portal vein track, as seen in the last video. So now we have access from the normal dips access. So we balloon dilate the track, we put a covered stand, and first the covered stand was post fluency around 10 centimeters, 10 into 10, then followed by uncovered stand, and we achieve a good flow in the final run. This is we have made the distal splenogastric collateral as a normal inflow. So we coiled the track. This is a interlocking coil. The umbilical venous root was coiled at the end of the procedure. So the procedure resulted in significant decompression of the portal system with symptomatic improvement. Post-procedural, there was shunt was patent. It is a 3-month follow-up Doppler showing normal and adequate flow. There is no recurrence of ascites and bleeding in the child, and the child is clinically stable. So, as you know, parambilical vein is one of the portosystemic collateral commonly seen in CLD patients. It has been utilized for the embolization of gastroesophageal varices, stromal varices, and is found to be a safe access. And also in the pediatric liver transplant patient, preoperative portal vein thrombolysis has been done through that tract. We utilize the parambilical vein for entering and recanalizing the portal venous system, and then did PVR dips through it. For parambilical venous access, ultrasound guide puncture is generally, with a macropuncture is generally used, and the straight segment should be selected ideally 2 inches above the umbilicus. And at the end of the procedure, closure can be by simple compression. Coils or plugs can also be used. So the combination of intrahepatic venous flow obstruction with portal venous occlusion often precludes standard approaches, necessitating innovative endovascular strategies for re-establishing portal inflow and decompressing the congested liver. In challenging vascular anatomy, when conventional route fails, the parambilical vein can become the interventional rescue route. This case highlights the viability of parambilical vein assisted PVR deals as a salvage technique. Thank you.
Thank you, Dr. Sharab. It was an interesting case. So we just lost the initial bit of it. Can you go to the first slide, since we have time? Can you go to the first slide? Can you go to the first slide?
First.
Yeah. So the clinical presentation part. Okay. Continue.
This is normally we see bud cherry, we see EHPO, but combination we haven't encountered first time.
Okay.
Even we asked the surgical department but there was no shuntable vein. After splenectomy, we are unsure that because since the hepatic veins were not there, so the system will be decompressed or not. The surgeon was also not sure. So only the visible everything in every image you see that this is the dominant parambilical vein. So we started with this and did the whole procedure.
So where was the access taken? Near the umbilicus?
Yes, sir.
The access was near the umbilicus?
Access was above the umbilicus, 2 inches above the umbilicus.
Okay.
In the anterior abdominal wall. I don't have the ultrasound image of the puncture, but in the midline, straight segment. Okay. Then we put the flexor sheath, 6 French sheath. This is the umbilical puncture above the umbilicus. This was the straight segment. Then we put a sheath, then again with the wires and catheters, we recanalize it, then connect it to the...
Okay. So the cannula and the wire goes to the splenic vein from the parambilical vein.
Yes.
It's going from the parambilical vein to the splenic vein?
From the parambilical vein, we entered it. Parambilical vein was opening at the junction of the left portal vein.
Okay.
So the left portal vein was also chronically fibrosed. So we just, with the help of catheters and wire, we started making it. Repeated balloon dilatation were done. So we are able to get the anatomy and able to reach this dominant collateral. So this was the dominant collateral. We thought we will make this the inflow. Since no splenic vein was there, so all the splenic blood was also shuntable in these collaterals only.
Got it. That was a very good case. Thank you very much.
How about the clinical improvement you have assessed after the procedure?
We have a 1 year follow-up, sir. 1 year follow-up is there. There is no ascites or recurrent virus bleeding. 1 year follow-up is there of this patient.
Okay. Thank you.
Thank you.
invite Dr. Prabjot Singh Chauhan to take the next talk.
A very good afternoon to one and all present here. So the case that I'm going to present today was one where we bent beyond convention and performed an intrahepatic extra-anatomic biliary drainage for isolated post-transplant bile ducts. So our patient was a 41-year-old gentleman who had undergone a living donor liver transplantation. And as far as the biliary anastomosis was concerned, it was a single duct-to-duct anastomosis between the donor right hepatic duct and the recipient common bile duct. Now, in the post-operative period, the patient had persistent direct hyperbilirubinemia. So an MRCP was performed, which showed an anastomotic narrowing with upstream dilatation of both the right anterior as well as the posterior ductal systems. This patient therefore underwent an ERCP and biliary stenting. And these are images showing the retrograde cholangiogram. In the first image here, you can notice the paucity of ducts with the pacification of only the anterior ductal system. So a guide wire was negotiated into this system and followed by placement of a 7 French plastic stent. However, despite best attempts, the posterior system could not be cannulated in this case. So in the post-ERCP phase, this patient continued to have persistent hyperbilirubinemia with values ranging around 5.8 of total T-bill. A repeat MRCP was performed which showed a persistently dilated right posterior ductal system. So the patient was then referred to us for draining this, so for a PTBD. So we took access via the segment 6 duct using a 22 gauge Chiba needle. And this was the initial cholangiogram that showed complete cutoff of the right posterior sectoral duct with absolutely no passage of contrast into the common bile duct. This was an RAO view that was taken, and we felt perhaps that this was the site of the beaking and from where we should try crossing into the common bile duct. And so we tried doing that, and we also felt that we got close. But since we could not pass in a guide wire down the CBD, we put in some contrast and we just saw that we were just creating some false tracks. So we had to abandon this and we put in an external drain into the segment 6 duct. So all attempts at internalization failed over 3 sessions by 3 different operators using all possible catheter guide wire combinations. So therefore this patient was evaluated for feasibility of an extra anatomic biliary drainage with the intent of making the patient tube free. Now, these extra-anatomic drainages are procedures where you bypass the normal anatomy of the biliary system to create a drainage route between the liver and the GI tract. So this may be intrahepatic, wherein you connect duct to duct, or this might be extrahepatic, wherein you create hepaticogastrostomy, or you do a hepaticoduodenostomy. So the planning involved a multi-phase CT, which was performed with an inflated stomach, with diluted contrast also injected via the external PTBD catheter to allow precise mapping of the posterior duct relative to the anterior duct, the D1 duodenum, the stomach, and the vascular structures. So at one particular axial section of the planning CT, a feasible straight line trajectory was identified. I'm sorry, there's some error here. Yeah. So a feasible straight line trajectory was identified. Could you help, please? This animation is not working here. Right. So at one particular section of the planning CT, a feasible straight line trajectory was identified passing through the stomach, the D1 duodenum, the stent in the anterior duct here, and the PTBD in the segment 6 duct. And all of this while avoiding the major vascular structures in between. So the intent here was to create a duct-to-duct communication which would enable passage of a guide wire from the posterior system into the common bile duct. So with that plan in mind, we took this patient up for the extra anatomic biliary drainage under general anesthesia. These were the initial cholangiograms that were performed, and then the stomach and the duodenum were distended, and herein you can see a catheter and wire in the posterior duct. You have the stomach and the duodenum distended here, and you see the plastic stent in the anterior duct. Next, a cone beam CT was performed after distension of the stomach, recreating the planning CT to execute the planned procedure, and we compared it with the arterial and the portal venous phases from before, so we were sure that there was no major vascular structure in between. So the working angles that we chose for this particular patient were the bullseye view in the LAO and a perpendicular angle to it so that we would create a profile view for that. So this is the bullseye view that was there. So you see the distended stomach, the dilated duodenum behind it, then the stent in the anterior system, and behind it is a snare device in the posterior duct. So this is what it looked like in profile. So we started off by putting in a percutaneous 18 gauge needle through the stomach, and the intent was to finally create a tract right up till the snare here. So this is what it looked like on the bullseye view, and this is a video here. Now this was an important step because we first had to demonstrate that we were actually going through the anterior duct and that we were not missing it. So contrast was injected here, and you can see your pacification of the anterior system with contrast going down the common bile duct. And subsequently, a coaxial 22 gauge needle was used to deliver an oven 4-inch guide wire into the snare loop within the posterior system. So this is a video showing a V14 wire being passed and subsequently being snared, and therefore we were able to establish a through and through axis, and therefore we then advanced the 6-French sheath over this, injected some contrast, and we could pacify the bridge between the posterior and the anterior ducts, and finally we were able to cross an 035 wire into the anterior system, and then we just pulled it back a little and negotiated down into the duodenum. So once we were sure that we were in the duodenum, after injecting contrast, we were then able to give up the percutaneous axis, and subsequently we put in a measuring pigtail because we basically had to measure the distance that was there, the length of the tract that was created between the posterior and the anterior ducts. This is a lateral view image showing approximately 5 centimeters of gap between the posterior and the anterior systems, and subsequently performed plasty using 6 mm balloons. And finally, we put in a 10 French internal external ring biliary catheter. So the important point at this step was that we wanted to ensure that there were no holes of the PTBD catheter within the tract, so which is why we did that measurement using the measuring pigtail. So as you can see, the side holes were all either in the anterior duct in the CBD, and this area here, basically the bridge that was there, this was devoid of all holes, and then you have holes here draining the posterior system. So this was our final spot showing that we have established an extra anatomic but physiological biliary drainage of the posterior ductal system. And finally, at 3 months from the procedure, this patient underwent a rendezvous procedure, and we were successfully able to place plastic stents, and the patient was made tube-free. So to summarize, when conventional methods fail, there are still multiple options available to the interventional radiologist for establishing biliary drainage, and sincere efforts must be made to make the patients tube-free, especially in transplant recipients. And as I've already said, the various techniques that you can use include extrahepatic
Last 2 minutes.
such as hepatogastroscopy, hepatoduodenostomy, intrahepatic procedures such as the one we just saw here, and then you can have rendezvous techniques. So these are cases wherein you may say you may have a collection along the cut surface of the liver, you're able to pass a guide wire from above, but you're not able to cross into the CBD. The gastroenterologist is able to come down from below into the CBD but not gain access into the intrahepatic system. So that is where you can, park your system there and they can just do a rendezvous and establish a through and through access. So as you would have understood by now, it's all about planning, planning, and planning. So an individualized, case-based, and a meticulous planning is key in order to choose the right procedure for the right patient. In the end, I'd like to acknowledge the entire IR team at Medanta under the very able and dynamic leadership of Dr. S.S. Vejo, sir. I'm sure everyone in the hall here knows that sir is the genius behind all the extreme and innovative IR that happens back at Medanta, along with our own master blaster, Dr. Anubhav Khandelwal, sir. And it is an absolute honor for young IRs like me to be part of such an amazing team. Thank you very much.
So, Dr. Prajyot, it was an excellent presentation. And I just have a few questions. What is the long-term goal for this patient? When you remove the stent, does the tract remain patent?
Yeah. So on subsequent follow-ups, this patient did develop some dilatation of the intrahepatic biliary system. So he underwent a stent exchange. He is on current follow-up. So right now his biliary system is decompressed. It's almost 9 months now that the patient is under follow-up.
So would you agree that this is not a permanent procedure for this patient?
Yes, I think we would, but given the current circumstances, this was the best we could do for him to establish a physiological drainage of the biliary system. But yes, as you very rightly said, the long-term results will have to be observed because there are very few such cases that we have performed. He's just the third or fourth patient that we have done. And there's not much in literature also. There is literature regarding hepatogastrostomies and hepatoduodenostomies, but creating a duct-to-duct connection intrahepatically is something that's not there in literature. So the long-term results will therefore have to be seen. Yeah.
So what was the surgical opinion for him? I mean, was there any contemplation of a new anastomosis like hepatoduodenostomy or something?
No, so the surgeons were not, no, they were not interested in reoperating.
They were not interested.
Yes, which is why we went ahead with this. Yeah.
Okay, thank you.
Thank you.
Thank you. Thank you.
Good presentation.
Thank you.
Thank you for the great talk. I invite Dr. Suraj Bhame for the next one.
So, good afternoon, everyone. Let's see, with the help of willpower and with much patience, what novel approach we have developed for our case of transarterial chemoembolization. So, this was a case of a 55-year-old gentleman who presented us with a pain in abdomen. On serum biology, tumor markers, AFP was on higher side in the range of 4700s. Serum CA 19.9 was 24. Liver functions were quite good. CT child-pox score was A5. On CT triphasic angio, we saw the arterial phase hyperenhancing lesion in the right lobe of the liver. So this was a scan which showed that on the right side you can see the arterial phase hyperenhancing lesion with multiple satellite foci surrounding to it. So when we saw the celiac artery, there was a critical stenosis with a complete occlusion. There was a big calcium bar which was sitting at the origin of the celiac. However, SMA was free in this case, so that was one of the possible access. Since this patient was not symptomatic for celiac occlusion, we first tried a celiac cannulation. So according to the BCLC criteria, this patient fall into the stage of intermediate class B, where multiple nodules were seen with preserved portal vein flow. So this was a BCLC B stage with for which the TACE was offered as a treatment of choice. So this was a non-negotiable celiac occlusion. We came from the radial axis. We knew that this will be the tight critical stenosis occlusion. So we tried multiple long sheath, multiple angled catheters and multiple microwires and catheters, because of which also we were not able to cannulate the celiac. Since this patient was not symptomatic for celiac occlusion, we tried switch to access over to the SMA. So in SMA also you can see there was a big collateral and multiple, with the help of multiple tortuosity, our catheter finally could track to the inferior pancreaticoduodenal collateral and finally reaching up to the GDA. But however, since because of this long track, our microcatheter lost the track and trackability. After this point of time, we are not able to take out this acute 270-degree turn. We tried multiple angled catheters and angled wires. After that also we were not able to cross this acute 270-degree turn. So now we have the patient who has a non-negotiable celiac occlusion, and we have the microcatheter which was sitting inside the SMA, which has already lost its torque and trackability because of long tortuous course. So we thought something out of the box. So we did the ultrasound of the spleen. We could find intra-parenchymal lower pleural branch of the splenic artery. So that can be targeted under ultrasound. So we used the 4-French micropuncture set from the Cook. 21 gauge needle was used as an access needle, through which the 014 wire was parked inside the splenic branch. After parking the microwire, we did the cannulation with the help of 4-French 7 centimeter micro sheath. So this was a prelude sheath from the Merit, because of which it has a glide coating out on its outer aspect, because of which it will be less traumatic. So this was a run which was taken from the lower splenic branch, which showed that there is a good opacification of the lower splenic branches. So it's not playing. So after which the case was quite straightforward. We did the cannulation with the help of 4-French glide cath, cobra catheter. Since there was again tortuosity because of the tortuous splenic artery, we could able to navigate this tortuosity with the help of glide cath. On hepatic angiogram, you can see 2 feeders were there for the tumor arising from the right hepatic artery. The selective cannulation of these feeders were done with the help of 2.4 French 130 centimeter prograde microcatheter. Since this was our on the only access we could get in this case, we went higher on our chemo drug. So 75 milligram of doxorubicin was used, followed by 12 milligram of 12 ml of the lipidol. So these were the runs which were taken from the runs were not playing actually. These were the runs which were taken selectively from the right branches of the hepatic artery, which showed that there was a good opacification and all the tumors feeders were embolized. So After we did our chemoembolation, we finished our case with the help of sheath removal. So while taking out the sheath, we did the track embolation with the help of 50% glue. So we made sure that the glue will have good percolation along the splenic tract and in the perisplenic area. So this was a case which we done for the case of occlusion. On 3 months follow-up MRI, you can see the good amount of necrosis. The entire tumor has undergone non-viable, and this patient had a 6-month follow-up scan also, which again showed that patient is not having any recurrent foci of the HCC. So when I did the review of literature, there was only one case which was published in Extreme IR in JVIR in issue of 2021. So in this case, the author, this was a case of post-transplant splenic artery still. There was already proximal splenic artery ligation was done by surgeon, for which again patient presented with the hepatic splenic artery still, for which they did the GD embolation. Even after embolation of the GD, you can see there is paucity of the intrahepatic vascular opacification. After which, again here, you can see multiple collaterals where they are peripancreatic and perigastric, because of which splenic artery could not be able to negotiate it from the celiac side. So here also author did the splenic artery access from the lower pole. This was a run taken from the lower splenic branch. And embolation was done here with the help of PV and coils. And after embolation, you can see there is a good opacification of the intrahepatic vasculature. So my take-home points will be, this is a very novel technique for TACE, which can be done in cases where there will be celiac occlusion, and if a patient is having tortuous SMA, which will prevent the access into the hepatic vasculature. Cases are usually done under general anesthesia with suspended breathing, because you have only one access and you can't afford to lose that access. So always target the intraparenchymal branch of the splenic artery, because if you target the extraparenchymal, there will be always the risk of bleeding. And when you come out, always have a good track embolation with the help of 50% glue. Thank you.
Nice case presentation, Suraj. Yeah. How big was the spleen? It could have been quite challenging to get a splenic access.
Yes, sir.
Yeah, splenic artery access especially. Yeah.
Yes, sir. So we took the help of Doppler also, ultrasound Doppler. So we usually targeted the area which was just intraparenchymal, more towards the hilar area. So there was the area hardly 3 to 4 mm in size, but it was quite challenging, but we could able to get it.
Okay. Nice case.
Thank you, sir.
Dr. Suraj, it was a good case. Just one more question. So when you did the angio finally after reaching the hepatic artery, there was some blush in the portal vein. Was it a portal vein shunting or is it a portal vein tumor thrombus?
No, sir, there was no evidence of portal vein thrombosis, tumoral thrombosis. So.
Okay. Fine. Thank you.
Thank you, sir. Sorry, sir.
Can someone give a mic?
Yes, sir. Celiac recalculation, we tried it for 1 hour, good 1 hour. We took access. Yeah, that also, sir, we tried. Our microcatheter wire was not crossing from that point, and even at the end of the day, we thought that patient was not symptomatic for celiac occlusion. So our main aim was to just have a access inside the hepatic vasculature to do the test. So splenic occlusion recalculation was also tried from the splenic access after finishing the test procedure. Even that was not possible.
Okay. Dr. Lijesh.
So actually, the first question was exactly what he asked, because we all know that the lesion is going to come back. It's an infiltrated lesion. TACE is not going to hold for a long time. And I think the tumor markers are already started rising as you speak. So one thing, infiltrated lesion, and as I said, there is a suspicion of portal vein means blush also. So TACE for these lesions, if in my practice actually we don't do TACE for these lesions, or we stop doing TACE for these lesions completely, is either TARE or SBRT for us. So for a patient, for a procedure, it's going to be at best palliative. Was transsplenic access justified? One thing. And because it may be that the patient is not affordable, maybe for some reason he's not a candidate for anything else, we have definitely tried to recanalize the celiac access. Because any repeat procedure, again, probably you are going for TACE itself, right? Yes. So again, you're going to take a transsplenic access. If celiac artery had been recanalized, repeat procedures would have been much simpler. But as you said, you have already tried, so that negates the point.
Yeah. So, sir, these cases we usually keep under close follow-up. Like we do follow-up scans every 3 monthly. Even if we get the HCC foci, that will be very small and maybe amenable to the ablation. So that is also one modality which we can offer in follow-up.
Time is up.
Was the patient started on any adjuvant chemo or immunotherapy?
Yes, sir. Lenvatinib was tried. Yes, sir.
Okay,
Lenvatinib
thank you.
was given.
Yeah, sure. Thank you.
Thank you, sir.
The next speaker.
Thank you for the great talk. I invite Dr. Santosh Babu for the next talk.
Good evening all. I'm Dr. Santosh. I work in CMC Valo. So I'll be talking about a case, a very interesting case, which I call as salvaging the unsalvageable. So this is about a transplant hepatic artery blowout, which we tried to reconstruct in a very tortuous anatomy. So I'll be talking about the case introduction, sequence of events which has happened, imaging findings in these patients, option of treatment which was offered there and even discussed with the MDT, what are the technical challenges in this case, what we thought out of the box and how we executed in this case, and I'll be concluding with some take-home messages. So this is about a 45 years old male, known alcoholic, liver cirrhosis with gross abdominal distension, with gross ascites, planned for liver transplantation. So he underwent a cadaveric liver transplantation on September of last year. So initially he was post-transplant, he was doing good, and he was discharged in stable condition. So after 25 to 30 days post-transplant, suddenly he landed up in emergency with pain abdomen, yellowish discoloration of the sclera and urine. So blood investigation was done. So this was the blood investigations. So his bilirubin was raised, hemoglobin was stable, SGOT and SGPT was also normal, and WBC was within normal range. So an MR was done. So you could see mostly post-transplant biliary stenosis stricture with intrahepatic biliary dilatation. And a small collection, as you could see on the stars, both on the anterior surface of the liver as well as at the anastomotic side, there's some collection, small collection. So patient was taken up for ERCP and ERCP guided plastic stents were placed. Post-stenting, patient was symptomatically improved. He was stable. He was shifted from ICU to ward and his bilirubin levels were come down as you see. Initially it was close to 3, now it's 0.8. Hemoglobin stable, SGPT and SGOT has also come down. The WBC is in the stable range. So this is a follow-up ultrasound. There is no major intrahepatic biliary dilatations. So this was, after this, he was still in the hospital. 3 days later, suddenly he presented with an episode of pain abdomen and melena. Initially he was tachycardic, but settled over time. His HB has dropped from 8.9 to 6.8 and even his bilirubin levels has raised up. So now it was a little warning because it was melena and the HB was significantly dropped. So MR was done because of the raised bilirubin once again. Small collection, that anterior part has come down, but at the anastomotic site the collection has slightly increased. Because of the melena we did a CT. CT, there you could see an hyperdense content at the anastomotic site on the plain scan. And on the contrast, you can see small outpouching, very suspicious, but not very convincing. But because the multiple ligated branches were there, not very sure on that. So we did an MDT with the HPP team, the liver transplant team, and as the IR as well. As the patient was hemodynamic stable, and it was a single episode of melena, and patient was also stable vitally. So even the surgeons told it could be a ligated stump. Sometimes they place a clip, and sometimes they ligate there without a clip. So here there was no clip adjacent to it, but they thought most probably it's a ligated branch. So surgeon had thought it's a ligated branch, and because it was very tortuous anatomy, single episode of melena, single artery supplying the whole transplant liver, we thought we also were not very aggressive to go ahead with this because patient was stable, single episode. So we did just a diagnostic angiogram to see how it is. The anatomy was significantly tortuous, as you could see. There's almost a 360-degree loop at this level. If my it's not seen. Okay. At the distal end of the hepatic artery proper, you can see a 360-degree loop. Then it's coming down and going up. So we also gave up the thing like we wait and watch. The patient was shifted to HQ for monitoring. A single unit of blood transfusion was done. He was doing well. No further episodes of melena. So this was the parameter because they transfused HB has picked up. Other things are all looking normal. So suddenly after 3 days in ICU, he massively bled again. It was 4 to 5 episodes of melena. Is tachycardic, hypotensive. They resected him with fluids and as well as blood transfusion. CCD done, abdomen was done. HB was dropped once again from 8.2 to 6.5. Now we repeated CT. That hyperdense content on the plane scan once again it's increased. And now which was looking very suspicious has now blown out. Initially there was a single area of outpouching. Now you could see on the third image there is 2 outpouchings. On the coronal, if you could see, it is significantly blown out. Very large. One is looking like a figure of 8, another one is a very bulbous one. So this is the line diagram, if you could see, that is the anastomotic area where it is taking in a U loop, and this is 360 turn. Actually, it's not a very straight segment at the common hepatic artery. It's once again have 2 wavy, like little torches there. So that was the initial small outpouching, which we thought it's a ligated branch, but this is the present scan. So treatment options, surgical team was called up and endovascular, we all sat together, but surgical team clearly told that it's 30 days old, we are not going to go in, very high risk, and even an expert opinion was taken out from the CMC as well, outside CMC, but the surgeon outside also, they told they are not going to touch this case. So endovascular, this is tortures, we are also very not sure because going out, how to cross this and how to reconstruct this blown out segment, because it's a single artery, if something goes wrong, then we are landing up because surgical backup was also not much there. So surgery was out of the picture. Endovascular option was attempted, but can be attempted, but with high risk. But another thing was even the HPB team was like, if you're not going to do, we are going to refer the case to cardiology because at least let them try, because if you're not going to try. So we thought we're going to try it. So I'll skip that part. So we cannulated the celiac trunk with an 8F long sheet. Then it was a Cobra glide catheter inside the common hepatic artery. That is the 2 pseudoaneurysm which you can see. The third image on the star, it's completely blown. It's almost that artery is eaten up. So we put a long sheath, 8F long sheath, and then we took a Navian inside, 6 French Navian. And then we crossed the pseudoaneurysm using Prograde microcatheter and exchanged with a Fielder FC 300 centimeters wire. So after that, we started to reconstruct with the graft master. We started to reconstruct from the distal end to the proximal. The first initial 2 graft masters went on well, but when we taken the third graft master, it was not going in. The long sheath kicked back, the Navian got kinked, but the wire also kicked back. So we were forced to deploy that stent graft in the proximal limb itself. Anyways, we are thinking to reconstruct as a U. So we deployed this graft master here itself, pulled out all the system, and once again we tightened up the axis. Instead of triaxial system, now we took quadriaxial system. Inside the long sheath, we took a seribase. Inside the seribase, we put the Navian again. We cannulated with Prograde, put a Fielder FC wire, reconstruct the whole segment. The center part of that U was very, very tight.
Last 2 minutes.
It was not allowing the stent graft. We took the Navian close inside the descending limb, wherever the previous graft. We went inside that. You can see that nicely. The Navian is inside the descending limb graft. Then we negotiated the graft master there, and we deployed that. But after deployment also, the pseudoaneurysm was still filling because it's a very U type, and all these 10 grafts, multiple, it's almost close to 6 graft master which was placed. Whether opposition has happened or well, not very sure. And then we ballooned this gently, not very much because it's all blown out segment. Gently we ballooned it whether it is opposing well, but still it is not. After the ballooning also, still the aneurysm is still filling. You could see that the star I am showing it, that the pseudoaneurysm is still filling. So no other option was there. After that, we thought whether we should telescope multiple other graft master inside or just to wait and watch. Surgical call, but it was not happening. So the surgery clearly told that we are not going to do anything. So we thought out of the box. We thought, can we do something? So we thought whether we can percutaneously access this under fluoro guidance, because ultrasound not at all visible. And with the balloon protection, across the stent grafts, we injected glue, 33% glue, and we sealed it, made sure that no glue enters into the graft masters. After that, this is the glue cast, you can see both the pseudoaneurysms. And then this was the final angiogram, all the intrahepatic branches are filling, the U is completely reconstructed, there is no filling of the pseudoaneurysm. This is the final image. Patient was shifted well, no melena, blood transfusion, we made sure that the HB is at least 8. Suddenly, the next day he dropped HB. Again, CCT abdomen was done. I'll go a little fast because it's a few seconds. So the intrahepatic branches was good. No pseudoaneurysm was filling. But luckily, we picked up the pseudoaneurysm at the groin because 8 French sheath. Patient was already bleeding. His We were given a little bit of antiplatelets as well because of the graft master. Then we compressed it with 2 sessions of manual compression using
Time is up.
and the patient was discharged well after that. His HP came up. 1 month follow-up, doing well. HP is stable, bilirubins are good. On ultrasound, the Doppler is picked up on the hepatic artery. Pseudonym is not filling. Once again, CT was done 1 month later. Intrahepatic branches are good. This was the VRT images. You could see how tortuous it is, and the glucose and all are sitting, and how nicely the graft master has taken up. This is follow-up after 2 months, no filling, and they even exchanged the plastic stents. So take-home message, liver transplantation is a well-known surgical procedure with its own post-op complications. Initial 2 weeks to 15 days, they can re-explore by the HPP surgeons if any vascular complications happens, but after that, it's all endovascular. Management plays a pivotal role in rescuing the transplant vascular structure to prevent graft resection. Always work with an MDT. Decision-making in this complex cases will be better. So hard work pays off. Tough roads always leads to fruitful destination. I'll end up with one last thing. I was going for an haircut. And after the haircut, in the midway, the barber told, like, you're looking very handsome these days. Then I was thinking, is he talking about me? In the mid of the procedure, mid of the haircut, sorry, not procedure. Then they were talking to somebody else. I looked back and saw, like, who's this person? Then that was the same person who did the transplant rescue for this artery. He's the same guy. I took a picture with him at least to thank you.
Good effort and very nice case. What are the sizes of the graft master you selected?
At the descending limb, it was a little big. We placed a 4.5. The ascending limb, it was 4.25.
Do you feel that it was undersized, that the pseudoaneurysm did not?
Sir, it was a little
close.
It was already blown up, sir. We were very, very cautious in
No, my query is that whether it was undersized, that's why the pseudoaneurysm.
No, arteries were, it was okay only, sir. It was not undersized for it.
What do you think is the etiology of the pseudoaneurysms?
So most probably there was a small collection there. It might be infected. Because of that, might be patient grew up Klebsiella, but with the antibiotics it came down. Small collection was there at the anastomotic site.
In this setting, do you think stent graft is a good idea?
Sir?
In the setting of a collection adjacent to the pseudoaneurysm,
Yes, sir.
won't the stent graft get infected?
So no other option was there.
Okay.
But at that time,
I understand
it
the
was
desperate
sterile. It was
situation.
antibiotics, but no other. This was the only response.
Desperate
Surgeons gave up.
situation. Yeah.
Now he's
Understood.
walking, talking. That is the only thing.
Great.
Thank you, sir.
Thank you.
I invite Dr. Sushant Babbar onto the stage for the next presentation.
So I will be presenting a case of extrahepatic portal vein obstruction who presented to us with refractory gastric variceal bleed and the role of TIPS and transplantic embolization for managing the same. So he was a 65-year-old male patient with known case of EHPV who presented to the emergency department with upper gastrointestinal bleed, and multiple sessions of endoscopy were already done. In past 2 days, 3 sessions of endoscopy done after admission, and the patient still had upper GI bleed with persistent symptoms, and it was referred for intervention radiology reference. The current HB was 7 gram, platelet was fine, LFTs was normal, creatinine was normal. So we did a repeat CECT abdomen to look for the status. So CECT abdomen tells us the portal vein is completely fibrosed and thrombosed with the portal cavernoma formation, and the whole of the tract, even the splenic vein and the proximal superior mesenteric vein was replayed with perivenous collaterals. And after in-depth evaluation of the CT, we could appreciate that in the spleen, the lower pole branch of the splenic vein was draining into the collaterals, and the upper pole branch of the spleen was contributing towards the formation of the gastric varices, from which they found that on endoscopy they were bleeding, and also we can see the large esophageal varices in the chest sections which are required. So it was a complete replacement of the portal vein, proximal superior mesenteric vein, splenic vein, which was non-recanalizable, with the large esophageal varices, which were high risk, and the actively bleeding gastric varices, which was referred to us. So we interpreted as a case of global hypertension, but they are not communicating with each other. So right-sided portal hypertension was present, which was contributing to the esophageal varices, and the left gastric vein was communicating with one of the collaterals of near the portal cavernoma and not directly with the portal vein. So they were contributing to the esophageal varices, and the left-sided hypertension was due to the upper pole branch of the splenic vein, which was contributing to the gastric varices. So we planned for a transsplenic access to evaluate and do a venography. We used the NEF set to cannulate the upper polar branch of the splenic vein, and on the venography we can see there was the opacification of the gastric varices, and there was no opacification of the esophageal varices or the portal vein, or any communication could not be demonstrated on the venography. So what we did is we glue embolized using the lipidol and glue in the ratio of 1:4, and while taking it out we tract embolized the splenic parenchyma also. Then we went ahead for a jugular vein access and took a portal vein collateral access and advanced the sheath into the one of the collateral. And on diagnostic venography again, the collaterals was seen, which were one of the large collateral was seen, and a small opacification of the left gastric vein was seen on the venography. And the wire was going into the small collaterals towards the SMV and the splenic vein. However, it was very tortuous. So we somehow took a microcatheter and cannulated this faintly opacified left gastric vein, and this is the left gastric vein after opacification from this collateral, and shows large esophageal varices. So we did cannulate with the microcatheter and glue embolize these varices, followed by tract dilatation and placement of tips to further decompress the system and to avoid the recurrence of the varices for the same, and so that the patient do not have any recurrence. Post-tips, good flow was achieved with the complete vanishing of the portal vein collaterals, which was seen in the previous venography, with the glue cast opacifying the esophageal and the splenic opacifying the gastric varices and the esophageal varices. So post-procedure, the patient was shifted back to ICU. No repeat episodes of the UJE bleed was seen. Patient was discharged on day 6 after the post-procedure with no repeat episodes. And currently at 6-month follow-ups, patient is doing well with no repeat episode. So in patients of EHPVO with refractory esophageal or gastric variceal bleed, a combined approach of transsplenic embolization for the gastric varices with TIPS creation offers a safe, feasible and effective treatment modality. And this hybrid technique takes care of both the right and the left-sided portal hypertension and reduces the global portal hypertension with sustained symptomatic relief in the long term. Thank you.
Thank you, Dr. Sushant. So one question, did you contemplate doing a splenic artery embolization? Would that help here?
So, splenic artery embolization was considered, but at the time of the presentation, the varices were actively bleeding from the past 2 days, and the repeat episodes of the endoscopy were already, sessions were done. So first was the complete obliteration of the actively bleeding gastric varices was thought of. So we directly accessed and overall the splenic diameter was also not that big. Okay. So we took a upper pole selective branch and took a venography to assess, to completely obliterate the gastric varices and to bail out the current active situation of the bleeding.
Because at the end of the maybe afferent embolization, whatever you call that, from the splenic axis, I couldn't see the glue penetrating the entire variceal bed. So do you think there can be some collaterals which can reperfuse the gastric variceal bed and then may lead to recurrence?
So for that purpose only, the lower pole of the spleen and the middle pole was draining through the collateral and somehow communicating with the portal vein. We put a tips to reduce the pressure so that the future episodes do not occur. We do not just end up obliterating the esophageal and the splenic varices. We try to decompress the portal system by putting a tips along with it. So collateral tips should help. At 6 months, patient is still fine. Tips is patent with no repeat episodes, and this decompression should help to further avoid the recurrence of the symptoms.
Thank you.
Thank you. EHPVO, sir. Sir, actually the whole axis of the portal vein, there was no on CT. There was a collateral which was communicating with the perivenous collaterals of the portal vein, which were also communicating with some of the SMV and the lower polar branch of the splenic vein. But they were very tiny and very multiple collaterals. It is not possible. It was not deemed possible to puncture a lower pole and then recanalize whole of the tract. And even if it had been recanalized, such a long tract, how long it will be patent? Because it was thrombosed from many years. The patient was already a known case of EHPVO. So we did go for a collateral circulation which is well established now, and we decompress the portal pressure from that system.
I believe accessing the collateral transhepatic is much easier than doing it transjugular because it's a EHPVO, it's not a hepatic.
But yes, but we thought of to avoid the recurrence, we plan to put a tips also. So if we do this transhepatic and varicose embolization, and patient again comes after 6 months, 1 year of, because the portal system, such a large varices has already been developed, the patient will have a propensity it will develop again. So to avoid the future recurrences, we planned on to put a tips also. So transjugular access was necessary for that case.
Thank you.
Thank you.
I don't know whether it's incidental or not, all the extreme cases were from the hepatobiliary portal system.
I invite Dr. Vaibhav Yadav from Gangaram Hospital for the next talk.
Good evening, everyone. I'm be presenting on the topic of silence of our liver. Hepatic hyperplexus block as sole anesthesia for microwave ablation of the hepatocellular carcinoma. There's an established pain generated during microwave ablation of hepatocellular carcinoma is due to the capsular stretch and thermal expansions, which leads to intense nociception. With that, motion control is very critical to maintain ablation accuracy and margins. For the visceral pain, it is amenable to hepatic hyperplexus block, whereas the parietal pain might require local anesthesia at the capsular or paravertebral blocks. There are two established divisions of the hepatic hyperplexus. The anterior plexus, which wraps around the hepatic artery, and the posterior plexus, which is posterior to the portal vein in the CVD. So the hepatic hyperplexus blocks the afferent nociceptive transmission at the gateway of the liver, which is the porta hepatis. The inclusion criteria for this prospective study included 10 patients with HCC, solitary lesions less than 3 cm, child PU class A, and candidates for percutaneous microwave ablation. Of the total 10 liver lesions, 6 were intraparenchymal and 4 were subcapsular. For the demographics, the mean age was 62 years, 7 were male patients and 3 were female patients, the most common etiology being viral hepatitis, and the mean MELD score was from the range of 8 to 13. The patients who met the inclusion criteria were taken up for the ablation procedure. The primary plan was sole hepatic hyperplexus block with local infiltration of LA in the intercostal space and at the capsule surface. Intra of the patients who had a VAS score of more than 4 were rescue converted to IV sedation. The rationale behind this was not using GA was the cirrhotic patients have hemodynamic instability, drug accumulation, and delayed metabolism of the drugs. And GA is a resource-intensive process. The mean power for the ablation parameters was 70 watts with the mean time of 6.5 minutes. For the technique and the technique was periportal fight at the anterior surface of the main portal vein, just proximal to the bifurcation was attempted. The rationale behind being the targeting periportal fat allows the anesthetic to bathe in the anterior as well as the posterior plexus along the triad and block the visceral afferents. For the procedure, ultrasound and fluoroscopic guidance transhepatic approach was taken using a 22-gauge G1 needle, which was directed anterior to the main portal vein. This was followed by injected of normal saline, followed by 0.5% bupivacaine diluted 1 normal saline, and 20 ml was injected in incremental fashion. The endpoint was peripetal halo around the main portal vein, and this was confirmed on fluoroscopy. These are some cadaveric stills from the demonstrating the anatomy of the hepatic hyperplexus. In the third image, we can see there's shows a cadaveric injected methylene blue showing hepatic plexus stained in the hepatoduodenal ligament surrounding the hepatic artery proper and the main portal vein. Here we have a case of an intraparenchymal HCC in a cirrhotic patient. The first image shows the first video shows a needle trajectory into the anterior hepatic plexus. The second video shows the fluoroscopic confirmation, and the third is a cone beam CT confirming the intra-op findings. In the fourth image, we can see the post-op CUS, which shows the ablative findings and no residual lesion. Here's another patient with case of patient with multiple pellet bullet injuries. Under USG guidance, hepatic hyperplexus block was attempted. After this was confirmed on cone beam. Here we can see the microwave antenna in the posterior segment 7, which is a subcapsular lesion with multiple bullet artifacts. The primary outcomes for the cohort was 7 out of 10 patients underwent ablation under hepatic hyperplexus block. 3 out of the 10 patients required rescue IV sedation. None of the patients were converted to GA. The technical success was 100% with no major vascular complications or local anesthesia-related toxicity. All the patients were discharged on the next day with 100%. For the pain analysis, the intra pain was assessed by VAS score. The hepatic hyperplexus block alone patients had a mild discount with mean VAS of 2.1. The patient who had to undergo a rescue IV sedation, the mean peak was 6.3, which came down to 2.5 after IV simple sedation. There was approximately 50% reduction in the use of opioids compared to historical data. This is the pharmacological profile in the patients who were given fentanyl and midaz. There was more than 50% reduction in the opioid sparing effect with mean fentanyl dose of 75 in a range of 50 to 100, and the mean dose of midaz was 2.5 mg, which was primarily used as an anxiolytic and not for analgesia. As compared to previous historical data, there is almost 50% reduction in the use of in the dose of fentanyl. For the cath lab efficiency time, there was the time saved per case was around 45 minutes. The door-to-door time for GA approach was 95 minutes, whereas for the hepatic hyperplexus block was 50 minutes with the time saved for 45 minutes. Also, the patients who underwent hepatic hyperplexus block didn't require any post-op ICU recovery, and this led to per case increase of approximately 1.9 cases in a day. And since no anesthesia charges were involved, this led to lower costs as well. For the post-op care, the patients in the post-op care were managed conservatively with oral painkillers in the post-op period. No ICU HDU bed references were needed. The routine vital monitoring was done, and the patients were discharged the next day. No major complications were seen, with no major vascular injury and no major local anesthesia-related side effects. Minor adverse event in the form of nausea was noted in 2 patients, which was self-limiting and managed using oral medications. In conclusion, hepatic hyperplexus block is a paradigm shift for GA-based ablative procedures. Denervation with improved hemodynamic stability. The primary cause of conversion to IV sedation is anxiety. Hepatic hyperplexus block therefore is clinically excellent with great operational efficiency and economic advantage. It is best suited where periportal coverage is achievable with sononatomy. The future directions being need for a larger RCT.
Last 2 minutes.
With subgroup analysis, long-term outcomes and comparison with GA-based outcomes. Thank you. And at the last, I'll finally say, block the organ, not the patient. Thank you.
The time for RF ablation, you have done RF ablation?
Microwave ablation.
Microwave, sorry. Microwave ablation, and all put together is 45 minutes, is it?
For the total case, sir, including the clean draping, transfer, consent, everything.
No, what about the fentanyl time, everything, taking in and out, the entire procedure?
Yeah, that is around 50 minutes for microwave and 95 minutes for GA.
Okay.
How long does this analgesia effect last for this once after block? Because they may require post-procedure pain.
For bupivacaine, it usually lasts for 6 to 8 hours.
Okay.
And if the patient has, we usually follow up the patient for 6 hours for a VAS score. And if there's a VAS score, if there's some increase in the VAS score, we'll just give him lower oral medications, tramadol, etc.
Okay. Did you notice that patients complain of pain post-procedure? No. Sorry. Did you notice patients complaining of pain post-procedure?
No, not really, sir. There was just mild irritation at the cut surface.
Okay. Thank you.
Thank you.
I invite Dr. Rupesh for the next presentation. Dr. Rupesh Ji.
Good evening, everyone. I am Dr. Rupesh from HCG Hospital, Bangalore. Today I am going to share our experience, a novel PRRT therapy in neuroendocrine liver metastasis. First, coming on to the clinical presentation, majority of the NETs arise from GIT and pancreas and they metastasis to the liver. Once they metastasis to the liver, they develop carcinoid symptoms such as flushing, abdominal cramps and diarrhea because of the hepatic inability to digest excess hormones. On the management landscape, early stage disease can undergo resection. However, majority of these patients are not suitable for surgery at the time of presentation. On the medical oncology side, patient can be offered chemotherapy, target therapy and immunotherapy. From loco-regional perspective, intervention radiology can offer ablative procedures like radiofrequency and microwave ablation and TACE procedures, which can be used as radical complementary and salvage treatment. Finally, PRRT, the focus of this talk. Systemic PRRT therapy can be offered to well-differentiated grade 1 and grade 2 tumors. However, its efficacy is very much limited in advanced grade 3 tumors. And this sets the basis for our study to move from systemic to intra-arterial PRRT therapy. So this study was conducted at HCG Hospital, Bangalore, and we have included 50 patients of NET with hepatic metastasis who are either inoperable or showed poor response to standard chemotherapy. And we adopted a combination strategy of captam chemotherapy regimen with intra-arterial PRRT therapy with lutetium dotatate. This intra-arterial delivery to tumor ensured increased uptake by the tumor with less radiation dose to surrounding healthy tissues. And this study has spanned over a period of 10 years from January 2015 to November 2025, which also ensured us adequate time for response assessment. And the main selection criteria was the lesion should be SSR, AVID and gallium dotanex scan with normal liver and renal functions. So this is our treatment strategy, which was based on Columbia University protocol. Each treatment cycle spanned over a period of 7 weeks. In the first 14 days, patient was put up on capecitabine, and the most important and crucial intra-arterial PRRT therapy was performed on day 10, and from day 10 to day 14 the patient was put up on temozolomide. The following 3 weeks was a treatment free period, and the next 2 weeks the patient was put up on only systemic captam therapy. So our procedural workflow included performing functional scan using gallium dotanex scan to assess SSR AVID lesions. And once that is done, isotope tagging was done to dotatate in the nuclear medicine department. And once tagging is done, intra-arterial administration to hepatic artery was done within 1 hour of isotope tagging after ensuring adequate renal protection. And finally, after 24 hours, post-therapy scans were done. So majority of our patients, that is more than 50% of our patients remained asymptomatic, and among symptomatic patients, majority of them presented with flushing followed by diarrhea and abdominal pain. On the primary lesion front, majority of these tumors were from pancreas followed by mesentery and small bowel. And out of 50 patients, 28 patients were grade 2 WHO grading, and followed by 14 patients with grade 3 WHO grading. And out of 50 patients, 29 patients had more than 3 or more liver metastasis, and a majority of the patients required only 1 or 2 cycles of intra-arterial PRRT therapy, with only minority of the patients requiring multiple cycles of PRRT therapy. And 75% of the patients had already undergone prior treatment. Coming on to symptomatic response, 60% of the patients showed complete symptomatic response, with 40% showing partial response, and none of the patients showed worsening of the symptoms. And coming on to radiological disease response using MRESIS criteria, 40 patients out of 50 showed partial response, and 3 patients showed stable disease, and 7 patients showed progressive disease. So average SUV reduction on gallium scan were 28% at the end of 6 months, which further improvised to 50% at the end of 1 year period. And average decrease in the size of lesion stood at 14% at the end of 6 months period, which again further improvised to 26% at the end of 1 year period. So this is rectal NET with multiple liver metastasis after 2 cycles of intra-arterial PRRT therapy. 3 years follow-up scan showed complete response, And this is another patient, NET stomach with liver metastasis. After one cycle of intraarterial PRRT therapy, 9 months follow-up scan showed significant reduction in the size and metabolic activity of the lesion, suggesting partial response. So this is another patient, NET small bowel, post-IV lutetium dotatate therapy and oral chemotherapy. Patient showed poor response and hence patient was taken up for intraarterial PRRT therapy. 1.5 years follow-up showed significant reduction in the size and metabolic activity of the lesion, suggesting partial response. This is another patient, NET duodenum. After one cycle of intraarterial PRRT therapy, 2 months follow-up scan showed complete response. So conclusion, intraarterial PRRT therapy resulted in dramatic reduction in carcinoid symptoms with adequate disease control for prolonged time with only 2 doses, and regular chemotherapy and maintenance therapy after intraarterial PRRT therapies remained optional. Thank you.
So, thank you for the innovative concept. I think PRRT has been there in HCG Bangalore because I've listened to Dr. Indushekar talks as well.
Yes, sir.
You've been doing for a very long time.
All these cases were done under Dr. Indushekar sir only.
Okay.
Sir.
Okay.
Yes, sir.
So outside HCG, I don't think anybody has any experience on this PRRT therapy.
Yes.
Anybody in the audience would like to? Yeah. Dr. Karthikeyan from Salem. I think one of his relatives got a treatment there. Can someone give the mic to Dr. Karthikeyan?
So how do you how do you take the patient? Because currently all the recommendations, even coming to all the oncology, it's a strong say in the tumor board, because it's without evidence, it's very difficult to convince in the tumor board. So, and our center, we are regularly doing PRRT, but it's all intravenous, because the patient comes, gets an injection, IV injection, get a scan and goes home. This becomes again admission and invasive procedures. So without a strong data, we are not sure how to convince, and do we because it's all targeted therapies. Whether you inject intravenous or the intraarterial, it is still going to sit in the receptors. So the only one probable advantage which is being claimed is the renal first pass effect we are able to avoid by intraarterial, but we are not having any sufficient evidence. So what is your experience on how to convince a nuclear medicine physician that this is really better over the intravenous?
So since ours is oncology setup, we have good coordination with the nuclear medicine, medical oncology and IR team, sir. So whatever case comes, whichever is the best, they go with, they refer the cases. And so we get cases, majority of the cases were referred from nuclear medicine to us.
Yeah, do we really have a data that to support that intraarterial is better over intravenous?
Yes, sir. This was done for the past 10 years and we have like 50 patients. And before 2015 also we were doing this for, from 2013 we have started to do this. So almost like 55 to 60%, 60 cases we have for the past 10 years. And compared to IV also we have discussion in our tumor board. Patients getting intraarterial therapy showed better response compared to IV therapy. So
probably I think you should start having RCTs and publish the data, because then only we'll be able to convince oncologists in every other center.
Yes, sir. We were also thinking to
once you publish the data, then it is useful for every other oncology center, because now every comprehensive center is being increased, and this can be really be useful, and it is not much expensive comparing intravenous. So
yes.
Because
any comments from big cancer centers, Tata, Kidwai? No one. Okay, thank you. We'll go to the next presentation.
I invite Dr. Ariharan for the next talk.
My presentation is on a balloon trapped aspiration in acute limb ischemia. So as we all know, acute limb ischemia is a limb threatening emergency, and the biggest problem is gangrene resulting in a major limb amputation. So the common treatment options are a surgical embolectomy using Fogarty's or an endovascular. And in endovascular, there is now enough evidence that it has lower in-hospital mortality compared to surgery. And our limb salvage rate is up to 80% endovascular. So in endovascular, we have either drugs or devices or combination of both. When it comes to drugs, catheter-directed thrombolysis, we commonly use a tissue plasminogen activator. And the systemic bleeding remains a concern, and we have to rule out the contraindications and all that remains. And it is not as efficacious as a mechanical thrombectomy. And coming to mechanical thrombectomy, angiojet and the indigo systems are the commonly used systems. So this was my patient, a 50-year-old male. She presented with acute limb ischemia, Rutherford's class 2B, 10 hours from onset. And I got a call at, I think it was around 11 p.m. And the patient's, one more this thing was the past history of mitral valve replacement with anticoagulation, and the treatment was irregular. She has stopped the medications and INR was not normal. So this was the angiographic image. It was a very interesting picture angiographically. There was a clot in every bifurcation. So common iliac bifurcation, there was a clot. Common femoral bifurcation, there was a clot. And below popliteal artery, there was a clot with a distal complete absent blood flow. And the patient was having severe pain, motor, some deficit was there. So setup and plan, and the finance was an issue. So angiojet and indigo systems were out of question. And we started with a contralateral retrograde access. A crossover sheath was placed in the left common iliac artery origin. And first I tried aspiration with a 8 French catheter, both manually and via the penumbra system. I tried different angles, tried using a guide wire to support, change the direction, everything I tried for half an hour. Nothing worked, and I think it was close to midnight. I was looking at the clot, and I felt the clot was staring back at me. So I thought, okay, what can be done? So what I tried to do analysis of the situation. So it was basically a saddle thrombus, and it was stuck in the internal iliac artery. In the external iliac artery, there was a severe flow limiting component. And the main problem I felt was the aspiration catheter is not engaging the clot. It kept glowing through it was being pushed towards the area, away from the clot, and it was either aspirating blood or the clot was too big and it was not engaging. And then again, one more issue is like, if I am too aggressive, what happens if the clot we just keep pushing the clot? I don't want to push the clot. So I decided, why not trap the clot? So what I decided was, this was my setup. So I kept a crossover sheath. Using this thing, 014 wire, I crossed the clot. Place the wire distally, and then I took a balloon from the shelf and some aux balloon, and then I was careful of two things. I intentionally went for an undersized balloon, and I inflated the balloon only to 2 atmosphere. So what I wanted to achieve is, I wanted something on the other side of the clot to hold the clot, and when I am aspirating, it's to make the aspiration more effectively. And it actually worked very well. A lot of clots came. I think this imaging was, I was very happy. I was not expecting it to work. So then I did the same thing. This was the image showing a complete recanalization of the external iliac artery. The clot in the internal iliac artery did go distally and did a block it. Then I went into the common femoral artery. Same picture, a saddle thrombus sitting in the superficial femoral and deep femoral artery. I tried a simple aspiration, it didn't work, so I again did the same thing. One thing was, I again wanted to use an undersized balloon, but as I said, finance was an issue, so I used the same balloon. So it was a bit I think it was a bit, the size was not exactly undersized. So in this here, there was some vasospasm, and there was some removal of the clot, and compared to the first image, there was a very good distal runoff, even though it looked like a clot was there. I thought, okay, I come back to it. I went into the distal popliteal artery, and it worked with simple aspiration. The clot came, and was infrapopliteal flow was really good. I could feel the pulse, and then I went back again to the superficial femoral artery. I wanted to know if it is actually how bad it is. I did a Doppler, and Doppler showed no significant drop in peak systolic vessel velocity, and acceleration time also was good. So I decided, okay, to leave it. So the outcome post-procedure angiography was good, and then post-procedure Doppler the peak systolic velocity was maintained, and the patient had a full clinical recovery. So this was another case. In this case there was a popliteal artery acute thrombus with a complete cutoff. Conventional aspiration failed, and so again I crossed with the 014 wire, deployed a small balloon, undersized balloon with low pressure, and I did the aspiration, and it opened up. So what are then I looked back, then what can go wrong, what can work. I was just looking back at this technique. So what I felt during is, like, when we are advancing, when you are trying to cross the clot with a balloon, the balloon can push the clot. So end balloon have a low profile, and should be, I think that's what we should go for if we are trying this. And aspiration catheter advancement. Once you deploy the balloon and inflate the balloon, and you are advancing the aspiration catheter, because the aspiration catheter has resistance in the front with the clot, there can be a differential movement and the balloon tends to move. Either it, because and you are, if you are, especially if it is a crossover system, and the balloon can migrate proximally also. When you are like, pushing this thing, it can, the entire system can go up the aorta, and intimal injury can happen. So this can be avoided by using undersized balloon, very low pressure, 2 atmospheres was what I inflated the balloon to. And this very slowly advancing the aspiration catheter, not so that where is the tension building up and which is going to move. So I was careful of these things. What is this similar to? So this then I went back and if there's anything similar done. So actually the similar technique has been deployed, but what they have done is in which in the popliteal artery they cross the clot with a wire, deployed a balloon distal to the clot and pulled the balloon back into the aspiration catheter. But I feel similar to what surgical Fogarty's we do in a open surgery. But I feel instead of pulling the balloon back, we can actually push the aspiration catheter forward. So maybe the intima, we can treat the intima more gently that way. And then we all know that in venous sinus thrombosis, this technique has been well known and described. And we use balloons to macerate the clot and pull the clot back.
Last 2 minutes.
So to conclude, this safe thrombus removal from peripheral arteries can be technically challenging, especially if you have limitations like you cannot use all the devices available. So thromboaspiration using this distal protection as a balloon to trap or pull the clot can be useful, especially when conventional methods fail. And some things we should remember is like proper balloon selection, low pressure inflation, and careful catheter movement are key. So thank you.
Dr. Arigan, it was an interesting technique that you followed, Jugaad, I think, when you don't have the right devices for want of cost. So did you think about trying lysis in any of these situations?
Yes, sir. In this case, my dilemma was where to lyse. There is a clot everywhere. So either I have to go into the popliteal artery, and that was the biggest complete occlusion. I have to put a catheter lyse. And one more thing, as I mentioned, this patient was on oral anticoagulant, stopped. INR was like more than 2, I think. It was not in the target range, not 3, but it was not normal also, somewhere close to 2. And we know that there is enough evidence that catheter-directed thrombolysis is good. But if you remove the clot, that is better.
So was your suction catheter over the same wire or was it parallel? The suction device?
No, over the wire, sir.
Over the same wire?
Over the same wire. I place the suction catheter, through the suction catheter only I place the, this thing, I think I used a Y connector to, in the proximally, in the hub end so that you can
There will be some air leak, right?
Sorry, sir?
There will be an air leak, no? Even if you have used a Y connector, you can't have a full suction force on with a balloon inside.
Yeah, definitely, sir. That is sure. That is, we will lose some space. Some of the lumen of the aspiration catheter will be lost. I used the ballast actually. I didn't use a react or anything.
Thank you.
Thank you.
I invite Dr. Jignesh Reddy for the next talk.
Probably not very innovative compared to what the other colleagues have told, not much of gadgets or anything. So this was something like making a customized hole in the SIM catheter in difficult angulation visceral branches. There is a lag between my screen and
Do we have someone from the technical team?
Can you just help me out? Yeah.
Someone from the technical team, please come over the stage, please.
So meanwhile, so this simplified technique was actually something that came out of the mind when I was reading a Miyama paper somewhere in between, especially while doing a adrenous venous sampling, wanted to put a hole in a SIM catheter, and then wanted to use that same on a midnight. There was a pancreatic aneurysm bleeding. People tried at 3 a.m. in the night. I wanted to do, tried all different things. It was not happening. Suddenly I remembered Miyama because of the name, and then tried to do a hole in the SIM catheter to just get into a very difficult middle colic artery, and that worked. So from after that, we used it in a couple of cases, and it's going on well now. So the background is very acute angled visual branches are remain difficult to cannulate, especially the inferior phrenic from celiac, IPDA from SMA, the middle colic from SMA. And in pancreatitis, the patient usually loses weight, the fat is lost in the retroperitoneum, the angles become more acute. And in these patients who are bleeding, the radial access also would be difficult because they might be on NORAD and the diameters of the radial artery become smaller, don't want to take a brachial access, and sometimes even that radial also fails. So all these techniques fail, and so multiple times if you just do manipulations, there's a risk of stability issues, injury risks, and more importantly radiation risks in continuing that. So this was the paper that I found. He was cannulating the hepatic from kidney and lima from subclavian through a hole in the parent artery. So this is how I was doing. This is one of the cases that, so I just did outside. If the video is being played, I used all G material to just show for the video purpose. So what I do is, I do angios with the SIM, position, understand on the angiograms the exact location of the branch origin, take the SIM out, and just make the hole in the SIM catheter on the exact position, like superiorly for LGA, probably lateral, upper lateral, lower lateral. And use a 11 number blade, just make a small hole first, and then twist, and then increase the size of the hole carefully, dilate the hole either with a needle as seen here or with the micro introducer set. Dilate the hole for some time, like this, pinch the tip if required, just shape it in such a way, and then the hole should have a bevel in the distal end of the catheter, like towards the tip. A bevel should be in such a way that it's like how you come out of the subway through escalator. The wire should easily come out of the catheter. And then try this thing with the microwire, microcatheter ex vivo on table for like 5-6 times, multiple times, so that the microcatheter develops the memory. And then in the video I showed an injection where we could prove that the most of the saline was coming out of the side hole rather than the tip of the main catheter. So the we should be careful in such a way that the hole should be smooth, the borders are smooth, and does not coverage more than 180 degrees of the circumference, because then the tip breakage risk increases. And then after all this is done, go back into the aorta, go back into the parent artery, and manipulate with angiograms so that the tip is facing the hole is facing the necessary artery. So I've done 5 cases with this. I've successfully cannulated in 4. In one of that we successfully cannulated all 5, but embolization was only successful in 4. Most of these cases will have small radials, small arteries also, but luckily it happened in all of them, and mostly it was pancreatitis, and in none of the case I had a tip breakage and issue with the vessel injury. Nothing happened, luckily. So this is one case where the middle colic artery was having an aneurysm on the CT, which is a small dot, and then so the middle colic artery had a small aneurysm, so it was difficult. We tried with SIM, we tried with Cobra, we tried with IM, it was not happening. Then this procedure was in the KT, so tried doing that. All lateral angulations didn't help. Even radial, we tried, radial didn't help because it was very difficult to get into that. So did the whole procedure, got the hole, got Asahi little slightly shaped outside, hooked into the branch and got the embolized this one. We wanted to protect the colonic branches, put a coil which was like a scaffold and used glue from behind so that the aneurysm was gone. And this is the last single shot is the final image. This is another patient which had a bleed from stomach's lesser curvature. The arteries, if you see in the second image, are very small. Patient was on very high NORAD and didn't want to try radial in this, tried to manipulate. My meaning was even in small arteries, it is difficult for the SIM, so usually LGS we hook by just pulling the SIM down into the aorta so that the SIM's tip faces up. But it's very difficult in these patients with bleeding because the arteries are small, you can't get that, and multiple times you have dissections. So this particular putting a hole in the catheter actually helps here, and I could easily cannulate the LGA and went on to embolize the bleed. So the take home message is, it's a very simple method, it's on the table, you know it, you have to do. The most important thing is making the hole. Meticulously make a hole, dilate it with the microintroducer, make sure that the edges are round, smooth, you are not causing a lot of damage, because once you take the SIM back again it will be difficult. And then incrementally increase in size again to the dilator. Make sure that the side hole is bigger than the tip, and bevel distally. That's something that's important because the micro comes out easily. And yeah, in all the 5 cases I never had a tip breakage or any complications, but touch wood. But the important thing is, these are not recommended by the company, this is innovation on the hand. Thank you.
Very innovative. Good.
Thank you.
That's fine.
Thank you. I think we are done.
Yes, sir. We have
Thank you all speakers. You've been very educative also.
Thank you all. The inauguration will be starting soon.
Check. Good evening, ladies and gentlemen. I'm sure you've had a great time. Just a quick announcement. We will meet each other again at sharp 6:15. We have the inaugural ceremony. So I urge you to be here, fully ready at 6:15 p.m. See you soon. Thanks again. If any of your colleagues or delegates have already left, please inform them that we will assemble here sharp at 6:15 p.m. for the inaugural ceremony. Ladies and gentlemen, we all want you to be part of it. It is ISVIR 2026. So we have a grand celebration that awaits you. So please be here sharp at 6:15 p.m. Thank you so very much.
Yeah. A very good evening to everybody present here. I know you guys are a little bit surprised as to what is this guy doing with a drum around his hips. We'll be finding about that in a moment. So, we all think that music is external, right? Music is something that we hear from the outside and we are not connected to it. But what if I told you music is something that comes from within? What if I told you we don't need expensive instruments in order to create music? What if I told you you just need this beautiful instrument that God has gifted us? None other than our human voice. How are you guys feeling today? Good? Okay? Decent? Bored? Superb. So, can I get all of you to say who? A little bit louder. Who? Who? Ha! Who? Ha! Who? Ha! Who? Ha! Who? Who? Ha! Ha! Who? Who? Ha! Ha! Guys at the back, I want all of you to participate. Come on. Who? Who? Ha! Ha! Who? Who? Ha! Ha! Who? Ha! Who? Ha! Who? Ha! Who? Ha! Who? 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 Ha! 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 Who? 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 Ha! 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 Okay, super. Now I'm going to map the sounds of the drum to the sounds that we are going to say. So I want all of you to listen. So this is who is ha. Okay? So whatever I'm playing, you guys have to vocalize that. Let's go slow. Wait. Youngsters there. Who? Ha! Who? Ha ha who? Who? Ha ha. 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 Louder, guys, come on. Who? I want all of you to go tribal. Who? Ha. Who? Ha. Who? Ha. Who? Ha. Who? Ha. Give us guys a round of applause. See just how saying just who and ha, just 2 syllables, right? It stretched all our facial muscles. We are always focused on work, doing presentations, attending a lot of meetings. Our faces are like always like this. Just say who, ha, at times, and your face brightens up. And when your face brightens up, the patients you meet or the people you meet, their face brightens up. Right? We are all mirrors. So when we have a smiling face, people don't frown at us. They smile back at us. Right? When we have a frowning face, they are like, I think this guy is dangerous. Right? So we don't want to give that expression. So remind yourselves to say who and who. Superb. So just to stretch your facial muscles. How many of you want to stand up? Have you been sitting all day? Are you guys in the mood to stand up? Can you all stand up, please? I am no doctor, but I definitely know this saying. I think sitting is the new smoking, right? And because we have been on our computers or on our devices all day, there's no blood circulation happening, right? We have to move our muscles a bit, move our joints a bit. It's very rigid. So I want all of you to just use your hands, just use your feet, move around in whatever way you want to. Here, trust me guys, I want all of you to become kids. Okay? Let's go. Come on, I love the enthusiasm. Thank you so much. So I want all of you to say this word. Dhum chak. 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 Super. Now we are all warmed up with our hands. What about the feet? Let's move. Easy. I know everybody has done march past in school. Left, right, It's not that complex, don't worry. It's even simpler than that. So, dhum, chak. Let's go. On the count of 4. 1, 2, 3, 4. Dhum, chak. Dhum, chak. Dhum, chak. Guys at the back. Dhum, chak. Dhum, chak. Dhum, chak. Say it. Dhum, chak. 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 Snap. Dhum, chak. Dhum, chak. Perfect. Dhum, chak. Dhum, chak. Dhum, chak. Dhum, chak. Dhum, chak. Say it, guys. Dhum, chak. Dhum, chak. Dhum, chak. Now alternate. Dhum, chak. 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 Dhum, hoy. Dhum, chak. Dhum, chak. Dhum, chak. Dhum, hoy. Dhum, chak. Dhum, hoy. Dhum, chak. Dhum, hoy. Dhum, chak. Dhum, hoy. Okay, now I want you guys to give a high five to the partner next to you. Okay? Whenever there's a chuck. Okay, let's get that camaraderie going on. Come on, guys. We are here for a reason. Right? Let's connect. Let's bond in whatever way we can. Even if you don't know languages, this is the language that we're going to bond in. Right? Let's go. On the count of 4. 1, 2, 3, 4. Dhum, chak. Dhum, chak. Dhum, hoy. Dhum, chak. Dhum, hi. Dhum, chak. Dhum, hello. Dhum, chak. Dhum, namaskar. Dhum, chak. Dhum, vanakkam. Dhum, chak. Dhum, hi. Dhum, chak. Doom, doom. How are you? Doom, doom, check. Doom, doom. I'm doing good. Doom, doom, check. Doom, doom. This is fun. Doom, doom, check. Doom, doom, hoy. Doom, doom, check. Doom, doom, hoy. Doom, doom, check. Doom. Hoy. Doom, doom. That's the spirit. Doom, doom, check. Doom, doom, hoy. One, check. Doom, doom, hoy. Doom, doom. Superb. Give yourselves a round of applause, guys. I know a lot of people have red hands right now, but I think this is worth it, right? You now have a special bond with the person next to you. You never know how the bond will develop. Hope you guys had a great time doing all the who's and the has and the dum dum and the chucks. Right? Just 2 syllables, but a lot of communication. Thank you so much.
Aditya, hang on. I just met the couple of the year. I saw them dancing. These two.
Oh, I spotted the dancers too.
Enna sir, ivlo super dance aadringa. Great performance, both of you.
Thank you so much.
Working professionals? But Aditya, I'm going to invite everyone. We're going to do the inaugural, but one challenge.
Yeah, sure.
Okay? The people here, they are the best of the best in the industries. They've been toppers all their life, okay?
Yeah.
They're exposed to radiation. There could be a Superman in this group. We don't know, a
Wow,
Spider-Man.
okay.
Right? But they have not yet experienced, you know, the Kutta spirit of Tamil Nadu. How many of you, I mean, Aditya, what do you think? Challenge, do you think they'll do the Kutta?
I definitely think they're gonna, dance, shake a leg. I don't think they'll be sitting, like there'll not be any person in the room sitting for this beat. Do you know the sound of Tamil Nadu by any chance? The sound of Kuttu beats. No? Let's hear it. But I don't want faces to be just smiling at me and watching me perform. I want all of you to shake a leg in whatever way you want to.
And you know what, Aditya?
Yeah.
We have Ira who's going to lead the dance. Give it up, ladies and gentlemen, a mascot for ISVIR 2026.
Ira is going to dance to my Kuttu beats, and brownie points for whoever wants to come on stage and join me and Ira. Right? Guys, nobody's judging here, so it's not a presentation, right?
Wait, Aditya, I know the natural dancers already. I'll tell you.
Yes.
That's one. He's been
Let's go.
I know. For no reason. He's like, I'm sure he's a
So
very good
people who are
dancer.
dancing, you can dance along. People who want to clap can clap along. Encourage them, right? There's nothing wrong in just... Let's go.
Yeah, one second. Sir, you know who are your fellow dancers? You've seen
Yeah,
them party?
you want to grab more people?
Come, ladies.
Come on, guys. We've been sitting all day.
Sir, I know you are also one great dancer, sir. How is it? Sir, for you, dance is in your blood and food. Come on. Come on.
Let's go.
Go fast.
Come on, guys, clap.
Yes.
Dance karna hai.
Ira. One second, Aditya. 1 second, guys. Very simple. Ira will lead the dance and you will
Please
follow.
take the
Yeah?
center
Take the stage. Yeah. Ready? Ira? Ready? Aditya, ready?
You can move.
Move.
Take the center stage. Very simple steps. Ira's going to lead.
Ira's lead.
Okay.
And
let's go.
the best. There's no lady on the stage. I'm deeply upset.
Come on, we need some women rep.
Aditya, I'll tell you a happy news.
Of course, yeah.
This year at ISVIR 2026, we have the highest number of women participants as
Woo.
well. So happy to have you on the stage. All right? Yes. Ira ready? DJ ready? Hit it.
Let's go.
लस्सी मिला के आ जाओ सारे मूड बना के पूछो तो थोड़ा राउंड घुमा के अन्ना के जैसा चश्मा लगा के कोकोनट में लस्सी मिला के आ जाओ सारे मूड बना के और मैं रजनी फैन don't miss that chance और मैं रजनी फैन don't miss that chance boogie dance boogie dance boogie dance boogie dance boogie dance boogie dance let's come on clap नाइट क्लब में आया मैं तो मुझको रोकेगा
Thank you so much. Give them a nice big round of applause, ladies and gentlemen. Woo! Sir, 1 second, sir, please come here, sir.
Thank you.
Wait. I'm going to ask the audience to pick the best dancer. Hang on. Audience, you will applaud, all right? So I'm going to,
We're going to vote.
We're going to vote. I'm going to stand next to the dancer. Whoever gets the biggest round of applause is the winner. Are you ready? Wait. Doctors, wait. Okay? So, yeah. That's just your table clapping for you, okay? Sir, opposition, sir. Choose me. Sir, you are the best dancer in the country, sir. Don't worry, sir. Aditya, they are scamming us, Aditya. Thank you so much, ladies and gentlemen. Did I
Thank
miss
you,
it?
Ira.
The winner, yes.
Clear winner.
Thank you so much, thank you.
Good,
Thank
good. It was good, encouraging.
Thank you.
Thank
Play some
you.
more music, yeah.
Thank you.
Yes, thank
The
you.
doctors, give
Thank
them a
you
nice
so
big round of
much.
applause. Thank you, Ira. Thank you so much. We're awesome. Give them a nice big round of applause. Ladies and gentlemen, we're all set for the inaugural. Thank you. We warmly welcome our dignitaries. Welcome our chief guests. We welcome our guest of honor. We invite all of you. Ladies and gentlemen, what an amazing feeling at ISVIR 2026. The best of the best from my country, the best of the best from the world have joined us here today. What an absolute honor. And in 2026, this is the 26th edition. I just want to hear, just from your round of applause, how has day one been so far? Just from the round of applause. Pretty good, I'd say. All right. We're all set to begin in a few minutes, ladies and gentlemen. So if any of your friends, colleagues, anybody else outside, please join us in just a few minutes away from the inaugural. But I'm going to take a moment here and thank all our wonderful sponsors who have made this amazing conference possible. So let me go ahead and thank the presenter of ISVIR 2026, our presenting sponsor, Involution Healthcare Private Limited, our titanium sponsor, Terry Moore, Boston Scientific India Private Limited, our platinum sponsors, Penumbra, Medtronic, Asahi Intech India, our gold sponsor, Merrill Life Science India Private Limited, our silver sponsors, ladies and gentlemen, SAOT, Bard India Healthcare Private Limited, Abbott, Vivier Imaging, Guber India Private Limited. And of course, we have many more sponsors who've made this possible. So show them your love. Give them a nice big round of applause. Yeah? Amazing. All right, we begin by paying a tribute. And this is something that we do in India. Before we begin anything auspicious, we always pay a tribute to divinity. We say thank you. We say, please guide us, please bless us. That is how we do things right here, ladies and gentlemen. So we are going to do the invocation dance right now. And you're going to see two songs on the stage today. One is Sendamil Nadanum Podinile. This is a patriotic song written by Mahakavi Bharatiyar, praising Tamil Nadu in Tamil language, and also talking about the nuances of my state, its ancient, revered language that is Sendamil, followed by a song praising Tamil Kadavul Murugan. Over to you, ladies and gentlemen, with a big round of applause.
செந்தமிழ்நாடெனும் போதினிலே இன்ப தென் வந்து பாயுது காதினிலே எங்கள்
தந்தையர் நாடென்ற பேச்சினிலே எங்கள் தந்தையர் நாடென்ற பேச்சினிலே ஒரு சக்தி பிறக்குது மூச்சினிலே எங்கள் செந்தமிழ் நாடெனும் போதினிலே
செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு வேதம் நிறைந்த தமிழ்நாடு உயர் வீரம் செறிந்த தமிழ்நாடு
வேதம் நிறைந்த தமிழ்நாடு உயர் வீரம் செறிந்த தமிழ்நாடு
நல்ல காதல் புரியும் அரம்பயர் போல் இளங்கன்னியர் சூழ்ந்த தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு
செந்தமிழ் நாடெனும் போதினிலே இன்பத் தேன் வந்து பாயுது காதினிலே
எங்கள் தந்தையர் நாடென்ற பேச்சினிலே எங்கள் தந்தையர் நாடென்ற பேச்சினிலே ஒரு சக்தி பிறக்குது மூச்சினிலே
காவிரி தென்பெண்ணை பாலாறு தமிழ் கண்டதொரு வையை பொருணை நதி
காவிரி தென்பெண்ணை பாலாறு தமிழ் கண்டதொரு வையை பொருணை நதி
எனமேவிய ஆறு பல ஓடத் திருமேனி செழித்த தமிழ்நாடு
செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடு எங்கள் செந்தமிழ்நாடு செந்தமிழ்நாடெனும் போதினிலே இன்ப விழிக்கு துணை திருமென்மலர் பாதங்கள் மெய்மை குன்றா மொழிக்கு துணை முருகா எனும் நாமங்கள் முன்பு செய்த பழிக்கு துணை அவன் பன்னிரு தோளும் பயந்த தனி வலிக்கு துணை வடிவேலும் செங்கோடன் மயூரமும் வண்ணமயிலேறும் என் தங்க வடிவேலோ கந்தன் உன்னை காண தினமோடி வருவேனோ செந்தமிழை காக்கும் வேல் செவல் கொடியானோ எண்ணி எண்ணி பாடும் என்னை கந்தன் அறிவானோ தோளிலே பால்காவடி சுமந்து ஓடினேன் மேடு பாலங்கள் கடந்து ஆடினேன் அவன் ஆலயம் நுழைந்து பாடினேன் வடிவேலனை நினைத்து தோளிலே பால்காவடி சுமந்து ஓடினேன் மேடு பாலங்கள் கடந்து ஆடினேன் அவன் ஆலயம் நுழைந்து பாடினேன் வடிவேலனை நினைத்து தந்தைக்கு உபதேசம் செய்து சுவாமி மலை ஆள்பவன் நீ மாம்பழத்தில் கோபம் கொண்டு பழனி மலை ஆண்டவன் நீ கடலோரமாக செந்தூரிலே வாழ்பவன் நீ வள்ளி தேவயானையுடன் தனிகை நாயவன் நீ தன்னக்கொரு தனித்துவ பட்டையென்ன நிலம் என்ன வாழ்வையில் எறியவன் முருகன் பாடங்கள் சொன்ன மகன் யாவும் என இல்லை என நதியற்று நாங்கள் அங்க ஆறுதல் அந்த மகன் முருகன் ஆறுதல் பெற்ற மகன் வாயினை காக்கும் படி வேலையா நீன்றி வேறு துணை யாரையா யாரையா வாயினை காக்கும் படி வேலையா நீன்றி வேறு துணை யாரையா யாரையா முருகன் வளர்ந்த கதையும் பொருள் மறந்ததில் வேல் சின்னந்தன்று கொடுத்த சிறையும் வள்ளி தெய்வ யானையுடனே காட்சி அருளும் தன்னிகைய நாயகன் உன்னை காணையில் இந்த நோட்டி மறையும் எந்தனையாளும் சுந்தரவேலும் செவல் கொடியரும் செந்தமிழ் நாடும் கந்தனை பாடும் எந்தனி நாமும் பாடும் பொழுதொரு துன்பங்கள் தீர்க்கும் குமரனை கண்டதும் எனக்கு கவலை இல்லடா குன்றத்துக்கு குமரன் இல்லடா என்றைக்குமே முருகனை நான் மறந்ததில்லடா அந்தியடங்கா நான் கடம்ப புள்ளடா கடம்பன மறந்ததில்லடா மண்டியிட்டு மண்ணில் விழ என்ன விட்டதும் இல்லடா அந்தியடங்கா நான் இறக்க நல்லவா அது தமிழ்க்கு இருக்க நல்லவா அருமுக நாடும் மண்ணில் வாழ தமிழ நல்லவா காக்கிற கருணையும் வீழது ஐயனி பெண்ணிரு கைகளும் காக்கிற கடமையில் பாயுது குற்றம் ஒரு சற்றும் இனி தொட்டும் தொடராமல் இனி காக்கும் கந்தாகலம் அவனை பதிவான் பட்டுப்பான அட்டி முழக்குது வெற்றி வேலாயுதன் பட்ட இறக்குது முட்டு கடல் முட்டி அடுக்குது கந்தனை காணங்கள் தேடி துடிக்குது காலடிகள் தாண்டி துட்டிய காவடிகள் கடப்பனை பொட்டிய காவடிகள் சத்திக்குறை முத்துக்குமரனின் முத்தமிழ் பேரலைகள் வாயனை காக்கும் வடி வேலையா நீன்றி வேறு துணை யாரையா யாரையா வாயனை காக்கும் வடி வேலையா நீன்றி வேறு துணை யாரையா யாரையா
That, ladies and gentlemen, is Dr. Divya, who's now working as a senior surgical resident at Rella Hospitals for the past 6 years, with over 10 years experience in assisting various laparoscopic, robotic and open surgeries. Right? Thank you so much. That was a fabulous performance. She's been training since the age of 5. Thank you so much. She's one of your own, ladies and gentlemen. Isn't that lovely? Thank you. You know, right, she started off with Mahakavi Bharatiyar. Mahakavi was freedom fighter. And if, you know, which is a state which has the highest number of working women in the country? The state Tamil Nadu. Because Mahakavi says, Nimirna nannadayum nerkonda parvayum nilathil yarukkum anjada nerigalum. There is a line, it says, a woman should walk with her head held high. She should walk like this and she should be bold. She should be able to achieve. He called her Pudumai Pen. And all I see, ladies and gentlemen, the Pudumai Pen who are here with me, give them a nice big round of applause. Yes, so all the Pudumai Pen in our family, in our lives. Thank you. Thank you so very much. On that note, ladies and gentlemen, we have a very special laser show for you. So we're going to switch off all the lights. And while the performance is going on, please do not use your mobile phones. Do not switch on the flashlights. It's a humble request. This is put together with an amazing dance crew called the Dwarians, and they have performed across the world, 2,500 shows and counting, and they're truly spectacular. So get ready to enjoy the show.
Please don't stop the music, music, the music. Please don't stop the music, music, the music. Please don't stop the music, music, the music. Please don't stop the music, music. They try to copy my swagger. They try to copy my swagger. They try to copy my swagger. They try. DJ Nitro. Swagger. They try to copy my swagger. They try to copy my swagger. They try.
Everybody, come on, put your hands up. Come on.
Ladies and gentlemen, please make some noise for Blazer, Blazer, Blazer. Blazer.
That was Dwarians. Give them a nice big round of applause. The dance symbolic of cutting edge technology in everything that you do, ladies and gentlemen, as specialists. And now it's time to invite the dignitaries on to the dais, take the proceedings to the next level. It is my absolute honor to invite on stage the president of ISVIR, Dr. Shyam Kumar N. Keshava. Vice President, ISVIR, Dr. Pushpinder Singh Khera. Secretary, ISVIR, Dr. Nitin Sudhakar Shetty. Treasurer, ISVIR, Dr. Abhishek Bansal. President-elect, ISVIR, Dr. Amar Mukund. And our state committee members will lead and accompany our chief guest. Organizing chairperson, ISVIR 2026, Dr. Deepashri T. Organizing secretary, ISVIR 2026, Dr. Karthikeyan Damodaran will accompany our honorable chief guest, Srimati D. Sabita IS, former additional chief secretary, Government of Tamil Nadu. President, TNPY, chapter ISVIR, Dr. Arun Periyakarupan. State Treasurer, TNPY, chapter ISVIR, Dr. Murli Krishna Swami will accompany our guest of honor, the wonderful Professor Mohammad Rela, onto the dais. All right, ladies and gentlemen, what we're going to do right now is rise for the Tamirthai Vartha. If you're able, we request you to please stand.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்பரத கண்டமிதில் தெக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Anbanamale Vanakkam, ladies and gentlemen. Please take your seats. We will now light the lamp, symbolic of how all the very people in this room have worked towards making the future of this country bright, turning it into the medical capital of the world. The very people in this room, and inviting the divine grace to guide and bless us. Inide Tuvangiyathu Vizha, a beautiful moment right here. A quick group photograph, if you may, near the lamp. Thank you so very much. We invite the dignitaries back to their respective places, and we will be honoring our chief guest and guest of honor at the moment. So I request the teams to be ready. We will begin by felicitating our wonderful chief guest who's taken out time for us to be a part of this wonderful event, wonderful inauguration. And the felicitation of our honorable chief guest will be led by Dr. Deepashri. I request you to please do the honors. Invite presenting of a shawl, bouquet, and a very, very special memento from all of us. That's something very special about Tamil Nadu. It's pure silk, ladies and gentlemen. That's how we honor our guests. The famous Kanjivaram silk. Showering in gold and love. That's Tamil Nadu for you. And of course, a special memento. Thank you once again. We'll now felicitate our wonderful guest of honor, and I request Dr. Shyam Kumar and Keshava to please do the honors, along with everybody else on the dais to please join in felicitating our wonderful guest of honor. Thank you so very much. Please take your seats. Ladies and gentlemen, we're going to begin with the welcome address. And for this, may I please invite the organizing chair of ISVIR 2026, Dr. Deepashri. Ladies and gentlemen, the nice big round of applause.
Good evening, everyone. I can just hear one person saying good evening. Good evening, everyone. Thank you so much for that. So I don't know where to start, but I would like to start with the respected dignitaries on the dais. Tirumati Sabita, former Additional Chief Secretary, Government of Tamil Nadu. Professor Mohammad Rela, world-renowned liver transplant surgeon and a Guinness Book record holder. Our beloved President of ISVIR, I would like to call very cool Dr. Shyam Kumar N. Keshava. Vice President ISVIR, Dr. Pushpinder Singh Kera. Our Secretary, another cool head, Dr. Nitin Sudhakar Shetty. Treasurer of ISVIR, who is responsible for whatever you're seeing today. So Dr. Abhishek Bansal. President-elect ISVIR, Dr. Amar Mukund sir. And our state committee members. We have myself and Dr. Karthikeyan Damodaran, who is the organizing secretary of ISVIR 2026. And we have our state treasurer, Murali Krishnaswamy sir, and president of TNPY, Tamil Nadu and Pondicherry chapter ISVIR, Dr. Arun Periyakarupan. and my beloved members of ISVIR, non-members, the faculty, national and international faculty, all my friends, colleagues, the industry partners, trade partners, without you this wouldn't happen, and all the volunteers, group captains, everyone present here. Thank you so much for being here this evening and making this the most memorable evening for me. When I say that, I mean it. And I would like to start the welcome address with vote of thanks. Because I truly believe gratitude is everything in life. I think when we are grateful for people, everything paves the way for you. And that is what I'm seeing today. And I'm extremely grateful to what is happening today right before my eyes. And whatever you're seeing today is just the outcome of the relentless hard work of so many people behind the stage, so many people behind the scenes that I would like to acknowledge right now. First, starting off with the scientific committee members, all the scientific committee leads who put up a great show for this event. And you're going to see in the next 4 days, the scientific show for the next 4 days. The abstract review committee, the volunteers, who we don't acknowledge most of the times, but there are so many volunteers behind the successful running of this show. The group captains that we introduced this year, and many more, and I can't tell you. I work for Professor Mohammad Rela, and this is a center which is a busy transplant center with about 30 liver transplants, or more than 30. I mean, every day we do at least 2 liver transplants. And that is a center that I am working. And if I'm able to organize something, this wouldn't be possible without the team that I have at Rela Hospital. For that, I would like to acknowledge Praveen. Praveen, can you please stand up? So Dr. Praveen, Dr. Vishal, Dr. Shiva. Praveen is a consultant and Dr. Vishal and Shiva are the fellows. And Kalpana, who's been traveling with me for the last 13 years, you would have heard her name day in and day out. So Kalpana, thank you so much for this. And everybody behind this, the trade partners, events management. Thank you so much, Sajita. I don't know if you're here. Thank you, Nandini. Thank you, Santosh. Thank you, everyone. If I missed out on someone, I'm really sorry because I'm really overwhelmed right now. But I would like to acknowledge everyone who are behind this show. Now, welcome to Mahabalipuram, the beautiful city, the beautiful town, which is known for its history and heritage and culture. When we chose Mahabalipuram as the venue, and when this was offered, there were a lot of questions and a lot of people raised their brows. How is this going to happen? Because this is very far from airport. It's going to take literally an hour and a half to travel. And it's not going to be easy, and you have chosen a beautiful scenic place. People are going to be on the beach, or they might be doing something outside, and they might not be in the scientific session, is what people said. But this is, I mean, you guys are an answer to what everyone thought of initially. So thank you so much for being here inside the halls and not on the beaches, at least today. I'm hoping the same thing continues for the next few days as well. So with that, I don't want to take much of your time. I would like to move on to the next address. Thank you so much once again. And before I leave, I would like to say there is a beach walkathon happening on day 3. I would like to emphasize this again. There is a beach walkathon on day 3. This is one of the highlights of this event because most of the times we always wonder why IR is not known in the community, especially in India. The awareness about IR is totally lacking. So the reason I feel is definitely lack of patient awareness. Unlike the West, the patient awareness is lacking. I'm really fortunate to be working at Rela Hospital wherein, we do get cases and we do get to treat patients, but it's not the same everywhere and we still are looking for patient awareness. So the beach walkathon that we are thinking is actually a patient awareness activity. So please, alcohol down tomorrow and please wake up at 6 a.m. day after tomorrow and please join us for beach walkathon wherein we have some patients who are coming over and they're going to participate, they're going to share their testimonials about the walkathon. So please do come along at 6 a.m. day after tomorrow. And there is one more person who I also need to acknowledge for the Vice President the position that I'm standing here. So I never thought of becoming the vice president because I'm happy in my own world, dancing along, and then I have a lot of passions, and I would never want to do this. But there is one person who actually said, you should become the vice president, and you deserve it. I really don't know if I deserve it, but then I would want to be grateful to that person, and that's Dr. Ajit Yadav. Thank you, Ajit, for proposing my name. Thank you. Thank you so much. Thank you. Thank you, and with that, I'll pass on to Sano. Thank you once again, and welcome once again to Mahabalipuram. Thank you.
Thank you so very much, Dr. Deepashri. Let me tell you, I've been working with these doctors. They've not slept in the last 2-3 weeks, and I tested them. They're very alert. These are the names, these are the people I would go to in the future. Good on you, dear team. Next up, may I please invite President ISVIR, Dr. Shyamkumar and Keshava, to address this wonderful audience. Ladies and gentlemen, you know what to do.
Thank you. Good evening, everybody. Professor Mohammad Rela, Tirumati Sabita IAS, and ISVR family sitting on the dais and among the audience, trade partners, all friends. And it's a real privilege to be with you, and this is a wonderful conference. I must say that year by year, the reference standard is being elevated, and it's really sounding like an international conference to me. And I must say that Dr. Deepashri thanked everybody. I think it's our duty to thank Dr. Deepashri and her team. And how much energy she has got in her team, she also has got equal amount of patience. That's how they are able to do such a wonderful conference. A big round of applause, please. It is 26 years ago, some seniors thought that we should have a society of our own. That's how Interventional Society was started for vascular and interventional radiology. And today, the society has grown very large. What we have achieved, we have a lot of trainees. We have formal training programs like DM in interventional radiology, DRNB in interventional radiology, several fellowships. There are nearly 100 positions every year where trainees can get in. But is it adequate? Definitely not. We need to have many, many more people who should be trained. And that is the time we will be able to deliver adequate patient care to every part of India. So these are all the challenges what we have. We have our own journal. We are really proud of it. And we have commemorative stamp released last year, and we have many more things to do. I see several international leaders from interventional radiology societies who are sitting here, representing Europe, America, Australia, Canada, and UK. So several people are sitting here. So I must request you on behalf of ISVR, we should really think of having a World Federation of Interventional Radiology. When several other societies are having World Federation, we also should be having, so that we can So I request you all on behalf of ISVR, and it will be very useful to the patients. It will be very useful for sharing knowledge and quick discussions possible. And I must say that 16th January, that is the day Charles' daughter did the first angioplasty, and that's the first intervention. And this day should be remembered, and this should be celebrated as Global Interventional Radiology Day, which has been considered, but we should do it with the full support, and all interventional radiology societies should join. And with these comments, I conclude my remarks. Thank you.
Thank you so very much. Did we just plan the next conference? All right. Thank you, Dr. Shyamkumar, for always showing us the way and inspiring us. Next up, ladies and gentlemen, may I please invite Secretary, ISVIR, Dr. Nitin Sudhakar Shetty, to address this wonderful audience. Ladies and gentlemen.
Hi, good evening all. Honorable Chief Guest, Srimati Sabita IAS, Guest of Honor, Professor Mohammad Rela, respected dignitaries on the dais, distinguished faculty, dear colleagues, and friends. On behalf of the Indian Society of Vascular and Interventional Radiology, it's my honor and a privilege to invite you all for this conference, which is the 26th annual conference of ISVIR. This year's theme, Innovate, Collaborate, Transform. It captures the very essence of interventional radiology. Ours is a specialty that is driven by imagination and precision, where technology meets compassionate care, and where minimally invasive therapies, they are rapidly transforming the outcome of patients across the country. We are deeply privileged to have with us Srimati Sabita, who exemplifies the highest standard of public service and administrative leadership. Her presence on this dais, it reinforces the importance of constructive engagement between the bodies like ISVIR and governance, so that the advanced and equitable healthcare can be delivered to every citizen who needs it. We are equally honored by the presence of our guest of honor, Professor Rela, who is a world-renowned surgeon like Dr. Deepa introduced. He is also a teacher and an institutional builder. So interventional radiologist, most of us work day in and out with the transplant surgeons, and his presence today, it's a proud reflection of this multidisciplinary partnership. Over the years, ISVR has grown from strength to strength. It's building academics or creating contemporary guidelines, expanding the state chapters, or nurturing vibrant junior wing. Today, our society, it stands as a confident national platform committed to training, research and innovation, and above all, patient safety. The coming days, it will showcase the best of national and international IR, be it scientific sessions, hands-on workshop, or lively debates. It also will provide young interventional radiologists to an opportunity to interact with the masters. I'm certain that every delegate will carry back new ideas, new skills, and new friendships. I take this opportunity to sincerely thank the organizing committee, our dedicated faculty, industry partners, and the entire ISVIR membership for making this conference possible. With that, I once again welcome you all for this conference, and I wish everyone a truly enriching and memorable experience. Thank you. Jai Hind, Jai ISVIR.
Thank you so very much, Dr. Nitin. Ladies and gentlemen, it's time to invite the guest of honor. And like how David Letterman says, he needs absolutely no introduction, but we should celebrate, ladies and gentlemen. There is so much. As you all know, a guest of honor is known for pioneering complex procedures like pediatric liver transplants and robotic liver surgery, Guinness Book record holder, the highest number of live donor liver transplants in the country, developing innovative techniques like the split liver transplantation, author of extensive scientific papers. He has, wait doctor, I'll celebrate 2 minutes.
I was going to push you out.
Hang on. Oh, 2 more minutes. He's authored over 400 peer-reviewed publications, a number of book chapters, including a chapter in the latest edition of Gray's Anatomy, and of course, the biggest supporter of IR professionals. The whole world now comes to India for their treatment, and most importantly, they come here to learn. The world's best is from India, the best doctor, the best teacher, chairman and director, Dr. Rela Institute and Medical Center, Professor Mohammad
That's a good music. Ladies and gentlemen, Tirumati Sabita IAS, it's nice to meet you again. We meet often in this sort of places. And the president of your interventional, I have to get it right, Vascular Interventional Radiology Society, the president and the office bearers who are all there. And I have to thank Deepashri especially. Deepashri joined me 15 years ago, and we have traveled together, and I can tell you something, we cannot exist without interventional radiologists. As a liver surgeon, or as a liver transplant surgeon, and she's been outstanding. She's multi-talented, as you all know. I was wondering whether she was going to dance here earlier on. She dances in every one of our functions. She has delegated that to Thivya, who's also one of our doctors. And I've learned very quickly. Most of you have been training in King's. I worked at King's College Hospital, London, for almost 25 years before I moved to India. As a liver surgeon, King's was a referral center for liver, and we were managing a lot of liver trauma, which would get packed and sent to us. And a lot of that work, interventional work, was middle of the night, and we were dealing with very senior people, much senior to me. You may have known the personalities I'm talking about. Dr. John Karani, I don't know if you guys know Dr. John Karani. He's here? No? And I've quickly realized that if you have a conflict with interventional radiologists, your patients will suffer. So I would never have a conflict with interventional radiologists because I don't want patients to suffer. I like my language. I like my land. I am from here. After working in the UK for 30 years, I came back here. And I want to say it was very appropriate introduction for today with a dance. The importance of that poetry that was written by a very famous poet from Tamil Nadu. I just want to translate the first word. It invites you to this land of Tamil, the land of Tamil. Tamil, as you know, is a language, and the land of Tamil has taken its name from the language, Tamil Nadu. And it is special because of the language. And the first lines of this song, where this young lady was dancing, was Sendamil Nadenum Podinile, Inbathen Vandu Payudu Kadinile. I'll just translate that. When you say the land of Tamil Nadu, when you mention the word Tamil Nadu, what we experience is a honey flowing through our ears. Honey is for tasting, but this honey is for listening, which is the language. So, Inbathen Vandu Payudu Kadinile is the language. So I always speak in Tamil language in these meetings, but today I will not because the majority of you here are from various places. But I would like to reflect on today's world, deviate from what you've been listening to, things that have been bothering me. Maybe it may be political. Are there many people from the United States here? How many? I hope you don't get offended. So really, ideal world to live. Tamil language and Tamil people, and which is where I return back. This is where I'm from, and I would say I love my country, and I love my state, and I love my language. And we had a poet in Bengal as well, who's actually a Nobel Peace winner. How many Bengalis are here? Rabindranath Tagore. Not many lifting your eyes. Rabindranath Tagore. And you're from Bengal as well. That's great. And I want to recite a poetry of an ideal place to live, where the mind is without fear and the head is held high. He is dreaming of a land to live in, where the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken up into fragments by narrow domestic walls. There we have a problem today, where the world has not been broken up into pieces by narrow domestic wall, where words come from the depth of truth, where tireless striving stretches its arm towards perfection. I like this line because we are all trying for perfection. But can perfection ever be achieved? And that is why he says, stretches its arms towards perfection, because what is perfect for you, somebody else is going to come and make it better than what you've done. However much you strive, where tireless striving stretches its arms towards perfection. Where a clear stream, I can't remember that line. Who knows that line? where, into that heaven of freedom, my Father, let my country awake is the last line, where the clear stream, it won't come. It's an important line. It talks about really us having prejudged views and not changing things. And that's the land that he wants to live in. And do we actually live in the land is what I'm asking. Today has become a time of bullies, where we can have one country torture another, where one becomes unacceptable, where another is not necessarily a bad thing. I'm not going to give you examples of countries' names and the countries damaged by them. And there are many of them. We are full of bullies. But at the end of the day, I think these countries will achieve. That's a sad thing. I think I came here thinking I'm going to talk about artificial intelligence to you, what my views are. And this world is going to be completely different. The conflict, I believe, is all about artificial intelligence, the energy for artificial intelligence. And many people say, how is it going to affect us? I think as radiologists, you already know, I think radiology is the easiest specialty for artificial intelligence to deal with. Just accept that, and tomorrow I'm going to tell you most general radiologists will want to be interventional radiologists because they won't have much else to do. So you're going to get huge competition, the young people here, that most radiologists to survive will become interventional radiologists. Pathology would be the easiest for artificial intelligence to deal with. We won't need pathologists because one pathologist looking through 100 slides and learning about one, artificial intelligence will learn through 1 million slides in no time and will come to a conclusion on what it is looking at. It can do a cell count within seconds and tell you exactly what the issues are if there is an infiltrate or detect cancer. But as doctors, where do we stand is what I've been worried about. But one thing we need to remember, if technology is going to be good for mankind, you cannot stop it. People say if technology will bring money, you can't stop it, but I don't think so. I think regulations can stop if technology will bring money. But if technology is going to be good for mankind, for human beings, you cannot stop it. That means our roles will be diminished. I'll give you one example. We are close to general intelligence. I think whoever is talking about, artificial intelligence won't make a big difference to our life is not understanding what they're talking about. You've heard about artificial general intelligence and artificial superintelligence, and we are not anywhere near artificial superintelligence. Even general intelligence is a threat. Elon Musk once said it's a 30% risk to humanity, existence of humanity itself. Now, we are all wanting to be good doctors. I'll give you an example of a good doctor who will get patients through because of their knowledge and commitment, would be an medical ICU doctor. Now, and that requires a huge amount of experience in one doctor to take a patient through. An artificial intelligence, even a general intelligence, would be 10 times or 100 times better than the best doctor because, I don't know, today's world, we have MDTs, yeah? We can't make decisions without MDT. You have to have a multidisciplinary team to make a decision about even your interventional radiology. Why would you think that is? That is deficiency in the human mind because not everyone is a specialist. So you have to have a liver surgeon there, you have to have a general radiologist there, you have to have an interventional radiologist there, you have to have a radiotherapist there, you have to have a medical oncologist there. and everybody is listening to a case history for 2 minutes and then making a decision. And it's a combined decision we have to make. With artificial intelligence, you don't need that. Artificial intelligence will be your pathologist, your radiologist, your interventions, everything. So we already are deficient, really. And where we are going to move from this into how we are going to adapt tomorrow is how it's going to be for you. I do robotic surgery. People say, oh, is that safe? I think it's getting safer, and the surgery is getting easier. And there are people who say it's so expensive, how are we going to learn? I mean, I think cost is not going to be an issue for the future. But what we can do today, I can sit in Chennai, in my office, in one console, and connect to 10 different consoles in 10 different parts of the world, and jump in wherever is necessary to do the operation. So the expertise can be spread all around the world with today's technology. And unless we take it on, I think I'm sure you guys know what the developments in artificial intelligence is. I know, I'll give you another example that I was fascinated about, that we human mind can't work it out, but artificial intelligence can work it out. There was a study on ECG, electrocardiogram. We understand ECG by the electrical impulses from the heart and how they changes. You can diagnose an arrhythmia, you can diagnose an infarct, you can diagnose things in various ways. They tested out an ECG to tell you about the risk of decompensation in liver disease. An ECG can tell you about the risk of decompensation in liver disease because it will tell you about the hydration of the patient, overfilled patient, overfilled heart, and how the heart is pumping. And in a patient with chronic liver disease, ECG with artificial intelligence will say this patient in 3 months' time is going to decompensate. The human mind never worked it out. Artificial intelligence worked it out. So I just want to end by saying, maybe not frightening you guys, that we are going to live in a completely different world in 10 years' time. And I hope I've not bored you. I thought I'd just reflect on what I've been thinking about. And I hope that our future will be better for it, and that we are not totally controlled by robots or humanoid robots. Thank you very much.
Thank you so very much. We received an important message. Yes, there is AI. Yes, there's development. Yes, all of that. But in this very divided world, if anything, be kind. Thank you so much for saying that, Professor. Ladies and gentlemen, it's time to invite our chief guest for the chief guest address. I just want you to remember this line. Women make a difference. Yes. Wait. Everybody's in a hurry. Allow me to celebrate you. There's a problem with women, you know. Hang on. Women make a difference. Behind every success story, there's a woman. I'll explain. Let me first tell you about our wonderful chief guest today. D. Sabitaya is former Additional Chief Secretary, Government of Tamil Nadu. Holds an MPhil in Commerce with a specialization in capital budgeting from the University of Madras, postgraduate diploma in public policies from the Institute of Social Studies in Hague, Netherlands. In her illustrious tenured service, she was the longest-serving Secretary of School Education. Her educational background has been instrumental in her holding many significant assignments in sectors of industries, finance, textiles, education, and general administration. She has also facilitated private equity investments in numerous industrial infrastructure projects in Tamil Nadu's manufacturing sector. And since her retirement, she has been serving as a chief business mentor at TVS Training and Services Limited. She's also a trustee of the Equitas Development Initiatives Trust, the CSR arm of Equitas. Additionally, she serves on the advisory board of PEN, a non-governmental organization that works in the areas of sexual crimes against women and children, women empowerment. She's a member of the Internal Complaints Committee of the Kalakshetra Foundation, serves on the governing board of Guru Nanak College and Good Shepherd School, and also serves as an independent director in multiple companies. Ladies and gentlemen, she's from the 1988 batch, comes from a very illustrious family. I said, why did you become an IAS officer? She said, my mother told me, even now I have to go and ask for money from my husband, from my father. You should grow up, you should be able to be financially independent, you should succeed. That one single statement and all these achievements, ladies and gentlemen, began with that. On that note, may I please invite a wonderful chief guest to address this audience.
Thank you, Sana, for that wonderful introduction. Distinguished guests on the dais, Dr. Ella, where we meet in common occasions like this. It's an honor to be sharing the dais with you, the president of ISBIR and all the other doctors on the stage, and of course, the other distinguished doctors who've come from across the globe. I would like to first welcome you all to our state, Tamil Nadu, and I think doctor has spoken a lot about it. I don't want to be doing sacrilege by standing between you and the glass or your sleep or your rest, so I'll make my speech very short. I was just, when Deepa spoke to me, when Dr. Deepa spoke to me and said, ma'am, would you come as a chief guest? And she mentioned to me about the society. I was very curious to know what is interventional radiology, because I've heard about radiology. Of course, I've heard about IR, but I really didn't have much knowledge about it. So quickly, I went to my friend AI and ChatGPT and just Googled and texted and threw so much of information. And what came was a surprise, because it said that not many people know about it. There's no knowledge about it. And there is always a difference between the surgeons and the IRs. So then I got more curious and I read more about it. And then I just thought, let me just link it to some of the anecdotes in my career as a service officer. We started off, how important knowledge is and how important information is and how important it is to be carried to the people, the right people at the grassroots level. Otherwise, it's never going to be known to anybody. So then I just thought about two things which I thought I should share with all of you here. One is, I don't know whether many of you would have heard about the self-help groups in India. In Tamil Nadu, we started way back in 1988 when I started my service with just a small group of women to whom we were trying to teach microcredit. They didn't know what microcredit was from Adam. They didn't know what credit was, to leave alone microcredit. So we needed to explain to them how important it is for them to start saving, thrift, how they should save money. We started with just 10 groups. Today in Tamil Nadu, we have more than 3.5 lakh groups, and we have more than 50 lakh women who are into this business. That's only because they gained knowledge, they understood what it is, and they understood how beneficial it is for them. So I suppose the same thing has to happen with your profession as well, or rather your type of medical advancement which is to be done. The second thing which came to me was the mutual fund investments. Today you go to anyone and ask, they will say, oh, I'm investing in mutual funds. But 30 years back, nobody knew what was mutual funds. If somebody had told my father, go and put your money in mutual funds, he would have taken a dig at them. He'd rather be safe in a bank, in a deposit, in a fixed deposit, where he was happily getting some 7% return, rather than go and trade in a mutual fund. But today my maid, my girl who works in my house, she tells me, Amma, I've started an SIP for my grandson. So that's the type of knowledge that has been transferred from, from where we have come a long way. So my only sincere request to all you doctors here, please go and tell the world. Go and use the social media. Like I opened the social media. I just went to Instagram to check whether there's anybody posting anything on IR. There was nothing. There was not a single post. But there were so many posts on physiotherapists, and skin doctors, aestheticians. They were all talking so much about how it is to do skincare, and physiotherapists saying how you shouldn't go to an orthopedician, but you should come to a physiotherapist, and aestheticians saying how you should not go to a dermatologist, but you should come to me. So that is what the world needs to know, who the IR is, what is it that you people are doing, how good it is, how cheaper it is compared to a surgery. Would you do that? That will be the best thing you can do to the world. And people like Dr. Rela leading you, and Dr. All the other dignitaries on the stage, I'm sure you must have a plan in this 26th year of your society to go to the world and talk about it and document yourself, and put as many shots, as many reels, as many YouTube things you can do for the world to know about you. Then the second point which I wanted to talk to you before I quickly close my talk is I was just looking around the tables here, the round tables, and I was just trying to count the number of heads the ladies sitting over here. I found very few. I said, normally, I felt doctors will have a lot of women in that profession. But here I find the number is very less. So I was just thinking about myself. When I joined service in 1988, there were very few ladies in our service. 2010, only 10% of the officers who got selected, the creme de la creme service of our society, which is the Indian Administrative Service, only 10% were women. But in 2023, we have managed to come to 25%, which is a great achievement. So I think, and of course, more number of women are coming. In the year 2023, out of the 180 who got into the Indian Administrative Service, 70 of them are women, which is really, really a great achievement. And also, surprisingly, West Bengal has the maximum number of women officers. 80 officers are there in the West Bengal cadre. I think 2 of them put up their hand when doctor asked. So, and of course, in Tamil Nadu, I can proudly say, being an officer from this cadre, there's no difference. There's no gender difference. I can hold the same post. I've been secretary for 7.5 years in a particular department with 10 people changing, but I was not shifted. So it's all about recognizing the talent. But I really didn't understand why the number of women are less. I suppose it's a type or the nature of the type of work you have to do. But then I always thought, one short anecdote before I finish. I'm an IAS officer, I'm a lady, I'm the housewife, I'm the mother, I'm the sister, I'm everything. My husband is an IPS officer, he's from the police service. He is the IPS officer, he's the man. So he calls me and he tells me, today I'm calling 20 people for dinner, please organize that at 5:30 in the evening. So I am supposed to finish my meetings, finish my policy making, make sure that dinner is put on the table for 20 people, and I have to be back home half an hour before that, organize everything, and make sure I make all the conversation, put everything on the table. So I have to make, then I realized I'm able to do all that. I'm able to cook. I'm able to organize cooking rather, not cook, but organize the cooking, organize the menu, organize the home, which is ready to receive all the people who are coming, make conversations with them on the Ukraine war with somebody, on maybe Trump with somebody, about Indian politics with somebody, at the same time about the beauty of some place with somebody, and any topic I can talk. I have to organize everything and also make a nice chicken gravy and matar paneer and put it on the table, and end of the day send off everybody with a smile. So I pat my back and say, Sabita, you can do it. You're a woman, it doesn't make you any less. So I don't understand any of the younger women why you should feel you're any less, or any of them why they should not come to this profession. I would advocate to all the young lady doctors here to please go and talk to the world and tell the younger generation, particularly the Gen Z, who I think will look at things very, very differently. As Doctor said, AI and Gen Z will be ruling the world in future, and I'm sure that all of you here will support the cause of more women coming into your profession than what it is today. That will be really a game changer. I hope to see that I see that a few years later, maybe in a couple of years later, to come back and see more ladies sitting here, more color over here than just the blues and the grays and the blacks. I hope to see that. Anyway, thank you so much for inviting me, and I must congratulate Deepa and her team and also all the other organizers. It was very overwhelming when I walked in. The laser show was fantastic. The dance was amazing, and that too from a doctor with a young child. It was really, really very impressive, and wish you all the very best. Mahabalipuram is a beautiful place, and the beach walk is going to be fantastic. You're very lucky you've come at the best season of the year, which is really, really cool and pleasant. So enjoy your stay and have a good seminar. Thank you.
All right, from making paneer butter masala, we went a long way in that journey. Thank you so very much. That was so inspiring. Big round of applause, ladies and gentlemen. It's very, very important. Very important, I tell you. When we see women like her, the rest of us get inspired and say, maybe we also can do this. That's why the 1988 batch is so important. Those batches are so very important because they inspired the next generation of women. Thank you for doing all that you did. Ladies and gentlemen, the celebrations continue. We have the award ceremony, and I invite all the dignitaries on the stage to join in as we felicitate our stars, our amazing people from this industry. We begin with the ISVIR Young Investigator Award, and the first place goes to Dr. Santosh P. Can I please have you on the stage?
DJ Google produciendo reggaetón latino y más el álbum.
DJ, give us nice music. We've gone into the house party mode.
Okay.
Thank you and congratulations, Dr. Santosh. The second place is a shared one. May I please invite Dr. Jinesh Valakada and Dr. Rangarajan Rajagopal to please join us on the stage. Many congratulations. Next up, ladies and gentlemen, our next category, ISVIR Best Trainee Award, and the first place goes to Shreya Garg. Can I please have you on the stage? Many congratulations, and the second place goes to Dr. Apratim Roy Chaudhary. Can I please have you on the stage? All right. The third place goes to Dr. Shiv Chandar Shivaji. Can I please have you on stage? Ladies and gentlemen, our next award, you taking a picture? Yes. Is the ISVIR Best Publication Award, and the first place goes to Dr. Pankaj Gupta. Can I please have you on the stage? The second place goes to Dr. Rajat Singhal. Can I please have you on the stage? The third place goes to Dr. Yashwant Patidar. Can I please have you on the stage? Many congratulations. Our next category, Certificate of Emeritus Membership. The award goes to Dr. M.K. Mishra. Can I please have you on the stage? Dr. V.R.K. Rao and Dr. Ravi Ramakantan. Can I please have you on the dais? All right, congratulations. Next up, the gold medal, ladies and gentlemen, and it goes to Dr. Shailesh Gaikwad. please invite Dr. Hemant Deshmukh. Many congratulations. So there's another Gaikwad that the state of Tamil Nadu loves. We know him as Rajnikant. Thank you so very much. Next up, ladies and gentlemen, may I please invite Dr. Priya Jagya. Can I please have you on the stage? May I please invite the gold medal, ladies and gentlemen, the award goes to Dr. Shrikant Murthy. Can I please invite you to join us? May I please invite Dr. MC Uttapa to please join us on stage, another gold medalist, ladies and gentlemen. Many congratulations. Ladies and gentlemen, give a nice big round of applause for all those who won tonight, including you. Many congratulations from all of us here. Thank you so very much. Thank you. Dignitaries may please take their seats. Ladies and gentlemen, it's time for the vote of thanks. And to do the honors, may I please invite the Organizing Secretary, ISVIR 2026, Dr. Karthikeyan Damodaran, to please do the honors. You know what to do, ladies and gentlemen, with a big round of applause.
Good evening, everyone. First of all, I would like to thank our honorable chief guests, Professor Mohammed Raila and Srimati Savita, for gracing the occasion despite their busy schedules and also inspiring us with their insightful thoughts for us to reflect and work on. And I also like to thank our office bearers of a national committee, ISVAR, state committee, all our international faculty, and all our national faculty and delegates for joining us for this session. Thank you.
Thank you so very much. Ladies and gentlemen, we spoke about Tagore, and this is one of my favorite lines from the anthem, Bharata Bhagya Vidata, the writers of my country's destiny, who are here in this room. Please rise with reverence for the national anthem, ladies and gentlemen.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Ladies and gentlemen, thank you so very much. Jai Hind. Ladies and gentlemen, we have the Special Recognition Award. We're holding the best for the last. It is an absolute proud privilege to invite Dr. Chandramohan onto the dais. Thank you so very much. Once again, congratulations to everyone. We are now, yes, ready to celebrate one more time. Ladies and gentlemen, we've officially inaugurated ISVIR 2026. A quick group photo to celebrate this wonderful memory on the dais.
केसरिया तेरा इश्क है पिया रंग जाऊं जो मैं हाथ लगाऊं दिन बीते सारा
Ladies and gentlemen, we have the orations which are going to happen right after this. The national and international orations will follow. And I love how everybody in this conference has been very diligent about keeping time. We were just delayed by 20-25 minutes, which is great. And some more.
केसरिया तेरा केसरिया तेरा
Ladies and gentlemen, before we move to the orations, we're going to get the stage quickly cleared because you're going to see a display of martial arts from the south of India, from Kerala and from Tamil Nadu.
केसरिया तेरा केसरिया तेरा
They're two of India's oldest and most powerful traditional martial arts, rooted in discipline, rhythm, and cultural heritage. The Kalaripayattu from Kerala, which is taught through the Guru Sishya Parampara, just like Silambam, which is what we're going to see next up on the stage, ladies and gentlemen. Thank you so very much. Kalari Parity from the students of the EP Vasudeva Gurukul's Kalari and the Silambam from students of Yar Kalaikudam. Ladies and gentlemen, what you witness on stage is a mother of all martial arts which traveled to China, and today we know it as Kung Fu. On that note, we will continue with our special sessions. We have the national oration, and to do the honors, may I please invite Dr. Rajesh Mundara to please do the honors. Dr. Rajesh, can I please have you on stage? Ladies and gentlemen, with a nice big round of applause.
Good evening, everyone. संसाधन कम थे पर सपने बड़े थे, रास्ते कठिन थे पर हौसले खड़े थे, दौर बदले, तकनीक बदली, जमाना आगे बढ़ा, पर सीखते रहने का जज्बा आज भी उतना ही रहा. Ladies and gentlemen, today we are just not introducing the speaker, we are celebrating his love story. A love story with interventional radiology. A love that began 40 years back, a love that was deep, passionate, and for many years it was completely one-sided. Long before interventional radiology became fashionable, before cath labs multiplied, IR became a hot specialty. Dr. Shrikant Kothekar was already romancing with IR, almost alone in central India. While others were still asking, can we treat this disease without surgery, he was already geared up with his needles to treat such diseases. He introduced interventional radiology when resources were scarce, infrastructure was minimal, and believers were very little. Yet he stood firm, nurturing IR with courage, conviction, and stubborn belief that yes, image-guided therapy is the future. For many years, his love for IR was truly one-sided, no glamour, no applause, no large teams, just dedication, late nights, difficult cases, and unwavering commitment towards the patient. And today, IR enjoys the spotlight, multiple subspecialties, and packed conferences hall. We are all privileged to hear from someone who has lived the entire journey from scarcity to sophistication and from skepticism to acceptance. Many often say that what is there in the soil of Nagpur? Why did so many people get attracted towards IR? But the answer is simple. Some people have that charisma to make the field of IR look beautiful. And yes, Dr. Kothekar is one amongst them. Not only he performed the pioneering procedures, but also sensitized both medico and non-medico communities on every platforms, and also the social media, and is greatly seen on Facebook. His passion and enthusiasm have inspired many of us to walk towards IR with curiosity, confidence, and pride. For more than around 4 decades, he has shared his journey not only with interventional radiology, but also with Dr. Rupal Kothekar, a renowned OBGY surgeon at Nagpur. And his partnership is marked by balance, strength, and mutual excellence. And now, ladies and gentlemen, please join with me to welcome Dr. Shrikant Kothekar, a pioneer, a mentor, and a passionate interventional radiologist for his oration over here. Thank you.
Thank you, Rajesh, for this passionate, lovely introduction. I'm a little... Anyway, let me start. Good evening, esteemed ISVR President and Secretary, distinguished faculty, colleagues, and future architects of interventional radiology. I stand here today with a profound sense of honor and humility to deliver ISVR National Oration. My deepest thanks for the privilege. Tonight, we journey to the geographic and spiritual heart of our country, Central India, Nagpur. This is not just a medical history lesson, this is a love story, a 40-year of romance built on courage, resilience, and a relentless pursuit of perfection and catheter. It is a story of how Central India went from being a referral origin point to a destination of medical excellence. Government Medical College, Nagpur, is not just an institution, it is a landmark of medical heritage in Central India. It is one of the largest and most prestigious teaching medical campuses in Asia. It has always been very vibrant. Every journey needs a first footprint. In Central India, that footprint belongs firmly to the pioneers who dared to dream of world-class facilities right here. A cohesive department at that time, supporting each other and celebrating small successes. The OGs of IR, these OGs of IR battled bureaucracy, infrastructural deficiencies, and a deep-seated lack of awareness. They began with a scratch, teaching themselves new techniques, using basic setup of image intensifier to perform nephrostomies, biliary drainages, and direct puncture carotid angiograms. Let us begin our journey at the point of origin. I joined the Department of Radiology and became a member of OGs of IR in February 1985, along with Dr. Rupal Mashruwala. This was her first house job. My first house job in anesthesia involved emergency and difficult ward intubations. This gave me confidence during my radiology house job, knowing I could intubate, ventilate with an ambu bag, and shift patient to the ICU if required, and won't allow patient to die in department. I became proficient in gynosil bronchography with a red rubber urethral catheter in awake patient using Mangel's forceps. This experience enabled me to assist others in non-vascular interventional procedures such as nephrostomies and biliary drainages. On 20th April 1985, I got my first opportunity to perform a direct puncture carotid angiogram. As my co-house officer Rupal was less interested in angiography and inclined towards OBGY, I began performing angiogram for her unit as well. So got hooked to the arterial spurt of blood and in turn to impress Rupal. From co-house officer to friend to girlfriend and to my wife on 29 June 1986, this happened very quickly. And romance with IRs started. Since last 40 years, I am trying to impress her. This time, during the 85, all the thesis topic used to be on intervention, nephrostomy, biliary drainage, hypernephroma embolization, and renovascular evaluation by angiogram. My thesis topic was on paravertebral plexus venography for evaluation of disc lesions. After 2-3 months of all attempts, due to lack of suitable catheters, guide wires, it was abandoned. You can go through this later. I was awarded ₹11 for excellent tomographic IVC-gram. That meant a lot to me that time. There were 8 lecturer posts in the department, and all of a sudden, all my seniors started leaving the department to learn the ultrasound. and I was left alone to do all non-vascular therapeutic interventions. In 1988, a major milestone was achieved with the installation of area's first cath lab at Central India Institute of Medical Sciences. During transfemoral 4-vessel DSA procedures, difficulty in cannulating left carotid often led Dr. G.M. Towry, director of CIMS, to call me to complete the study with the permission from Dr. B.S. Chaube. He was dean that time, dean of GMC Nagpur, and I was full-time lecturer in the department. For the first time, I saw 7 French introducer sheath and 6 French Judkin catheter. There were no headhunters, and I am using Judkin for all 4-vessel DSA. 87 to 90 was a period of uncertainty as I was locum lecturer at GMC. I joined CIMS on 1st October 1990 with a salary of rupees 5,160, while my wife, a class 1 gynecologist at Ordnance Factory Hospital, Nagpur, earned rupees 12,800. Our household ran smoothly despite my not learning ultrasonography. Beautiful setup of analog cath lab. You can see puck changer, Odilka camera, and it was really very interesting to develop a film, that too in dark room that time. A true turning point in any IR program is the shift from diagnosis to therapy. In Central India, this began with non-vascular intervention such as a nephrostomy, biliary drainage in 86, offering vital surgical alternatives. The defining leap came in April 1992 with the region's first renal angioplasty. This was small in scale but transformative in impact, marking the moment IR was truly born in Nagpur. This was soon followed by complex life-saving procedures that shaped the new specialty in the region. In 93, the first uterine artery embolization using diagnostic catheter and gel foam was performed for post-LACS PPH, saving lives and uteri and highlighting IR's vital role in OBGY. The work was later presented by gynecologists at World Congress of OBGY in Montreal. Post-evacuation torrential bleeding PV received 14 transfusions while in transit, embolized using diagnostic catheter and gel foam only. Dr. P.S. Bidwai, a distinguished cardiology pioneer, former HOD PGI Chandigarh and SGPGI Lucknow, he was working at CIMS. I benefited from him immensely as I used to assist him during his coronary and non-coronary interventions. You can see I attended the first World Congress of Interventional Cardiology also. In his presence, I used to do coronary angio. This helped me in keeping away cardiologists from doing peripheral vascular work, as I used to do coronary angiography for free. Interventional radiology does wonders. No surgery is required to save your limbs, brain, and life. This was the tagline used to make IR procedure popularized among the masses. I always had an independent clinic, 1 hour in morning and 1 hour in evening for new and follow-up patient. Got appreciation and recognition from none other than Dr. Ravi Ramakantan in 1994. This boosted my confidence to do better work. A major complication occurred the following year during bronchial artery embolization for massive hemoptysis in a young patient. Although the bleeding was controlled, a 4 French royal flush catheter with a guide wire got stuck in the right bronchial artery and could not be retrieved. Attempts caused severe pain, and amid pressure from large crowd, The catheter was left in situ and the patient was shifted to KEM. Dr. Ravi sir also attempted retrieval and concurred that it should be left alone, after which the relatives were calm and counseled. News atom for FTR came in March 97. The first cath lab with DSA and roadmap was installed at Super Specialty Hospital. I was appointed honorary professor there. The first carotid stenting in the region was performed on 4th October 1998, marking a high-stake neurovascular milestone and firmly establishing IR in the treatment of stroke and complex neurovascular disease. It signals Central India's readiness for state-of-art endovascular care. The patient belonged to CIMS under Dr. G.M. Towry, who graciously acknowledged the procedure in the annual report of CIMS despite it being performed at another hospital. Spandan Heart Institute installed a Philips cath lab in February 99. So all the cardiology work generating from there about peripheral work that I used to do there. CIMS cath lab got digitalized and upgraded to DSA and roadmap, and ECOM aneurysm coiling was done in 2001. Third National Registry meet was conducted in CIMS. This was a significant milestone as all stalwarts of IR were there in Nagpur. We took this occasion to make public awareness and publish advertisement in local newspaper about embolization and revascularization procedure. 2003 saw 2 more cath labs coming to Nagpur. And this was a significant case. A young woman presented with flash pulmonary edema and hypertensive crisis and found to have solitary ectopic right kidney with high-grade renal artery stenosis and aneurysmal dilatation. And with a fistula into renal vein. She was successfully treated with balloon expandable stent graft, marking a remarkable regional milestone. Wockhardt Hospital, a corporate setup, came into Nagpur, and that changed the awareness part of IR in medical community as well as in general population. Radirecognizer chart was created, which included problem, presentation, etiology, and procedure. And I think I am thankful to Vimal. When he was in Bombay Hospital, that time he had created some booklet. On that line, I created this radirecognizer chart. Even brochures for general public awareness, they were published and distributed. I was keeping my vascular system up to date by going for walks, trekking in Himalayas, and visiting places with family. Beginning 2002, with intracranial, arterial, and intravenous thrombolysis, first using urokinase, lateral actylase, and progressing to mechanical thrombectomy, Nagpur emerged as an aggressive IR center with contribution of Sachin Domne along with Dr. Atul Revatkar and Rajesh Mundra. A major academic milestone was establishment of DM program at Datta Mege Institute of Medical Sciences. I served as a TFAC core domain expert from 2007 to 2012, and under Dr. Pankaj Banode, the department expanded with fellowship and DM program. This academic momentum soon spread, with GMC also starting DM program under Dr. Jawahar Rathod's leadership. Meanwhile, I conducted a unique CME on the occasion of Silver Jubilee of CIMS, wherein a clinical problem was presented by a diagnostic radiologist, discussed by a panel of clinicians, and moderated by intervention radiologists. It was a huge success. All goats of IR were there in Nagpur. First transradial carotid stenting was done in February 2010. In the same year, first hybrid cath lab with installation, in 2010, and Nagpur has arrived at global level. All complex aortic and visceral procedures were performed in this lab. Hybrid procedures were done routinely here. And you know this duo, the first IR entrepreneur duo of India with successful own setup. Now they will be shifting to a new setup, bigger new setup. In 2014, India honored Sachin Tendulkar with Bharat Ratna, recognizing a lifetime of excellence. In a fitting professional parallel at the 16th annual conference in Mumbai, the same year, I was awarded the prestigious Legion of Interventional Radiology honor. Article to this effect came in Times of India. Five stalwarts from Nagpur School of IR now serve as global brand ambassadors to the region, each leading a distinct subspecialty. Together, they exemplify the clinical excellence, academic rigor, and global reach of Nagpur IR. Two major events were conducted in Nagpur. 18th ISVR Registry cum Complication Meet in 2016 and update on venous diseases in November 2018. Beautiful setup of cath lab was installed at Viveka Hospital. Did two contour device placement, one in unruptured ICA top and another ruptured MC aneurysm on single day. Public awareness through newspaper articles continued. I was humbled to receive Lifetime Achievement Award by Vidarbha chapter of Maharashtra State Radiology Association. Tradition of excellence continues in my family. My elder daughter Neha and her husband Aniket, school-time companions, now serve Canadian healthcare. Neha is a dental surgeon and Aniket as a hematologist at Princess Margaret Cancer Center, Toronto. Similarly, my younger daughter Isha, an interventional radiologist, and her childhood friend and husband Pratik, a hemato-oncologist, both GMC Nagpur graduates, are pursuing their career together at Brown University, Rhode Island. Father-daughter duo attended SIR 2022 at Boston. While professional and academic achievements are often the focus of a presentation, none of this would have been possible without the person standing by my side. These photos of Rupal and me represent the heart of our family story. Rupal, you are the innovation in my life and collaboration that made our family that it is today. Here is to many more New Years together. Thank you, ISVR, for the honor. Thank you, my colleagues, and most importantly, thank you to the patients of Central India whose faith and trust fueled this incredible journey. Thank you so much. Thank you.
Thank you so very much, sir. Thank you for sharing this incredible journey, and we'd like to honor you with a medal as a memory of this wonderful moment right here at ISVIR 2026. Yeah. Can we please bring the medal, which is there? Yeah. Ladies and gentlemen, we started with Pyar, Mohabbat, and what I saw today on stage is a man who is not just in love, but very madly in love with his profession, and what an incredible journey, and what a service to our country. And thank you for telling us something very important. Family is everything. Thank you so very much. Ma'am, if you want, you would also join us on the stage. Ma'am, if you're here. I think he just said, I love you to you in many words, so please come. I agree, sir. As you receive this distinguished medal from us at ISBIR 2026, join us in this celebration, ma'am. Can we come to the center of the stage for a nice picture? Many congratulations. Thank you so very much. Dr. Shrikant, you've been incredible. Thank you for all that you did. And thank you for creating the next generation of leaders. Thank you so very much. What happened? All right, we're doing a bit of fact checking. That's how women are. Fact check everything. Rupal ma'am, please join us on the stage. We'd love to hear. Ladies and gentlemen, the reason why we succeed is family. It's simply that. Give it up for the wonderful Rupal ma'am. Ladies and gentlemen, nice big round of applause. Yes.
Good evening, everybody. May this new year find you hale and hearty. Thank you for giving me the opportunity to speak. I anticipated that someone will tell me, that's why I have written this. Would like to talk about my husband, Dr. Shrikant, and how the city like Nagpur and he grew together as far as IR is concerned. I have witnessed Shrikant's journey from the time interventional radiology was still in its nascent stage. IR embraced him wholeheartedly, and Shrikant, with equal courage and conviction, chose to walk alongside it. In the early 80s, many interventional radiologists were working within institutes or as a part of teams across India. What was truly heartening was to see him grow richer in experience and wisdom with each passing day and year, often working alone, facing challenges head-on, as if guided constantly by some divine force. Even during his recent illness, his zeal and zest kept him going, always holding his chin up. In the early days of his illness, I was deeply touched by the way he handled a particularly complex case, keeping his own anxiety at bay and ensuring that the patient's children who had traveled from abroad were not disappointed. Life can be harsh at times and can leave you confused. But if you are determined to maintain a positive frame of mind, you work on it, you make the journey easier, not just for yourself, but for everyone around you. Thank you very much.
I think in the presentation that Doctor made, thank you, Rupal ma'am, that was incredible. Thank you for sharing the warmth and love on the stage. Many times we don't realize, we the civilians don't understand the struggles, the dark moments that all of you go through, and that chapter she very beautifully brought out. Give her a nice big round of applause. Thank you so much, Rupal ma'am. Thank you. Next up, ladies and gentlemen, it's the time for the international oration, and I'm going to introduce this wonderful orator who's up next. Dr. Baljendra Kapoor is an American board-certified vascular and interventional radiologist whose career reflects a deep commitment to innovation, multidisciplinary collaboration, and patient-centered care. He currently practices at the Michigan Medicine University of Michigan in Ann Arbor, where he serves as Division Director of Vascular and Interventional Radiology. And yes, he comes with more than 24 years of clinical experience, and he's widely recognized for shaping the practice and culture of modern interventional radiology. particularly in the care of patients with complex digestive and hepatobiliary disease. Dr. Kapoor's academic contributions include more than 90 peer-reviewed publications and over 150 invited lectures delivered nationally and internationally. His leadership roles reflect the trust and respect of the broader radiology community. He served as chair of the Society of Interventional Radiology annual meeting in 2023 in Phoenix, Arizona, currently chairs the Interventional Radiology Annual Program Committee for the American Röntgen Ray Society, and previously served as a chair of the Appropriateness Criteria Committee, the American College of Radiology. We're truly honored to have you with us. With a big round of applause, ladies and gentlemen, our international orator, Dr. Baljendra S. Kapoor. Big round of applause, ladies and gentlemen. Wonderful.
Wow. Quite an experience and quite an honor. Thank you so much. I can't express in words how humbled and honored I feel today here to be back here in Mahabalipuram, a city that I visited with 40 teenager medical students in 1986 for the first time. And here I come back for the second time to give the international oration. This has been truly a very remarkable journey for me. The topic I picked is positive leadership, embracing the cultural shift in interventional radiology. Just like every specialty, interventional radiology has gone through its own fair share of shifts and changes, and to keep it all together, the positive leadership becomes important. Recently, I graduated from an MBA program from University of Michigan, Ann Arbor, Ross MBA program, and I think over those 18 months, the most useful, practical, and the best week that I had was the week that I spent with the Center of Positive Cultural Organization. And those amazing teachers, professors created everything, every negative thought or the positive thought or any thought they can turn into positive. So I would highly recommend, if anybody, not just because I'm from Michigan, if you ever get a chance to do it. So based on that, the Mahabalipuram then again after 86, it's really is a fascinating, and to learn about the fascinating journey of IR in India, which I really didn't know, and you'll know why in a second. So I'm going to start my lecture with a person I deeply admired, most of you admired, kind, humble, smart, and here is the picture of Professor Thierry de Beering. He is one of the, as Cardiovascular Society of Interventional Radiology of Europe mentioned, he was one of the great interventional radiologists, fantastic physician, researcher, and scientific mind. Most importantly, however, he was what every one of us should strive to be, a wonderful human being. I'm truly touched the way it's all written and the way it's true, although I didn't get a chance to reach out to or meet him in person, but every time I saw him from a distance, he truly is something. To know Thierry meant to admire him. For so many, he was not just a colleague and a friend, he was a mentor, a guiding light at work and in life. What an amazing story. And this is the portrait of leadership. This is the portrait of positive leadership. Everything each one of us try to be and try to keep it together. So when we started this international oration, Dr. Yadav spoke with me, and he suggested that I talk about my journey, obviously being from India and how I went through the different channels and became an interventional radiologist. So in addition to that journey and with my MBA program, Positive Leadership, I thought this would be a good, suitable topic for this oration. So here it goes, my journey to the interventional radiology. I grew up in a very, very small town in northern India, about 3 hours north of New Delhi. And core to my all educational success, in addition to my family, is my high school. This is my high school. This is where I grew up, and as you can see, and this is what, I was one of these students standing about 40, 50 years back, and I was noticing that everything is 26 and that January 26 is so close. So that is the Republic Day of the India. And that's my high school. So journey began there. We all brother, sister grew up in small town, and two of us became doctors. I was one of them. And after my high school, I went to for medical school, and my general surgery training, I went to IMS BHU. We did the medical school there, and then followed by my residency in the general surgery. So I became general center under a very renowned, very smart, ultra smart group of people, truly fascinating, who made training totally worthwhile. However, during those general surgery days, I was slowly, this IR, particularly the field of hepatobiliary intervention, was becoming more and more intriguing. And somewhere along the line, the STIPS procedure became more prominent, or the more and more popular. And in 1992-93, it was gaining more and more popularity, and that was the area of my interest. So I decided to go for radiology residency, and I went to St. Thank you so much. Appreciate it. Sorry, I got a little cold if you are having difficulty. So I did my radiology residency, diagnostic radiology at St. Louis University Hospital, and followed by my fellowship at University of Minnesota under Dave Hunter. So here is my mentor for interventional radiology, Dr. Dave Hunter, and right next to him, many of you will recognize Dr. Kurt Amplatz. And Dr. Amplatz has already retired at that time, but he used to come to the department just for his research interest. But it was such a powerful time to just see such a person in those corridors and have his name over there. After I finished my fellowship training, then I decided to go to Saskatoon, Saskatchewan, Canada. I was there for some time. And then again, where from minus 64 degrees cold weather, I decided to come to University of Alabama, Birmingham, which again was a phenomenal experience, particularly city of Birmingham, Alabama. Amazing people, very good, and very kind and humble, very graceful. So I spent 3 years there, and then suddenly, obviously, coming from the surgical background, places like Cleveland Clinic or Mayo Clinic, they stood up at the top. And there was an opportunity at Cleveland Clinic, so that was my next move. So from the south back to the north, I came to Cleveland Clinic in Ohio, spent most of my career at Cleveland Clinic for 12 years. Again, it's a truly a fascinating experience. You have to have it. I have never seen pathology like this. I have never done cases like this. I have never met people like this. The only thing is that you actually don't get to meet most of the people in person. You just get to talk on the phone. And later on, the opportunity opened up at the University of Michigan, Ann Arbor, so that's where I am now. So that's the part of my journey, and while in Ann Arbor, I decided to go for my MBA program at University of Michigan Ross School of Business, Ann Arbor, and again, one of the renowned, great places to be. So why the leadership part is so important? It started here with Charles Dotter in 1964, we all know that, and that was just the beginning of the specialty. And here are some of the old pictures, which you all have seen at many conferences. And here is the Laura Shaw with the stenosis, which Dr. Dotter treated with dilators, and she did not have to get amputation. So that was the start of it, and that was the explosion of it. And that was the start of it. And then the technology just exploded. There was evaluation, decades of IR growth, enormous growth. And there's so much more room to grow further that we don't have enough resources to make it happen. So somewhere in the 80s and 90s, all these portal venous, biliary, hepatobiliary, angiography, all these things were coming along, and that's what took me too. But at the same time, when all these new procedures, new specialties are in the beginning and their early phase, so building a specialty is a mammoth task. But IR has successfully done so, despite the fact that there are so many people, or the other specialties would like to do it. Our commitment to the specialty, to the people, to the patient, and all this for the betterment of the mankind and the patients, but still there is a lot to be accomplished. Now, how do you maintain all that positive atmosphere in that competitive environment where other specialties might be trying to take, or many other regions? So as many of you or some of you might know, Warren Buffett is one of the world-renowned investor. So I really enjoy his books, his quotes, and reading and learning about him. And he said it, surround yourself with people that push you to do and be better. No drama or negativity, just higher goals and higher motivation. Good times and positive energy, no jealousy or hate. Simply bringing out the absolute best in each other. And I 100% totally believe in this. He is an amazing person. If you get a chance, check out some of his YouTubes. They are really good. So as the specialty was moving forward from 80s, 90s, now towards it continued to grow. However, there was a time in the early 2000s, late 1990s, where, as many of us know, that the vascular surgery, cardiology, many other specialty were encroaching or getting involved, and IR went through the tough time. And during that time, that is the kind of moments where the positive leadership is important. And to keep it together, we survived, we thrived, and then here came along the oncologic interventions and treating and all sorts of ablations. So IR has evolved from that 1964 to this current state where interventional radiology provides the longitudinal care. We see patients in office. I see all my patients on every Tuesday in this clinic, and taking best care of the patients beyond procedures, providing ambulatory spaces, swimming upstream. We cover the entire spectrum of medicine. What it started with was just a simple angioplasty. How far we have come along. There's a lot to cherish and a lot to be thankful about, and it's a change for better. And in the future, we heard about the artificial intelligence, so we don't have to worry about it. We already heard from transplant surgeon Dr. Yao. That's more of a worry for the diagnostic radiology. But the future for us looks very bright. Now, I was going through the presidential address of Dr. Keshava, and he said IR is at the crossroads in India today. So it's not just India, it's actually everywhere. We all have different kinds of challenges, different kind of needs. So we all are at the crossroads. For here, there may be shortage of equipment or hardware. At my place, on the other hand, there are the subspecialty turf issues or the battles that we have to fight with the gastroenterology, cardiology. So those are the kind of moments having a strong, positive, outward leadership is exceptionally important. So the road ahead is as pretty as these fall colors. It's beautiful, but we have to learn how to navigate the change. Change is important, it's inevitable, it is part of the life, and we better get used to it. So IR has gone through the change, it has transformed, or it's transforming in a clinical specialty, which is a major change. Then the clinical practice, as you all know, that it started with this very small number of 30 plus people here, and similarly in the United States, again, it was a small group of people that started the society. Then you have to be concerned about what the education and the board certification of our future generation is going to look like. Again, you need the strong, good, positive leadership. Even more important is, or equally important is, how do we conduct the research? In order to compete with other specialty, we do need some strong, good, randomized clinical trials, research, basic research coming from surgery. I also know that all these research is such an important, integral part of. You have to prove yourself, basically, that you actually are better, your outcomes are better, your complications are less. We already heard quite a bit about the awareness and networking, and clearly there's a shortage of awareness. And I think even above that is resources. We have to definitely produce more and more interventional radiologists. Dr. Kalwa was telling me about we produce 100 IR fellows a year here. India being such a big country with a population, you will need a lot more. And again, you need a strong leadership to get those resources, manage these turf battles, And then again, during the difficult times, you have to celebrate every small win. I recently found some of these articles here. One of the articles that was published in Current Problems in Diagnostic Radiology, and here Dr. Christina Kovisko and her group from Cornell, they analyzed 24 articles, revealed that the exposure to interventional radiology in medical schools is lacking, with limited pool of diverse mentors in the field. Moreover, medical school advising student applying to interventional radiology may be inadequate. So get out there, talk to your medical students. They're definitely interested, and shortly I'll tell you a story. Then another thing we heard earlier, that there were very few women IR in the audience. It's been published. And here, Julie Kim published the gender gap in interventional radiology, barriers and opportunity, and role of integrated IR residency. And their conclusion was the women continue to be underrepresented in IR through this gender gap, although this gender gap is improving. And integrated IR residency appear to have majorly contributed to this improvement, and consistently supplying more women in the IR pipeline. But I think there's still a lot more to be. There's a lot more to be done in the women leadership to encourage more women IR. And talking about the awareness, this article that was published in JVIR in 2023 with 1,000 participants, and when they were presented with the idea of whether they'll go through the minimally invasive procedure or surgery, 92% of them preferred undergoing minimally invasive procedure over surgery. Just they were not aware. So lack of the awareness of IR may underutilization. And all of you are great mentors. So if you talk to your medical students, my story is when I was at Cleveland Clinic, I was in charge of the medical student program. And we used to take one medical student per month. After about few months, Associate Dean of Education calls me and say, you have a very long list, you need to increase the number. We increased it to 2. Then after another 6 months, he calls me again that you have 2 is not enough. Now he could see that I will cave in and will increase the number. So he said, you have to increase more. So that we decided to increase 2 more to 2-week program. And so that's how you can build this awareness within your medical society. As many of you can see, that if you talk to your family, everybody in your family would know who general surgeon is, and who internal medicine doc is. But many people would not know, including my own family, what interventional radiology is. So we definitely need to increase the awareness. Now, talking about the leadership and the positive leadership, now there is at places, there's some family feud brewing. IR versus DR, definitely it's in United States. And that comes from obviously, feud is dissatisfaction, and many times money is the part of it. So again, we have to have strong positive leadership, not only just to discuss and have its emergence as an independent specialty from the diagnostic radiology, as well as leadership with the other specialties, so that we can provide an outward-facing leadership to the other specialties. And I happen to have some very strong leaders here, and Dr. Pereira is here, and as well as Rob Luxstein. So these are the society, again, we can talk to, and ISVIR here for the leadership and for moving forward in the difficult time. Change requires leadership, diplomacy, confrontation is never helpful, and the positive energy networks. And this is the residency and fellowship program. I saw happy smiling faces. I thought I'll share with you. This is from the SIR website. And this is what it should feel like when you're entering. But there are a lot of people who would like to come and join this IR community at every place, I guarantee it. And here is another quote I found. It's not the strongest of the species that survives. We all know Charles Darwin, we read about him. Nor the most intelligent that survive. It's the one that is most adaptable to change. And we sit right in the middle of it. Who would be more flexible and adaptable than interventional radiologists? So I have zero doubt about our survival. So future of IR as a specialty in the United States, and here also the new IR-DR pathway has resulted in enhanced exposure to interventional radiology and improved dedicated time to IR training. What we need is the new data-driven clinical and experimental expansion of the scientific evidence. We are seeing the initial phase of paradigm shift from describing what can be technically done to objectively proving how image-guided interventions can improve patient outcomes. And again, at the core of it is the multidisciplinary care until AI comes and takes over. That would be a different story. I seriously doubt that's happening in our lifetime. A more prominent role in the leadership, administrative, and policy setting positions on local, national, and international levels is another important, very important aspect, especially at the local level, at the hospital level, getting the adequate administrative support. Well-designed and meticulous carried out peer-reviewed research and randomized clinical trial and comparative effective research in IR are essential. And again, we have to establish a high level of evidence. And again, I'm a firm believer in multidisciplinary meetings and multidisciplinary tumor board. And this is one of the multidisciplinary meeting where we all general hepatobiliary surgeons and endoscopists and interventional radiologists, this is the meeting we started in 2014. Then again, continuing on the same theme of multidisciplinary, we also started this journal, quarterly journal, Digestive Disease Interventional, which is truly, it's again, the editorial board consists of endoscopists and interventional radiologists and hepatobiliary surgeons, radiation oncologists, and last two issues were actually created by Dr. Kalva and Dr. Amar here. Again, we can definitely reach out to our partners and colleagues in Society of Interventional Radiology or CIRSE, and for all the different kind of leadership advice and help. I'm almost towards the end of my talk, and this is my rock star brother. He's my elder brother, and he's my guiding light. He's also a physician and practices here in India. He goes one day to our little town just to see the patients for free without any charge till date, and he's partially retired. That's my sister-in-law. She's also a doctor, and my son right next to her. And this is my beautiful wife, Simran, my son. He graduated from high school. Now he is in college at Michigan. And at the end of the day, we are all IRs, and we all should be very proud of ourselves. Our future is very bright. In the end, I really would like to leave you with this thought, and this is from Mahatma Gandhi. It really hits in the core. All of us have done it at some way or the other, but I've never seen it said so well. Keep your thoughts positive, because your thoughts become your words. Keep your words positive, because your words become your behavior. Keep your behavior positive, because your behavior becomes your habit. Keep your habits positive, because your habits become your value. Keep your values positive, because your values become your destiny. So at that note, I would conclude, and thank you so much. It truly is an amazing honor to be here in front of you all and learn about it. Thank you.
We would like to honor you. So give him a nice big round of applause, a standing ovation. What an incredible journey indeed. Dr. Kapoor, can you please take center stage as we honor you? The President and Secretary of ISVIR to do the honors. 1, 2, 3, hit it! You know, you came to Mamallapuram in the 80s. You came back as a leader in your profession. I'm sure when you come back, you're going to achieve so much more. Wishing you the best, Dr. Kapoor. Thank you so much. Many congratulations. Thank you for sharing the incredible journey with us. Thank you so much. Thank you. And you have Simran, that's the story of DDLJ. Thank you so very much. On that note, ladies and gentlemen, we come to an end of day 1 at ISVIR 2026. There's happy hours, the bar is open, but for a limited time only. Make the most of it. Have lots of fun, and give a nice big round of applause to the people at the console who've been at it since morning. Yes? Thank you. And it's going to be DJ Sen who's going to be entertaining you this evening. There's a wonderful DJ night that awaits you. We will see you sharp at 9 in the morning to innovate, collaborate, and transform. This is Sano signing off. Thank you so much. It's been incredible.